हम दोनों की मजाक है, तू बीच में मत पंगे ले, तो रात मजाक में मत करना गलती से।
नहीं मैंने इसको 10 बार बोल दिया भाई तू बीच में मत बोला कर।
ओए यो तार पास रख ले।
जा लिया जा
कहीं
कोया जोड़ो थोड़ा ला कोना तो
नौ पीछे
पैसा की तार नहीं करनी चाहिए
कोना आठ उसके
कोना तो सर को ले जा 500 को नोट जा
ये लाइव कर दिया ने भाई।
हां ये चल रहा है मेरे लोगों
नहीं नहीं लोगों तो चल रहा है, ये अपने को ड्रॉप रेट देनी है, दूसरे अभी ध्यान नहीं, यहाँ पे कुछ ड्रॉप तो नहीं है। देखो ये वाला ड्रॉप फ्रेम होना है, एक बार मुझे बता देना। अगर ये ड्रॉप होना फ्रेम
कैसे ड्रॉप कैसे मुझे बता।
ये आ रहा है ना 0 0, तो ये होता है मतलब कि आपका नेट अगर धीरे चलता है ना, खराब होता है, तो आधी चीज़ें
नहीं हो पाएगा यार। वो हॉस्पिटल, वो लोग, वो ओटी, वो सब मुझे उस रात की याद दिलाते हैं।
Hey, sir. Hey, wa, sir. Hey, 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 wa, hey, sir. Hey, hey, wa, hey, hey, wa, hey, sir. Hey, wa, sir. Hey, wa, sir. Hey, hey, wa, sir. Wa, hey, 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 wa, sir. Sir, wa, hey. Sir. Hey, wa, sir. Sir. Hey. Hey, wa, sir. Sir. Hey, wa, sir. Hey, wa, sir. Hey, hey, wa, sir. Hey, wa, sir. Hey, wa, sir. Wa, hey, 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 hey. Hey, sir. Hey, 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 wa, sir. Sir. Hey, ch, 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 hey, 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 ch, 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 ch.
नहीं हो पाएगा यार। वो हॉस्पिटल, वो लोग, वो ओटी, वो सब मुझे उस रात की याद दिलाते हैं। वो ओटी, वो सब मुझे उस रात की याद दिलाते हैं। नहीं हो पाएगा यार। वो हॉस्पिटल, वो लोग, वो ओटी, वो सब मुझे उस रात की याद दिलाते हैं। नहीं हो पाएगा यार। वो हॉस्पिटल, वो लोग, वो ओटी, वो सब मुझे उस रात की याद दिलाते हैं।
अरे चालू, हाँ हेलो। आप सभी लोगों से रिक्वेस्ट है, प्लीज जो भी रजिस्ट्रेशन काउंटर पर खड़े हैं, कृपया आगे आ जाए ताकि हम सेशन शुरुआत कर सके और रजिस्ट्रेशन हम बाद में भी करा सकते हैं, प्लीज। सो ऑल आर रिक्वेस्टेड काइंडली प्लीज कम ऑन द सीट्स। और मैं रिक्वेस्ट करूंगा डॉक्टर राजशेखर से, डॉक्टर राजशेखर प्लीज आए और कार्यक्रम की शुरुआत करवाएं। जो डॉक्टर राजशेखर चेयरपर्सन को बुला रहे, जो बैठे कौन कौन है? मॉडरेटर डॉक्टर अशोक गर्ग, द लीडिंग फिजिशियन एंड कार्डियोलॉजिस्ट, प्लीज कम अपॉन द डायस।
गुड मॉर्निंग ऑल। सिंहासन हिल उठे, राजवंशों ने भ्रकुटी तानी थी, बूढ़े भारत में फिर से आई नई जवानी थी। सुभद्रा कुमारी चौहान जी के इस कविता के एक एक शब्द हमें याद दिलाता है हमारे आरटीएच मूवमेंट की, जिस मूवमेंट को देखकर तथाकथित राजवंशों की कैसे भ्रकुटियां तन गई थी और कैसे उन तथाकथित राजवंशों के सिंहासनों को हमने हिला दिया था हमारी डॉक्टर यूनिटी ने। और हमें यदि हल्के में लिया गया तो आगे भी हम सिंहासन हिलाने की क्षमता रखते हैं। सुप्रभात, सुस्वागतम, रेस्पेक्टेड सीनियर्स एंड माय डियर फ्रेंड्स, आप सबका मैं डॉक्टर अशोक गर्ग इस अनूठे कार्यक्रम मेडिको लीगल समिट 2024 के पावन अवसर पर, एक अनूठे कार्यक्रम के अवसर पर आप सभी का MLAG मेडिको लीगल एक्शन ग्रुप एंड उपचार के बिहाफ पे आपका बहुत बहुत स्वागत करता हूं, अभिनंदन करता हूं। और मैं आशा करता हूं कि हम सब लोग इस कार्यक्रम में एक्टिवली पार्टिसिपेट करेंगे और कुछ ना कुछ नया अवश्य सीख के जाएंगे। कार्यक्रम की शुरुआत हमारे फर्स्ट सेशन से होगी, जिसका नाम होगा प्रिवेंटिंग मेडिको लीगल इश्यूज इन क्लिनिकल प्रैक्टिस। और इस कार्यक्रम के लिए मॉडरेटर हैं डॉक्टर रितु शर्मा मैडम।
The responsibilities. In our case, it may be an injury caused by or during the treatment by the treating doctor. It might be due to the actual negligence, and many times it is a perceived negligence that patient thinks he has not been attended well. Medical profession has its ethics, parameters and code of conducts, but as I told during this journey, many times we forget to abide with it, we violate or ignore it. Professional duty, which owns the duty to the patient. There is a duty, a contract. There was a breach in duty which caused damages, and damages were significant. This can be classified as criminal negligence or civil negligence according to the extent, and as you know, it can be tackled on many forums as consumer forums, various courts, or the medical council rules. Medicine is not an exact science. It is growing daily, changing daily with lots of modalities coming in. They say you learn by your mistakes, but here, today, when you practice medicine, it is not true. You don't have any time to learn by your mistakes. Directly, you are into the court. Basically, the contributory permutations and combinations of corporatization of the profession, demanding patients who have paid, they think it is their right to get the exact services, the services of the Western world in a developing country, and a bit ignorance on our part in the medical code of conduct leads to the medical negligence cases. And these cases are settled in the courts by the honorable judges who are actually not the medical experts. They rely on the reasonableness by the Boehm's law or the prudence. There is a thin dividing line between the gross negligence, ordinary negligence, and the slight neglect. But this line might blur many times level of negligence which will be decided, will be settled in court on the basis of place, time, individual involved. As we can see in many court cases, like if you see 10 cases of sterilization or the ligation failure, every time court given a different verdict which might differ. Sometimes it is up to the, like you have to pay compensation up to the child attains 18 years of age, or sometimes some lump sum amount has been rewarded, and in many times it has been not considered as negligence. So the total verdict depends on many things which are dynamic. What is the amount? What is the quantum of medical negligence for which we are addressing this issue today? Basically, according to the reports, there are 5.2 million cases of medical negligence at a time in India, with 110% annual jump annually. There is 400% surge in the medical litigations, although by a committee constituted by a government of Haryana, only 17% cases in 3 years were found true. In most cases, there is no neglect on the part of skill or knowledge. Doctors were competent, but lack of communication and coordination among them led to the mismanagement sums. The sums which me or you, we cannot earn in this lifetime, as decided in the case of Kunal Saha versus Emory Hospital, the sum including the interest of the compensation was around 11 crores, which sounds unrealistic. These are few landmark cases in the history of medical negligence. Indian Medical Association versus VP Shanta, which brought this profession into the gambit of Consumer Act. Poonam Verma versus Ashwini Patel, which forbade the other practitioners like homeopathy and Ayurvedic practitioners to practice the allopathic medicines. Paschim Banga Khet Mazdoor Samiti versus State, which asked government hospitals not to refuse any case. Parmanand Katara case, where the RTA, road traffic accident cases, or the life-saving cases should be taken without reporting the police. First, you have to stabilize the patient, then you can go for the police formalities. Dr. Kunal Saha case, which was the biggest ever compensation in the Indian medical history. Sameera Kohli case, where the importance of informed consent was highlighted again by the Honorable Court, although doctors were not found negligent. And the Bombay Hospital versus Asha Jaiswal case, or we know the Dr. Jacob Matthews case, in which doctors were freed of the, not found guilty of any negligence on their part. Few of the clinicians here might be having their own hospitals. So as hospital owner, they have certain different responsibilities in terms of laws of land. There are more than 90 laws, regulations, certificates which govern the establishing, commissioning and running of the hospitals. Laws are there according to the building rules, according to the environment. You have to abide with legal things, employment and management of power rules, management of patients, laws governing safety of patient, medico-legal aspect, laws governing the business aspect, few licenses as PCP and DT, organ transplantation, few certifications, biomedical waste is a big thing today, and few periodic reports like maybe the epidemic diseases kind of reports they ask you every time. So before, if you are a owner of the hospital, then you should look into these things beforehand. So now we will come to the actual thing. I will start with informed consent. Most of us know that we have to take informed consent, but we forget to practice this. Informed consent means the thing should be explained in the layman terms to the patient about his medical condition, the available treatments, like the treatment we might not be having, but you should at least tell him that this can also be done. The proposed line of treatment, what are the risks in this procedure, available alternatives. You should encourage questioning and answering. Satisfy him. Communication is a very good skill. It treats half of the disease. And document the informed consent along the, in all filled consent form, like you have to take anesthesia consent and surgery consent in two different documents. and preferably not pre-printed. If it is pre-printed, you can write a note, a gist or the summary in the patient's handwriting and he can sign there. Failure to obtain the valid informed consent can lead to legal repercussions, including charges of negligence or maybe battery. One more thing, if patient refuses for the procedure, you should always document this refusal. That will be a saver in the court of law. As we know, the Kunal Saha case for only the highest compensation. But to start with, Kunal Saha made Breach Candy Hospital a party too. But during the preliminary investigation, basically, Breach Candy has documented everywhere that patient attendant is interfering. They are refusing for this treatment. They are asking for this treatment. By consulting overseas physicians, which were their friends, Breach Candy has documented each and everything with doctor's sign. So in the very initial inquiries, Breach Candy was not found negligent, but Emory did this practice, so they were in soup. I was the member secretary for this inquiry. You have not documented means you have not done. Like even the doctor sitting in the inquiry committee cannot support the fellow doctors without any documentary proof. Documentation should be comprehensive, complete, timely, accurate, and available when asked for. It should be in detail, chronological. All forms like consent forms, admission form, nursing notes, anything, they should be in the chronological order. All examination finding, treatment plans, and all orders should be, and the written consents, and all signed with the date, time, and signature of the authorized person should be there. Clear and legible documentation enhances the communication between the healthcare providers too. कि आपने ये order किया और सामने वाले ने उसको कैसे comply किया. It ensures transparency. Record retention should be done according to the government policy, that is 3 years in OPD and 5 years in IPD, 10 years in the medical legal cases or till the case is disposed. Record keeper, before depositing the file, should look for all the compliances, they are done or not. If deficient, they should address it then and there. Extra attention, as a private practitioner, you should pay extra attention to the death cases, complicated cases, troublesome attendants especially, and the cases having fat bills, because they will go definitely into litigation. Adhere to the standards of care, don't be a hero. Whatever is the standard treatment guideline, just adhere to that. If you want to deviate from it, do it with reasons after asking or consulting with the colleagues of your confidence. Minimize the risk of medication errors. WHO says that medication errors are the 10th biggest killer in the world. The use of unique health identity, 7 rights of medication, right patient, right document, right route, right dose, look-alike, sound-alike drugs should be kept separately. Keep away the expired, near-expired drugs, narcotic drugs, and the high-risk medication. Diligent prescribing policies should be there. Patient education should be there regarding the doses, adverse effects. Surgical safety checklist should be used in every single case. Patient part procedure. Be sure of them, and before closing, please count your swabs and instruments. Ready drug dose reference in cases of high-risk drugs, route, rate of high-risk medication, and the person authorized given for this should be there, as there is a case against Bombay Hospital where injection Larago was injected stat for a child and the child died of cardiac arrest. In that case, the doctor was found negligent for not prescribing the drug in the right prescription. Continuous education and training might help to keep you abreast of the latest practices in medicine and the medical legal too. Interdisciplinary collaborations are good. You can attend CMEs, workshops. One more thing, all hospitals should have an internal death audit, cesarean audit, and discussions in the institute. This might be providing you insight for the future. Like audit should not be a blame fixing exercise. take them as system improvement exercise. Branding and accreditation. I know that is like a controversial, that might sound controversial, as in a developing country like ours, certification just become like license Raj. They don't work in the true spirits. But believe me, accreditations help you because they make your all papers accredited agencies. I have told you many things, but in case nothing works, then go for asset protection and indemnity. If like you can go for personal or the group, and if you are a hospital owner, you can go for like errors and omission policy also. You should protect your assets because litigations can cause, like they can already, your already earned assets can be at stake. So it's vital for the survivals, as these days the compensations awarded by the courts are unrealistic. A very special caution should be there in these cases, as like teenage pregnancy, rape cases, high-risk pregnancy, retrovirus positive, drug in pregnancy, lactation, IVF, donor insemination, egg donation, surrogacy, physical damage of any type during birth, embryonic stem cell research, genetic research, especially clinical trials, because many of you might be enrolled in the clinical trials. And lastly, we are hearing the noise, so you should be very particular when you are doing organ transplants. These are the cases where your files, consents, everything should be in line and appropriate with the law. So comply with the laws of land, whatever they are in the building or in the practice. Stick to the medical code of ethics and conduct. It has been taught to us in the medical college in the very initial days, but we need to revise it further. Practice standard treatment protocols, as I told you. Don't try to be a hero. And primum non nocere, that is, if you cannot do anything, please don't harm. Like, wait and watch, symptomatic, that will do. Any questions?
Very good, informative presentation, Dr. Nivedita. My question is, if the patient is minor, suppose newborn, I am a pediatric surgeon, so if the patient is minor, and if the parents are not available, suppose cesarean delivery is there and my husband and wife is not there, can we take the consent from the their uncle or grandparents?
Immediate relative.
Yeah, immediately. Is it valid?
It is valid in the court of law, but to be secure, you can do it beforehand, that who will be giving the consent in case parent is not available. Because the mother might be visiting, or in fact, if it is a non-booked patient, then it is valid if it is like immediate relative, but it's better, like I told you in the Samira Kohli case, she was an adult. She was an OT for a diagnostic lab, and she needed hysterectomy. Her mother sitting outside gave informed consent for the hysterectomy. So the court, he freed, the judgment was that doctor was not found negligent, but they highlighted the need of informed consent to the patient beforehand. You can, beforehand you can tell them that it might be needed, then who will be giving consent, or your consent is necessary, you can ask them.
Actually, I am talking about emergency. In plant
emergency,
case,
you can take immediate relative.
I am not talking about the plant case.
Yeah,
we can postpone it.
Immediate relative is authorized if the mother is not available.
Okay, thank you.
And many times, like mother is in the cesarean postpartum period, father is not there, masis, chachas, they bring to the clinicians, they bring a child to the clinician. So, with whom, unless told otherwise, he is competent to give consent.
Thank you, Dr. Nivedita, for a nice talk. And you spoke very good about the preventive aspects to be taken by doctors as such. And pertaining to the topic, 2-3 points I will just like to highlight.
Yes, sir.
Because preventive part is not on part of doctors. Prevention starts right. There are 3 heads which we can divide on. One is the administrators, that is the government and the administrators. Second is the doctors and the medical fraternity. And third is the public at large.
Yeah.
These 3 have a major role in preventing future medical legal competition. Now, how and why we can go for it? For doctors, I think 3 major changes are required. One is Dr. Bhandari is already there. So I will like that students should have a course of medical legal part, not a small part. It should be examined and properly, thoroughly tested, that students know what are the preventive aspects of medical legal part.
Yes.
That will prevent for future cases. Second is for the consultants and the owners. You have already highlighted. One major part is the nursing staff. If you want to prevent medical legal cases for future, the nurses should be well taught the preventive aspects. And second, their notes should be there in every session, especially the critical care. I remember in many parts of the world, they just don't examine the notes of the doctors. Rather, they will examine the nursing staff notes. That when was the doctor called upon, what was his response, how and why the patient and their attendants were compliant or not compliant. So I think that is an important arena. Third is record keeping. You have highlighted well, but what I also follow is, if any critical case is there, keep the record of the patient in a very secure area. Because if somebody
Secure and complete.
And so preventive aspects we should, and third is public awareness. All of us should see to a point that public is made aware of our rights too. Where we are lacking nowadays is that we are going down. We are not telling them the rights, that we have the right to refuse when we are not there. What are the rights? So I think prevention starts right there. We should make public aware too. Thanks a lot.
Thank you. Thank you, Dr. Nivedita and chairpersons. House is open for discussion. Hello, I am Dr. Gitika Jain. Ma'am, I would like to add one point in Dr. Vinay's question.
Yeah.
So, ma'am, if the parents are not there, like he said, it is a cesarean delivery. So the parents might be busy with the lady is already operated and the husband might be busy. So in that case, what Court of Law says is that you can take a telephonically consent from the parents. It can be a video call, and then you can record it, and that is going to stand in the Court of Law. Thank you.
Then when they are saying not available, then I am assuming that they are not available by any means. Yeah. Yeah, if they are there, you can ask them. But otherwise, like usually the close relatives are there, and in emergency we are doing like maybe intubation.
See,
yeah.
I would like to add something.
Yes.
Consent is not just a signature, right, or information. What on a telephone you are giving or on a video you are giving is just a information, right? Consent is the entire thing, which you have to explain to the person. Now, if child is minor, child is always minor, right, less than 18 years of age. So in that case, who is guardian? That was the question. Guardian, definition of guardian is in whose possession or whose custody the child is at that point in time.
Exactly.
Even principal of the school is a guardian if he brings the child.
Yes.
So whosoever
On
brings,
the picnics
you can
it
do.
happens.
If there is nobody, you can inform police. State is always guardian of every citizen of India. State is a guardian also, and state is child also. If somebody dies intestate, the property goes to the state. So state is our parent also. So you can inform state. And who is state? For us, it is either magistrate or police. You can inform them and you can go ahead with that. Or if you are working in an institute, the head of the institute, the superintendent or the dean of the college,
In
you
fact,
can
court
inform
will
them
court
and you
will
can
consider
operate.
in good faith too.
But if there is emergency, there is no need for consent. You can go ahead and do it. That is also not a problem. But that should be an emergency immediately to save life of a person. It is not emergency you want to attend this conference and you are in emergency. Patient should be in emergency.
Yeah.
That's it.
I didn't say that last thing very, I didn't highlight that, because what we do is we just take that message. We don't explore the possibilities, initial possibilities. Most of the clinician, what they do, they go to this ultimate measure, that we are this. But actually, we are that, court will take that, but initially try to look for the immediate guardian with whom the patient has come.
Dr. Nivedita, one more question.
Ji.
Dr. Nivedita,
Haan ji.
see,
Haan ji.
one more question.
Haan,
Is it good to take written consent with his own writing, his or her own
As
writing.
I said, if you have a pre-printed form, the gist of the consent, like क्या procedure है, क्या anesthesia देंगे, ये आप उसका handwriting में लिखवाएं. Pre-printed are like they are disputable in the court of law. So the gist, 4-line gist can be there at the last.
नहीं, कई बार ऐसा होता है जैसे पेशेंट को से अपन कंसेंट लेते हैं और पेशेंट जो है वो इतना लिटरेट नहीं होता है कि वो लिखता है, तो आप जैसे रेजिडेंट होते हैं हमारे, वो रेजिडेंट लिख करके और उसमें साइन कराते हैं.
लेकिन
इज इट ओके?
विनय, जो मेरी ऑब्जर्वेशन है, एज आई टोल्ड यू, आई एम लाइक क्वालिटी एडवाइजर टू 4 states.
Dr. Nivedita, I'll have to intervene due to paucity of time. We can continue this discussion over tea or lunch.
Yeah,
But
so
sure.
sorry, but
One right
Just
message,
one
handwriting is not required. If somebody signs somewhere, whatever is written above will automatically become accepted to him.
Basically, what your residents do, they just get a sign on a blank
That is not
paragraph.
allowed. That is
So that's
forgery.
not allowed.
I would request the chairpersons now to please honor our speaker, Dr. Nivedita. Dr. Tarun, Dr. Vinay, and Dr. Vivek. Dr. Nivedita. तालियां बजती रहनी चाहिए, उन्होंने बहुत मेहनत करते हैं स्पीकर्स. And thank you our dear chairpersons for being here. To do the honors, I would request Dr. Sunil Gora and Dr. Prem Kumawat. Dr. Sunil Gora and Dr. Prem Kumawat, to do the honors, please come onto the dais and honor the chairpersons. Thank you. Dr. Sunil and Dr. Prem to honor the chairpersons. Thank you, Dr. Ashok and Dr. Meenakshi.
Thank you, moderator, chairpersons, and speaker for the wonderful session. Now it's time for very important part of the ceremony, that is the inaugural session. For inaugural session, I would like to invite Dr. Meenakshi Jangid. She is running his hospital at Navalgarh. She is from base 1992 from SNMC Jodhpur, and she is also the Zonal Secretary of Sikar Upchar year 2023 to 2025. और मैडम के जोशीले भाषण जिन्होंने आरटीएस मूवमेंट में जान भर दी थी वो हमने सुने हैं अच्छी तरह से. And second to moderate to conduct the inaugural session, Dr. Dinesh Shahabos, the president of Jaipur Upchar and renowned colorectal surgeon of India, running his own hospital by the name of Piles Hospital at Vidyadhanagar. और दिनेश शाह बॉस के बारे में मैं जितना जानता हूँ छोटी सी बात बताऊंगा. ये बॉस अपनी उम्र के लोगों से दोस्ती नहीं करते, हमेशा छोटी उम्र के लोगों से दोस्ती करते हैं और वही इनकी जवानी का राज है. तो वेलकम दिनेश शाह बॉस एंड मीनाक्षी मैडम.
थैंक यू डॉक्टर अशोक. गौरवशाली महान इतिहास की ये मेरी राजस्थान की धरा सांस्कृतिक धरोहर को अपने भूगर्भ में समाये हुए और उसमें ये अनुपम गुलाबी नगरी गुलाबी आभा लिए हुए आज इस प्रतिष्ठा बैंक्वेट में संपूर्ण देश से अपने अपने विषयों में पारंगत और अनुभवी चिकित्सकों का इस मेडिको लीगल समिट में बहुत बहुत स्वागत करती है, अभिनंदन करती है। जोरदार तालियां बजाइए। उपचार और मेडिको लीगल एक्शन ग्रुप के संयुक्त तत्वाधान में होने वाली इस मेडिको लीगल समिट में हमारे अतिथिगण अपनी गरिमामयी उपस्थिति ला चुके हैं। मैं आमंत्रित करना चाहूंगी मंच पर माननीय डॉक्टर सुधीर भंडारी, जिनकी उपलब्धियां ही इनकी पहचान है। जोरदार तालियां। ये निवर्तमान एसएमएस के प्रिंसिपल और कंट्रोलर रहे हैं और वर्तमान में विश्व प्रख्यात RUHS यूनिवर्सिटी को कुलपति के रूप में, या यूं कहिए कि कुलपति पद को शोभायमान कर रहे हैं। जोरदार तालियां बजाइए। इसी के साथ डॉक्टर योगेंद्र मलिक भगत फूल सिंह यूनिवर्सिटी, या यूं कहिए भगत फूल सिंह मेडिकल कॉलेज ऑफ वुमेन, सब आजादी के बाद सबसे पहला मेडिकल कॉलेज जो हमारे देश में था, उसके फॉरेंसिक डिपार्टमेंट के और टॉक्सिकोलॉजी के प्रोफेसर हैं और वर्तमान में ये फुल टाइम मेंबर ऑफ EMRB एंड NMC हैं। जोरदार तालियों से ऐसी गरिमामयी जो हमें आज आशीर्वाद मिला है कि ऐसी विभूतियां हमारे मंच को सुशोभित कर रही हैं, मैं इनको आमंत्रित कर रही हूं। अब जिनके सहयोग के बिना आज की ये समिट नहीं हो सकती थी, जी हां, डॉक्टर नीरज नागपाल, सीनियर गैस्ट्रोएंट्रोलॉजिस्ट एंड एक्स प्रेसिडेंट ऑफ IMA चंडीगढ़ और प्रेजेंट में ये MALG कन्वीनर हैं और इन्हीं की सहमति से और उपचार के संयुक्त तत्वाधान में उन कानूनी पेचीदगियों से हम सब चिकित्सकों को बचाने के लिए आज इस समिट का आयोजन हुआ है। अभिनंदन, मान सम्मान। कहते हैं ना, जब तक मंच सुशोभित नहीं हो तब तक मन नहीं भरता, क्योंकि ये हमारे अतिथि आज हमारे नयनों को बहुत प्रिय हैं। इसी के साथ मैं मंच पर आमंत्रित कर रही हूं डॉक्टर राजशेखर यादव, जो कन्वीनर है उपचार के, या यूं कहिए कि इनकी दिन रात कड़ी मेहनत, इनकी लगन और जन्म ही उपचार का इनकी एक सोच से हुआ है। ऐसी महान विभूति जिनकी सौम्य मुस्कान हम सबको चौकन्ना बनाए रखती है कि उपचार हमारा परिवार है, ऐसी महान विभूति को मैं नमन करती हूं। और इसी के साथ डॉक्टर कमलचंद सैनी को मैं आमंत्रित करती हूं, जो उपचार SEC के अध्यक्ष हैं। डॉक्टर कमलचंद सैनी एक कर्मठ कार्यकर्ता हैं, वो कृपया मंच को सुशोभित करिए। सभी अतिथिगण हमारे हृदय को बहुत प्रिय हैं। कहते हैं मुस्कान में छिपे दर्द को किसने देखा, मौन में छिपे तूफान को किसने देखा, अमृत पाने को तो सबको ही आतुर, गरल पान की जलन को किसने देखा, दिन की धूप रात की नींद, अपने बच्चों का प्यार, बच्चों का बचपन, मान सम्मान सब खोकर पीड़ित मानवता की सेवा करता हूं, क्योंकि मैं चिकित्सक हूं। मैंने सेवा धर्म निभाने की शपथ खाई है। मेरी संवेदनाएं मरीज से जुड़ी हैं, मरीज के परिजनों से जुड़ी हैं, पीड़ित मानवता से जुड़ी हैं। पर इस समाज को मैं सब कुछ देता हूं, लेकिन मेरी संवेदनाओं की रक्षा कौन करेगा? इस समाज से क्या मेरी कुछ अपेक्षाएं नहीं है? व्यावसायिकता के दौर ने जब मेरी इस संवेदनशीलता को तार तार करने की कोशिश की, मेरे मान सम्मान स्वाभिमान पर चोट पहुंचाने की कोशिश की, तो बुद्धिजीविता के आंगन में एक फूल खिला जो दूरदर्शी सोच थी, उसने आप सबने सींचा। आप सबका ये परिवार है उपचार। चिकित्सक एवं समाज की मृतप्राय संवेदनाओं की संजीवनी है उपचार, जो आप सभी के ज्ञान चक्षु खोलेगी और आपको उन कानूनी पेचीदगियों और दांव पेचों से बचाएगी जो व्यावसायिकता के ऐसे घिनौनी हरकतें चिकित्सकों पर की जाती हैं और उस पेशे पर मान सम्मान पर चोट पहुंचाने की कोशिश की जाती है। हमारा मूल ध्येय एक ही है, पीड़ित मानवता की सेवा, ताकि हम बिना किसी मानसिक दबाव के काम कर सकें और इस समाज को आगे आने वाली पीढ़ी को बहुत कुछ दे सकें। अतिथिगण हमारे बीच में पधार चुके हैं। मैं एक बार पुनः उपचार और मेडिको लीगल एक्शन ग्रुप के संयुक्त तत्वाधान में होने वाली इस मेडिको लीगल समिट में आप सभी का स्वागत करती हूं। कहते हैं ना, बिना ईश्वर के आशीर्वाद के और बिना पावन लो के कोई भी शुभ कार्य फलीभूत नहीं होता। इसलिए मैं दीप प्रज्वलन के लिए माननीय डॉक्टर सुधीर भंडारी जी को आमंत्रित करती हूं। साथ ही हमारे अन्य जो डायस पर बैठे हुए अतिथिगण हैं, डॉक्टर नीरज नागपाल, डॉक्टर राजशेखर यादव, डॉक्टर बत्रा सर उपचार संवाद और उपचार संवेदना जिन्होंने संभाली हुई है, डॉक्टर कांतेश खेतानी, डॉक्टर अशोक गर्ग, डॉक्टर दिनेश शाह और कृपया डॉक्टर रामदेव चौधरी, यूं कहिए कि आरटीएच आंदोलन के भीम थे, डॉक्टर सुनील गोरा, आप सभी को मैं, उपचार आपका परिवार है, ये दीप ये प्रज्वलित हो रहा है जो उपचार के लिए हो रहा है, ये अज्ञान अविद्या नाशक है दीप, शुचि ज्ञान प्रभाव प्रकाशक है दीप, नैतिकता का निर्माण अपनी लो में लिए है, जग जीवन का कल्याण करे, तिमिर का नाश करे, घर घर ज्ञान का प्रकाश भरे, सहकर नित जलने की पीड़ा जग में ये उजियारा लाता है, इसीलिए तो विश्व हमें हमेशा देवालय में दीप जलाता है, देवालय में दीप जलाता है। इसीलिए तो हरिवंश राय बच्चन ने कहा है, अंधेरी रात है पर दिया जलाना कहाँ मना है। शुभ सत्य स्नेह की ये ज्योत जगे, सत सेवा का सन्मार्ग लिए, दीन दुखियों के कष्ट हरे, जन जीवन में सद्भाव भरे, मंद मंद पुलकित ये ज्योत जले हर जीवन में आनंद भरे। माँ सरस्वती ज्ञान की अलख ज्योत, बुद्धि दाता स्वयं की देवी, ज्ञान का वरदान वीणा वादिनी, माँ धवल धात्री हंसासिनी के वरद हस्ते तू, हम सभी आज नतमस्तक हैं। इसकी ज्योत का आह्वान जो इस समिट में आने वाले अज्ञानता अंधकार को मिटाकर ज्ञान चक्षु खोले और अपने मान सम्मान स्वाभिमान के साथ अपने सेवा पथ पर पड़ते हुए बेहतर मानव कल्याण समाज कल्याण कर पीड़ित मानवता की सेवा का हम धर्म निभाएं। दीप प्रज्वलन कहते हैं ना, दिशा दिशा दीप्त हो उठी, पाकर पुण्य प्रकाश तुम्हारा, लिखा जा चुका है अनल अक्षरों में, अतिथि स्वागत सत्कार तुम्हारा, जहां जहां पड़े चरण कमल, माटी बनी है चंदन, हो रहा चहूं उजियारा। और अब बारी आती है अतिथि सत्कार की। अतिथि सत्कार, अतिथियों का जब तक सत्कार नहीं हो मन नहीं भरता। मैं माननीय डॉक्टर सुधीर भंडारी के अतिथि सत्कार के लिए आमंत्रित करती हूँ डॉक्टर राजशेखर यादव को वे शॉल और मोमेंटो देकर कृपया उनका मान सम्मान बढ़ाएं। उन्होंने आज अपने इस गरिमामयी उपस्थिति से हमें नवाजा है, उनका बहुत बहुत मान सम्मान। डॉक्टर नीरज नागपाल, डॉक्टर सुधीर भंडारी एक हस्ती है जिन्होंने पूरे राज्य के स्वास्थ्य को संभाला है, उनकी उपलब्धियां ही उनकी पहचान है, ये तो सिर्फ मान और सम्मान है। माननीय डॉक्टर सुधीर भंडारी के बाद डॉक्टर नीरज नागपाल, डॉक्टर नीरज नागपाल के स्वागत के लिए मैं आमंत्रित करती हूँ डॉक्टर कांतेश खेतानी, एक जोरदार हस्ती जो हमारे उपचार के प्रवक्ता हैं, मीडिया प्रबंधन संभालते हैं और बहुत कम शब्दों में बहुत बड़ी बात कहे जाते हैं। डॉक्टर नीरज नागपाल जो MLAG के कन्वीनर हैं, उनका स्वागत कर रहे हैं। बहुत ही शुभ वेला, शुभ घड़ी, ये मान सम्मान की, ये यूं ही बना रहे, यूं ही बना रहे। डॉक्टर राजशेखर यादव के सम्मान के लिए मैं आमंत्रित करती हूं योगेंद्र मलिक साहब का स्वागत करने के लिए मैं डॉक्टर नवनीत गुप्ता को आमंत्रित करती हूं। डॉक्टर योगेंद्र मलिक हमारे बीच चंडीगढ़ से आए हैं और इनकी कहते हैं ना कि इनकी सामाजिक सरोकार जो इन्होंने बेटी बचाओ बेटी पढ़ाओ अभियान में हरियाणा सरकार के मुख्यमंत्री के सलाहकार होकर बेटियों का वध होने से बचाया। एक जोरदार गिव हिम बिग हैंड। ऐसा अतिथि आज हमारे बीच है। हमारे ही घर में सभी अतिथि हैं और सभी स्वागत सत्कार के पात्र हैं, पर कहते हैं ना विशिष्ट अतिथि जब तक नहीं हो तब तक किसी भी कार्यक्रम का आनंद नहीं आता। जी हाँ, मैं बात कर रही हूँ डॉक्टर सुधीर भंडारी, जोरदार तालियां देंगे, जो RUHS के कुलपति पद को शोभायमान कर रहे हैं। डॉक्टर सुधीर भंडारी मानवीय सेवाओं के साथ सामाजिक कार्य में असाधारण रुचि है जिनकी, और उनकी जो एकेडमिक उत्कृष्टता है, अकादमिक उत्कृष्टता, उसकी उच्चतम उपलब्धियां ही आपकी पहचान है। मैं आमंत्रित करती हूं कि वे आएं और आशीर्वाद अपना दें। वो किसी पहचान उनकी, मैं छोटा मुंह बड़ी बात होगी अगर मैं उनकी एकेडमिक उपलब्धियों को गिनाऊं, और ये महामहिम राज्यपाल मुख्यमंत्रियों तक के चिकित्सक हैं, तो ये हमारे मन की भावनाओं को भी समझेंगे और हमें आशीर्वचन स्वरूप 2 शब्द कहेंगे। माननीय डॉक्टर सुधीर भंडारी।
Respected dignitaries on dais, the organizing team of this noteworthy National Summit on Medical Legal Cases, ladies and gentlemen, and all my fellow colleagues. I feel proud and honored to share my thoughts on this very important and integral discipline of medical science with this renowned, reputed gathering of practitioners, academicians, and professions. Let me start by telling that we belong to the most noble profession. We belong to the profession which acts with conscience and heart. This is the only profession where professional excellence is coupled up with total consciousness, humility, and empathy, which everyone extends to his patient proportional to his level of knowledge. Today, we gather to discuss a matter of utmost importance within the realm of healthcare, the medical negligence and increasing number of medical legal cases, which is taking toll on the quality of the life of we all. It is a topic that strikes at very heart of the noble profession of medicine, challenging the fiduciary relationship between doctors and the patient. In fact, today, the doctor-patient relationship is at the lowest ebb. Probably a lot of unnecessary media trials has contributed to this. The medical profession is considered to be one of the noblest professions in the world. The practice of medicine is capable of rendering noble services to humanity, provided due care most sincerely, efficiently, and professional skill is observed by every possible doctor, take it granted. However, today the patient-doctor relationship has almost diminished its fiduciary character and has become more formal and structured. Doctors are no longer regarded as infallible and beyond question. There was no reason to question a doctor decades before, and they were considered to be infallible because they were very considered as godlike. Common man thinks, again I repeat, common man thinks that corporatization of healthcare has made it like any other business, and medical profession is increasingly becoming and is being guided by profit motive rather than that of service, which is not true. And we need to change the thinking of a common man by what best we are delivering to common man. On the other hand, a well-publicized malpractice case can ruin the doctor's career and practice. The law, like medicine, is an inexact science. One cannot predict with certainty an outcome of cases many a time. It depends on particular facts and circumstances of case and also the personal notions of judge concerned who is hearing the case, and hence it is very important to have strong data to give our point of view. The axiom, you learn from your mistakes, is too little honored in healthcare. So the best way to handle medical legal issue is by preventing them, and hence we need to concentrate how we could prevent it. It is in our pursuit of excellence, it's crucial to discern between medical negligence and error. While errors are inevitable in any human endeavor, negligence implies a breach of duty and warrants legal scrutiny. Unfortunately, accidental errors in our profession, because of the changing scenario, are treated in category of negligence more and more, which is not true most of the time. As guardians of health, doctors bear the weighty responsibility of upholding a standard of care in decision-making and treatment administration. However, our legal system demands accountability when negligence, so-called negligence, which may be most of the time an error, occurs. Patients have right to seek recourse through compensatory, punitive, or disciplinary actions as it is thought. It's incumbent upon to recognize the gravity of these legal ramifications and the strive for utmost diligence in our practice. Yet, accountability extends beyond individual practitioners to encompass the institution in which they operate. Hospitals too must bear the responsibility for the safety and well-being of their patients, whether through direct liability or vicarious accountability for the actions of their staff. But let us not dwell, let us not settle solely on pitfalls of medical negligence or error. Instead, let us turn our attention to prevention by addressing common errors such as avoidance, defensive medicine, failure to communicate. We can fortify our defensiveness against negligence suits. Moreover, we must familiarize ourselves with the legal framework governing our profession. Sections of Indian Penal Code pertaining to medical negligence, informed consent, and immunity of government doctors serve as a guiding principle in our practice. In face of media scrutiny and potential harassment, it is imperative that we stand firm in our commitment to ethical patient care. Let us not succumb to sensationalism or defamation, but instead seek recourse through legal channels and professional associations. In conclusion, let us remember that our mission as a healthcare professional is rooted in service and compassion. As we navigate the complexities of medical practice, let us uphold the highest standard of care and integrity, safeguarding both the well-being of our patients and the reputation of our profession. With medical legal cases being an integral part of practice, we are seeing an ascent in number of medical legal cases in our daily practice. Where all medical legal cases encountered share a common goal of promoting justice and well-being, but sometimes conflicts may arise when legal and medical principles collide. While ethical dilemmas, resource constraint, and differing interpretation of law can complicate matters, challenging us, both physicians and lawyers, to reconcile competing interests and find equitable solutions in the interest of casualty. As a matter of satisfaction, with the emerging trends of accreditation and certification of standard and protocols like NABH and Manyata, the documentation practices in the hospital have been systematized and practiced thoroughly, which works as a shield for doctors and hospitals, particularly in terms of medical legal aspect. We should encourage to follow such standards and protocols seriously. I would recommend strongly that every hospital should conduct CMEs on medical legal aspect by inviting expert practitioners at least once in a year, and all the staff, medic, paramedic, and pharmaceutical of the hospital must participate actively. I have a submission that in outcome of a patient care, the nursing knowledge, nursing care, nursing responsibility is one of the most important aspects of preventing all such issues in the future. I remember conducting CMEs on medical legal cases by health department, and medical colleges have made positive dent on handling the medical legal cases by doctors. Besides doctors, the police and judiciary should also be sensitized towards various aspects of medical legal. We have seen the fruitful results of such joint CMEs or orientation, sensitization of doctors, police, and judiciary. May our deliberations over the coming days in this conference not only contribute to the advancement of medical legal knowledge, but also kindle a flame of dedication to betterment of humanity. I would like to conclude by saying that together, let us embark on this journey, fortified by wisdom, courage, and an unwavering commitment by each other. And this is my request to all the people sitting here, that every one medical professional, each and individual belonging to medical profession should respect each other and not to criticize fellow colleagues for a greater good of the profession. I wish you all the best to enlighten yourself for medical issues, medical legal issues, and probably we should all go on the preventive mode, support each other so that we come out of this menace. In spite of being the most noble profession, best of the intentions, there are natural outcomes which does happen with utmost sincerity and dedication. I wish you all the best, and I hope all of us go with a very strong message and learning from this conference. Thank you very much. I thank Dr. Dinesh Shah and his team for having invited me. I feel honored to have met all the dignitaries on dais, and it's wonderful to be here. And I'm sure the topics, what I was going through in the program, are very enlightening, and I'm sure all of us are going to be a wonderful human being, and we go back with a pledge that we start respecting each among us. We start correcting very brotherly, very fellow colleague of ours, because everyone tries to do best to his patient proportional to his knowledge. Sometimes you can miss it out because of the pressure, because of paucity of time. But once we start respecting each other, probably we can be out of this burning issue of the day. Wish you all the best. Good luck. All the best.
हृदय की गहराइयों से बहुत बहुत आभार आपके इतने सुंदर सारगर्भित उद्बोधन के लिए माननीय डॉक्टर सुधीर भंडारी सर। और अब आज के इस समिट का वो अद्भुत पल जिसका हमें बहुत दिनों से इंतजार है, क्योंकि बहुत मेहनत की गई है इसके ऊपर। जी हाँ, मैं बात कर रही हूँ स्मारिका विमोचन का, पर उससे पहले एक हर्ष का विषय है कि हमारे बीच श्री पीपी सिंह जी फॉर्मर डिस्ट्रिक्ट जज, जोरदार तालियां बजाइए, जिन्होंने चिकित्सा और कानून के दांव पेच अपनी अनुभवी आंखों से देखे हैं, उनको मैं मंच पर आमंत्रित करती हूं। श्री पीपी सिंह जी कृपया मंच पर आएं। स्मारिका विमोचन के ये अद्भुत पल हैं। बुद्धिजीवियों के विचार मंथन के उपरांत निकले अमृतपान हेतु एवं उपचार के जन्म से लेकर आज तक की उपलब्धियों एवं महत्वपूर्ण घटनाओं को बड़े ही सुंदर ढंग से समायोजित संकलित कर आने वाले समय पीढ़ी को सौंपने के लिए इसे स्मारिका के रूप में समर्पित किया गया है। डॉक्टर कांतेश खेतानी, प्रवक्ता एवं मीडिया मैनेजमेंट, कृपया मंच पर आएं और स्मारिका विमोचन की प्रक्रिया को आगे बढ़ाएं। आयोजन समिति के डॉक्टर राजीव बत्रा, जिन्हें लीगेंड कहेंगे, डॉक्टर राजीव बत्रा को मैं आमंत्रित करती हूं। डॉक्टर विजय बत्रा, क्षमा कीजिए, डॉक्टर विजय बत्रा बहुत ही अनुभवी एक वरद हस्त हमारे उपचार पर है और उन्होंने बहुत मेहनत की है। उपचार संवर्धन, उपचार डायलॉग, उनका नियमित रूप से हमें उनसे लाभान्वित करना, सर के लिए बहुत बहुत आभार, बहुत बहुत धन्यवाद और जोरदार तालियां। दिन रात मेहनत करके आपके सामने ये स्मारिका प्रस्तुत की है। कृपया मैं अतिथिगण से निवेदन करूंगी कि वे स्मारिका विमोचन के लिए खड़े हुए। आज का ये स्वर्णिम पल है जो स्वर्णिम अक्षरों में कल बनकर आने वाली पीढ़ी का मार्गदर्शन कर उन्हें लाभान्वित करेगा। कहते हैं तलवार यूं बोली कलम से, मैं ही शक्ति पुंज हूं, युद्ध में मैं जान हूं और शक्ति की मैं शान हूं। बोली कलम, जब कभी थक करके तुम सो जाओगी, मेरे लिखे पन्नों में अपनी कहानी पाओगी। जी हाँ, यही है स्मारिका। खून बहकर भी हट जाएगा, पर जो मैं लिखूंगी वह युगों तक न मिट पाएगा। स्मारिका के लिए बहुत बहुत मेहनत की है हमारी सभी आयोजकों ने।
मैं निवेदन करूंगा कि स्मारिका कमेटी के डॉक्टर गीतिका जैन, डॉक्टर पराग गोयल और डॉक्टर अतुल गुप्ता कृपया मंच पर उपस्थित हों। निसंदेह इसमें पूरा टीम वर्क इन्वॉल्व था। साथ में बुद्धि प्रकाश जी, मामराज जी, दिनेश शाह साहब उपस्थित हैं और पाटीदार साहब कृपया मंच पर उपस्थित हों।
2020 में सॉप्सर की सब्सिडी के रूप में उपचार का जन्म हुआ। उसमें हमेशा टीम वर्क, निस्वार्थ भाव से सेवा, समर्पण और सामूहिक नेतृत्व अहम रहा है।
मैं नवनीत बोस को भी निवेदन करूंगा कि कृपया मंच पर उपस्थित हों।
पारदर्शिता की वजह से आज उपचार ने न केवल राज्य स्तरीय अपितु देशव्यापी छवि बनाई है। निजी चिकित्सकों एवं निजी अस्पतालों की आवाज बन चुका है उपचार हमारा परिवार है। उपचार राज्य के सभी निजी चिकित्सक इस मंच के माध्यम से अपने मन की भावनाओं को कह सकते हैं। उपचार डायलॉग, उपचार संवाद आपकी मन की बात जानता है। उपचार संवर्धन, उपचार समृद्धि, उपचार पर्यटन, उपचार मैत्रेयी सरकारी योजनाओं के बेहतर क्रियान्वयन के लिए हाई कोर्ट में याचिका दायर कर चुके हैं। उपचार के सभी सदस्यों को मैं बहुत बहुत आज के इस समिट के सफल आयोजन की बधाई देती हूं। और अब समयाभाव है, पर जो अतिथि हमारे बीच आए हैं उनके उद्बोधन से हम निश्चित रूप से लाभान्वित होंगे। आमंत्रित करती हूं मैं प्रोफेसर डॉक्टर योगेंद्र मलिक, जोरदार तालियां बजाएं। प्रोफेसर फॉरेंसिक मेडिसिन एंड टॉक्सिकोलॉजी, भगत फूल सिंह गवर्नमेंट मेडिकल कॉलेज खानपुर कलां से, सोनीपत हरियाणा से हमारे बीच आए हैं, आमंत्रित हैं।
Dignitaries on the dais, off the dais, I am very grateful to the organizers, specifically Dr. Suresh Vashisht sir and Rajshekhar Yadav sir, for giving me this opportunity, because most of the time in an MC we deal with professors, maybe associate professor or assistant professors in medical colleges, and most of the time it's the government people, government doctors we deal with. So when this opportunity came, Dr. Suresh made sure that you write it down in your calendar and you have to come. And it's an opportunity for me also to learn from people who makes major chunk of the healthcare in India. I've been asked to give a keynote address, and I'll try my level best to make it little musical so that the whole day goes very nicely for you. And with this, I'll start my presentation because the time is short and I want to say so much. So I'll directly come to my presentation. Presentation, is this what I'm supposed to do? Is it so? Not now. Okay, so maybe they wanted me to say something during inauguration also. So, okay, fine. So, it's an opportunity and we have to understand few things. That National Medical Commission, because I believe, I'm called not as a forensic expert, but a representative of NMC here. We are trying to do so many things in medical education, but what affects you the most is what we do in regulations related to the conduct of the registered medical practitioners. And obviously the registration also, just now also Dr. Nagpal was having a discussion and he was telling me what you are doing in new National Medical Register. So, I'll take this opportunity because it's not there in the slide on ethics. I'd like to clarify that what we are going to do this in NMR, and it will affect all of us, life of all of us. Actually, like in foreign, we are now dividing registration into two parts. One is registration and another one is license to practice. Registration means you will get a unique ID. Whenever you pass MBBS, next, as per the Act, you will be entitled to practice medicine, allopathy, modern medicine in this country as a registered medical practitioner. So that will stay with you forever. That means, that will tell you that I am an MBBS doctor. That is the meaning of a unique ID. Whatever it is, like Aadhaar card. But then, if you want to practice, suppose in Jaipur, NMR will make life simple for you. That unique ID, against that unique ID, on the NMC website, you will have your profile. And you will have access to that profile. When you have access to that profile, there will be icons on the left. One of them will be like, I want to have a license to practice. When you click there, there will be a drop down of 30 states. If you want to practice in Rajasthan, just click there. It will take you to the link will take you to the Rajasthan Medical Council. You have to pay an amount fixed by Rajasthan Medical Council, and then you will have an entitlement to practice in Rajasthan. Sir was asking about what about multiple registration, because in Delhi, so many people go to Gurgaon and Noida, so 3 states. So you, from drop down, you choose 3 states, pay the fee, and you start practicing there. So it will be that easy. Just by the payment, you will get a license to practice. It will be an automated process. That is what has been envisaged. I hope I was clear on that. One is that. Second is, there are so many issues, including this complaint against doctors in your mind. I'm telling you that we have devised a SOP in Ethics and Medical Registration Board, and we have started a training of experts in state medical councils. Our Honorable Vice Chancellor was there in that meeting also. In 22nd February, we were here in Jaipur, and we trained more than 125 professors of medical colleges from Rajasthan. So 4 medical councils we have already trained. We'll go throughout the country training the experts there how to give the opinion. I was discussing yesterday that sometimes we may feel that that doctor is pro, that a particular doctor in regulatory bodies pro doctors, he gives opinion only pro doctors and he is very good. It might not be the case always. Suppose there are 100 cases and we exonerate all of the 100 doctors. All of the cases will go to the court. And the court will see what is the quality of that judgment, whether it's a speaking order or not, whether it's a reasoned order or not. And if it is not, then even your regulatory body will lose face. So that is why it is important that as per Bolam, expert body opinion is most of the time is binding on the court. I'll finish in 2 minutes. Okay, fine. So we are trying to devise some SOPs there, and we want SMCs to also adopt them with modification, so that the orders coming from the State Medical Council, Ethics and Medical Registration Board, National Medical Commissions are such that they are speaking order, they are reasoned order, and they stand the trial of the courts. That way, if we do, then I think we'll be doing more good to our fraternity than simply, be biased, which we are not supposed to be as per the Act also, and as per the spirit of our profession also. So I have been told, so with this I have been told that I can continue with my keynote. So, acha, theek hai, okay. I have to change the slides myself. यहीं से करना है. Next, tag pointer. So I'll speak little bit about ethics in medical practice. That is what the topic given to me, and obviously there is a disclaimer, because whatever I say may be out of emotion, because I'm from the fraternity, may not reflect the views of the NMC, but most of the time, believe me, 90% of time it will reflect the views of NMC, right? So this is the outline, sir. I don't want to, because there are very senior people here, and there are people from whom I think we have learned a thing or two. So I won't go into the details of theoretical part of ethics, what are ethics and all, though I'll touch them a little bit. But this is the outline, and this is the most important slide I'll say. First, I'll tell a little bit about NMC and EMRB. Second, I'll tell a little bit about what are ethics and how do we decide what is ethical. In third part, I'll speak about the confusion. There are so many confusions in our mind regarding law and ethics. So I'll try to tell you about the confusion. And the third, in the third part, I'll tell you about ground reality also. In fourth, this is very important, I'll tell you that ethics are not static. They change. So how they change and how we are not changing with the changing ethical environment in our country. And then past, present and future, there were nearly 40 examples. I think I'll give you only 2-3. And then changing nature of healthcare and role of doctors. This is the most important thing. If we do not understand this, we will not understand the changes taking place in regulatory bodies, in the world, in the healthcare, and in medical education also. And last part, do we actually require ethics? Why we require ethics? Can we do away with? Because every now and then you will hear that after Consumer Protection Act, actually ethics are not required. So I'll try to deal with that part of it also. Now, what is National Medical Commission and what is the objectives? The objectives are to improve the access to quality and affordable medical education, ensure the availability of adequate and high quality medical professionals in all parts of the country, encourage medical professionals to adopt to the latest medical research, in their work and in contribute to the research, promote equitable and universal healthcare that encourages a community health perspective and make the services of medical professional accessible to all citizens, objectively assess a medical institution periodically in transparent manner, maintain a medical register, I have spoken about it, enforce high ethical standards in all aspects of medical services, and have effective grievance redressal mechanism. So basically, everything was there in MCI Act also. What is a little different is, because earlier, what a medical college is supposed to do, if I speak broadly, only three things. Am I audible? Okay, now, fine. So a medical college actually is supposed to do broadly three things. One is teaching, another is patient care, so teaching in college, healthcare in clinical care, patient care in hospital, and the research. Now the focus on research has increased, and then the goal of what MBBS should do has certainly been little different. Now we are expecting him to focus more on our programs, how to run various government programs, and then how we can bring equitable access. And then we have to increase the numbers of doctors also in the country, because there is a skewed ratio in urban sector, in rural sectors. We can have a debate on that. But these are the few things which NMC envisages. This is the organogram, I think, just for the sake of information I am putting it. There is a advisory council, which is a large body. It meets every 6 months. Hundreds of professional, nearly all doctors, majority of them are doctors. In fact, 90% of them are doctors. And National Medical Commission, 33 people, 22 are part-time members. That means every 3 months they are supposed to meet, but we meet frequently also. Monthly mostly we are meeting now. And they are nearly all doctors from State Medical Council and the Vice Chancellors of the health universities, and 10 ex officio members like DGHS and ICMR and AIMS and that kind of thing, and one chairman. We have a secretary which heads the secretariat of the chairman office, and 4 autonomous board. Obviously, they were there in MCI Act, but in the form of committee. Now these boards are also autonomous board, right? So for UG education, there is undergraduate medical education board. For PG postgraduate medical education board. For assessment and rating, we have MARB, and for ethics, we have ethics and medical registration board. So this is what these all boards do, and they meet. And now this is the focus for today's address. That is what Ethics and Medical Registration Board is supposed to do. So these are the things: maintain national register for all licensed medical practitioners, regulate professional conduct, and promote medical ethics in accordance with the regulation. Develop mechanism to have continuous interaction with the state medical councils to effectively promote and regulate conduct of medical practitioners and professionals. Exercise appellate jurisdiction with respect to the action taken by state medical council. So this is what we are supposed to do. We came out with some regulation in 23. They are in abeyance due to some reasons, and most probably they'll be through very soon. Till then, we are using the 2002 regulations of IMC Act, and they were revised periodically. These are some of the publications which we have done, which will show you that we are really serious about the business of ethics, conduct, and even the standard of care, and how to build resilience into the healthcare professionals in India, so that there are less cases, and even if there is a case, they know how to deal with this. So this is expert training module. As I told you, we are going to all the state medical councils, training various experts who give opinion in complaint cases. See, we need to understand one thing. We complain so much, but then you understand that whoever is giving opinion is a doctor. Whoever is deciding, maybe in district also, in the negligence board, or in state medical council, or in ethics and medical, is also again a doctor. So against whom we are complaining? We have to, this is a thinking point I'm giving. When we speak, things are not going in the right way, then we'll have to look inside also. That is why to give good expert opinion is an art. We are trying to teach them to all our fraternity members. We have a booklet for this. It's there available online also, and I can send it to anybody who wants it. And then this professional conduct review. There are so many cases we are deciding. And you know, some of them are in court, some of them do not go to the court. So we are trying, in this booklet, we are trying to send to the stakeholders, maybe patients, public, as well as the doctors, to understand why this particular case occurred, how we could have avoided that, and what are the things we should keep in mind to avoid the complaints. So this is the, and then in medical education, it is important that the teachers understand their role. We say the level of medical education is going down, and we give so many reasons. Some of the reasons are genuine also. We are trying on that, but then teachers have to understand that if they do not work hard, all the institutions which were best in this country, like All India Institute of Medical Sciences, JIPMER, CMC, SMS, KGMU, PGI Rohtak, and there are so many others also. What makes them the best institution? Because everybody earlier had very good clinical material. It was the teachers who made the institution best. So we need to understand that they have a responsibility and they have to work harder to make their institution grow. So we came out with these guidelines for teachers, and obviously for students also. Nowadays, there was a picture from a very, very, very prestigious institute that one professor is teaching, only 4 students and a dog is listening. It was a picture there on social media from a very prestigious. That means where are the other students? They have adopted some digital learning tools to understand. So can we have this kind of education in our country? So students' guidelines also. So now I'm coming to the second part of my presentation, and that in our practice we all know we face 3 types of questions: scientific question, technical questions. You know about this. And then there are questions like about values, about rights, about responsibility, about behavior and decision making. These questions make ethics important in our profession, because technically what you will do is a technical question. Whether we should extend the incision in appendicectomy or not is your decision. That is a pure technical decision. But then whether you should take consent to extend that or not is a question related to values. So that question makes it an ethical question. Now scenario, I'll just skip that, but there is a very good scenario if you can quickly read and tell me that a couple had a baby born with an undiagnosed genetic disorder. They wish to know the chances that any future child will be similarly affected. To answer that question, their genome were sequenced and compared. The analysis revealed that the father is not the biological father of the baby, and the condition of child is result of unfortunate combination of sequence in mother genome with the biological father. The disorder is like that of classical recessive inheritance. So the next baby of this couple will be normal, as the father in that case will have 2 normal genes. Would you reveal the information about fatherhood? Is my question. What is technical about it? What is scientific about it? No. It's question of values. And you have to debate inside whether I should tell or not, whether I should, because telling will lead to a particular consequences which is not medical for the family. But if you do not tell, then you may be thinking maybe next 2 months whether I did the right thing or not. So I leave it at that, because the time is running short and I have a lot of things to speak, but this is the best example to tell you how scientific questions, technical questions and ethical questions are different when we practice. Now there are 2 thoughts about it. One school of thought say morality is what ethics are. Another say this is subset of morality, that is more of a philosophical discussion, but actually it is something related to morality that we have to remember. And then there are 3 branches of ethics. This is very important, we have to understand, because why I am telling this is there are meta-ethics, normative ethics, and this medical ethics is part of applied ethics. What is applied ethics? Means suppose there are 2 patients and we have only 1 kidney for them. They need transplant. So whom to give? So philosophical discussion into it is different, but how we will decide based on the environment in the college, the laws and regulations about my own values, that is different. So this is what applied ethics are. So for business ethics. For medicine, there are medical ethics. So that is how these applied ethics are. The medical ethics is a part of applied ethics. This slide is very important, and I would request all of us to change a little bit after this presentation. Why? Because I have heard, I've been now going to many places about ethics and all. People call me. It's not that I know much about it, but just because I'm there. So what I hear from even the senior most people, they say ethics is something, why we need to teach it. Ethics is something which we have in it. We learned it from our seniors. Why you want a different chapter on this? It's not required. Please stop saying that. Ethics is something which we have to learn. And maybe at the end of the presentation, I'll be able to convince you why. What we talk is these are non-rational approaches. It's not that the literature doesn't know. They know that obedience is one way of learning ethics. But these are non-rational approaches. Imitation. I have a role model in my college, maybe my senior, maybe a good professor. So I imitate him. Feeling or desire, I have my feelings. I want to be a good doctor. How I can be a good doctor, I have to be good with the patient. Intuition, I have an intuition. And then habit. You learn from habits of others also, and you make your habits like that also. So these, and somehow if you are in a unit, the people are behaving in certain way, and that also becomes your habit. So that is also one part of it. If it was good, the SOPs were good, then you have learned it, you have made it a habit. So these are non-rational approaches. Rational approaches are deontology, consequentialism, principalism, and virtue ethics. I'll not go into the detail of it due to paucity of time, but I request you to read this. This is very important. They'll take you to the Kant and philosophy, but they'll give you a good insight. Personally, I like virtue ethics. That means there are some values which we learn in the society, which we learn from our family. If those structures are very robust, then obviously some of the virtues we'll have in us. The spirituality will have in us. The care for the patient will have in us when we reach to the medical colleges. So, that is also one part of it, and we need to, why I kept this book's cover page, I'll tell you later if I'll get time. Now this is the confusion actually in the minds of everybody. We have to understand this, and until and unless we understand this is very important, very difficult, that will not be able to separate the emotional component which we have for our fraternity, the academic and scientific temperament, and the practical approach to it. So what is right and wrong? What is ethical and unethical? What is moral? What is immoral? What is lawful? What is illegal? What is good? What is bad? We have a confusion with this. Why we have confusion? It's not that we are confused. Actually, it is confusing. Some things which are ethical, they are legal also. That is a good scenario. But then there are few things which are legal, but they are unethical. Just to give an example, we say that if we arrest somebody, we can use reasonable force. That is legal. But what as a doctor you think? I don't want to give my sample, even if I'm a victim or a complainant or accused. Why should I give? The ethics will tell you patient's rights are supreme. May tell you. So some of you might think it is legal, but is unethical. Then there can be a possibility that things is ethical, but it is illegal. We were discussing one case yesterday. I have not taken permission to take names, but it is there in the public domain also. I can use Dr. Jacob Matthews' case. So he tried to help somebody. He was not involved in the case. And then I heard this case from Safdarjung Hospital also. One of the resident was going, like Dr. Jacob Matthew, and some patient in other unit said he is having severe abdominal pain, doctor, please come, because the doctor in that unit is not coming. You go there, and then something happens, and then you are, in a quagmire of litigation. So you will always think whether I should have gone or not. So what you did was 100% ethical, but was it legal? I mean, how the legal perspective to that is maybe different. So, that is why this confusion. What is the importance of ethics? Please don't think that ethics and law are separate, and we should not give importance to any one of them. Laws are generally made by parliamentarians, and the foundation of law is always ethical, please believe me. But ethics change, we have to understand that. And when ethics change, it is the time to change the law. There is a time lag between that. That is where the problem lies. So when the ethical foundation of the law changes, then the law needs to change. Now the ground reality. This is what I've told, what is theoretical, but the ground reality is, if there is a case against you, that will be as per the law of the land, and the patient can go to the civil courts and criminal courts, and then there are regulatory bodies also. And I hope Dr. Nagpal will tell you there are 6-7 other fora also where he can lodge complaints. CM window, this window, CM, Consumer Commission I told. So, and these are the warnings which we can give to you. Now, important thing which I wanted to tell you is, do ethics change? They change. They change with values. And how the values change? Values change with change in knowledge. Earlier we were not knowing something, now we know, that is why the ethics have changed. Individual personal experience. As a MBBS, I used to think in a certain way. When I came into a PG, I used to think in a certain way. When I became professor, in a certain way. When I was the chief minister, in a certain way. And now in a regulatory body. So I am learning, and then I am growing, maybe. I believe I am growing. And then with the personal experience, I grow. And then change in social values and cultural values. Our cultural values change, our social values change. And with that, I hope you can see, and I'll run through these slides, because this will tell you that earlier, what were the ethics, and now we have changed them. Like communication, it was a low priority. Paternalism, we called it. Doctor has to decide if during appendix, I found a different lump in the abdomen, then whether I should operate or not. Earlier, they used to tell you operate, because it's good for the patient, you decide. Now, after Samira Kohli, Dr. Suresh will be telling you, you can't. You'll have to ask the patient. Even if you know that it will do good to the patient, you can't. So, history taking, personal involvement, now dissociation, life-saving decisions. Earlier, the machines were not such. So many questions now related to brainstem death and all. So, definition of ordinary has changed extraordinarily. Euthanasia, I hope you know the debate. Hippocratic oath. Abortion you can't do. Now, women right, I mean, we all know about it. And the confidentiality, how it changed. And then benefit of the patient. In research, in randomized control trials, it may not always be the issue, and you know from the beginning that some of them will be on this side and some of them will be on that side. Healthcare reforms, earlier nothing of such thing was there, and now doctor talk in language of cost-benefit analysis, audit priorities, rationing, governance, and so many other things. And lifestyle issues. I can give many examples on this, and very good example, whether a person who is smoking should get the insurance benefit was a question in UK, in NHS. So now, such kind of questions, we can't even think 20 years, 30 years back. Vaccination, whether we should continue vaccination or not is a new thing. HIV infection has significant shift in the behavior regarding the sexuality. Transplantation, major change. Contraception, major change. Infertility treatment, surrogacy, major change. Cloning, genetic screening. I just wanted to give an idea about that these are different type of changes which are taking place. And public views on medical profession are changing. We have to understand this. Greater public questioning of role of doctors, the way medical professionals operate and regulate itself. Role of religious authorities have decreased. Interest in human rights and animal rights has increased. Intolerance and hatred is on rise. rise of single issue groups. There are so many groups, patient right groups, environment groups, health issues groups. So, various groups are coming up based on the rights approach. Role of information and technology and internet is one which is leading to a disruption in the whole ecosystem. And then changing attitude to family and sexual relationships. We know that the very foundation of family, various orientations now, there is a debate, and now there are some judgments from the highest of the highest court of this country on various gender issues and all. So all those things will change our practice in a very different way. But we have to understand that these will not change. There is a very good book by Swami Ranganathan. It's in 5 volumes. Those who are interested can read. This one is specifically for, this is first volume, I think, Parivartanshil Samaj ke Shashwat Mulya. It's there in English also, if you can get. That there are so many changing things in the world, but few things, they do not change. So this compassion will never change. It has ethical component, skill, attitude, competence. You will always need to have competence of scientific facts, knowledge and technical skills. Autonomy is a concept which comes with the individual rights, and we have to give due importance to it. If we do not understand this, we will again be saying why we know what is best for the patient, why the whole world is after the doctors. You have to understand now the patients. In communication, I told you, now they are a stakeholder in decision making. It's not like you'll tell them and they'll understand. Then human rights. So these are the core values of medicine. This was the past where there was paternalism. Physician had right and duty to decide how to treat patient. Patient had to submit to the commands of the doctor. No obligation to obtain informed consent. And then this torture, we know Nuremberg trials and all. I don't want to go into the details of it, what doctors did there and how this code evolved. And then abortion, slavery, racism, gender discrimination, LGBTQ, these issues. We know what we thought about it in the past. We know what we are doing in the present. And we have to understand how the things will be in future. So now the question is, does ethic or these values, these moral or these regulation matter? Yes, they matter. People tell me that after CPA, why you need all these. Please believe me. And if you have a contrary opinion, I'm ready to discuss it. There is no court case till date where the court is not sympathetic towards doctors, including Dr. Jacob Matthew case. That is a landmark judgment. You see how even the CRPC, CRPC says if there is a cognizable offense, this is what a police officer is supposed to do. This is non-cognizable offense. This is special mention of medical negligence was made for the first time, saying that if you do not do that, doctors will start defensive practicing and is not good for the society. So that means the courts take a lenient view. Why they take a lenient view? Because they understand the importance as well as complicity of the medical fraternity. And they also have given very good thing which is called Bolam test. Still now we have Bolam test, that who will decide what is right and wrong? You yourself will decide. Your fraternity will decide. So that is still the case. So I feel why we are having this liberty in courts is because there is this patient trust and confidence. How much you may say it has eroded, but then still I'll say the major component is there. This fiduciary relationship is there. And if we do away with these ethics, then this component will be gone, and then this will be in the contract business. It's not a very simple thing, I'm telling you. And then order and disorder. Some form of rules and regulations are required for smooth functioning of society, larger society. I'll tell you, this Upchar or maybe Medicolegal Action Group, you also have made some, rules and regulation how people will behave in your particular group or in your society. So similarly, the larger society also needs, the patient-doctor relations also needs some kind of, order, and that we may call a part of it is ethics. Professional standards. We being professional, it is our bound duty that we also uphold those higher standards which our forefathers in our fraternity did. That is why we require professional standards. And then future. These are only some of the things. I'm standing here and talking. If I come after 5 years, nearly 90% of my slides will change. I'm telling you. So much disruption is going to come from the technology, from AI, and all other digital intervention in the healthcare, that other issues will become more important than the issues which we are discussing now. In future, developments in technology like artificial intelligence, social media, robotic surgeries, whether everybody from America will do surgery in India or from India will do surgery in West, is a question we'll answer in few days, few years maybe. Digitalization of healthcare and telemedicine guidelines, development in science, stem cell research, genetic engineering, nanotechnology, development in socio-cultural environment. With these changes, socio-cultural environment, I hope you have seen a very good documentary on Netflix. It is called Social Dilemma. So you'll know that how our socio-cultural environment, and there is a movement going on in the West in the name of minimalist. Some are naturalist. So you'll have to understand that our socio-cultural environment will change. Biggest change will be the pace of the change. Please remember this. This is the book. If you can read, you will understand that what I'm saying is not fancy. It is going to happen in near future. And I'll request you to keep pace with the pace of change. The last, I think, slide, I'll want to tell you that earlier it was just doctor-patient relationship. It's not like that now. It's like in medical research, there are ethics. In pharmaceutical industry relationships, there are ethics. Medical device industry relations, they are list. Technical drive interaction with technical people, public social health, policy making, administrator, doctor, media interaction, health team leader for the patient care. So these are the various dimensions. And why these dimensions? Because earlier we were gods. Because all these things we were doing alone. We were policymakers, we were administrator, we were teacher, we were laboratory technician, we were researcher, we were priest, we were pharmacist. Now they are paramedics. Now more than 200 paramedics work around a doctor. So what we have become? We have become most important part of the delivery maker next to God. Patient, doctor, but there is a hospital and the whole. Now this is, we became team leader of healthcare. This was the team leader. I'm about to finish, so I won't go into the detail. But we are just a part of healthcare industry. This, if we do not understand this, we will not understand the change taking place. There are so many other people who are working with us here. So this is my conclusion, that the traditional physician-patient relationship based on mutual trust is fading, but is still there. Public knowledge of patient rights is increasing. A business model with customer and provider slowly but steadily emerging. Inappropriate medical action resulting in harm is perceived as an opportunity for financial compensation. This is happening. Even after this conclusion, I would say ethics are important, and we have, as a professional, we have to bound by this. Yesterday's saints are safe with their past, but today's sinner will have a difficult future if urgent remedial measures are not taken. This is the takeaway message. Thank you so much. Thank you, sir, for this. Though I have a presentation where real life case scenarios are there, but in 30 minutes it was not possible. Dr. Suresh was telling me, please discuss some real time cases. But then I told him in half an hour it's not possible to discuss even one case. So I tried to, be as brief as possible. Though in this presentation I have next 10 slides on negligence also, but I think it's not required. I would request the organizers to take it further from here. I don't know how to do it. This is from my side. I thank again the organizers for giving me this opportunity to present my views in front of such distinguished, learned guests here in this room. Thank you very much for having me here. Thank you.
साभार धन्यवाद। आपके मेडिकल सिद्धांतों के बारे में, नैतिक मूल्यों के बारे में, कर्तव्यों के बारे में जो आपने विवरणात्मक, विवेचनात्मक और विश्लेषणात्मक उद्बोधन दिया, उसके लिए उपलब्धि पत्र देने के लिए मैं आमंत्रित करती हूं अरिसीदा के अध्यक्ष डॉक्टर अजय चौधरी। जोरदार तालियां बजाएं ऐसी महान विभूतियों के आगमन से ही आज के इस समिट की सफलता के शिखर को ये छुएगी और बहुत बहुत हार्दिक शुभकामनाएं हैं। ये समिट सभी चिकित्सकों के लिए है, चाहे वो निजी चिकित्सक हो, चाहे वो सरकारी से जुड़े हुए हो। ये चिकित्सक के हितों की रक्षा करने वाली समिट है। और एक बात मुझे समय मिल रहा है तो मैं बहुत जोरदार शानदार तरीके से कहना चाहूंगी कि विगत वर्षों में जब जब किसी चिकित्सक के हित पर कुठाराघात करने का प्रयास हुआ तो उपचार परिवार 1 सेकंड में एक साथ खड़ा हुआ है। यही हमारी उपलब्धि है चिकित्सक एकता के लिए। और अब कहते हैं ना, अगर संकल्प पुण्य की वेदी पर एक विचार होता है तो वो संकल्प बन जाता है। ये हाथ अगर यूं जुड़ते हैं तो प्रणाम बन जाते हैं और ये हाथ अगर यूं जुड़ते हैं तो ताकत बन जाते हैं। जी हाँ, एमएलए जी के सहयोग के बिना आज की इस समिट का सफल आयोजन नहीं हो पाता। मैं बड़े ही श्रद्धा प्रेम से आमंत्रित कर रही हूँ डॉक्टर नीरज नागपाल, जोरदार तालियां बजाइए, सीनियर गैस्ट्रोएंट्रोलॉजिस्ट जो पास्ट प्रेसिडेंट आईएमए के हैं और जो आज के समय में लीगल कन्वीनर हैं मेडिकोलीगल एक्शन ग्रुप के, जो कि एक नॉन प्रॉफिटेबल संस्था है जो हमेशा 2012 से हमेशा चिकित्सक हितार्थ के लिए खड़ी रही है। जोरदार उद्बोधन, शानदार उद्बोधन अभी आप सुनेंगे। तालियों की गड़गड़ाहट के साथ स्वागत है सर।
Thank you so much, ma'am. Before you start my timer, please give me 2 minutes. Dr. Yogendra Malik is here, and I don't want to lose this opportunity. It was a keynote address, and if I had asked some questions, Ashwini would have sacrificed me because it is tradition you don't ask questions in a keynote address. So my request to you, sir, under RTI, Medical Legal Action Group has asked different state councils, if a person from Mumbai wishes to practice in Punjab, what is the procedure? Will you allow him or will you ask for an NOC? You said it is going to be as simple as a click of a button. 2 state councils have already given me under RTI the information that they want an NOC, number 1, and I'm not asking a response, sir. I'm just giving you the problems which are, so that when you come up with the regulations while you are doing your job, you are aware of that. Second thing is, we have a huge list of duties and responsibilities of RMPs. Could we please have out of those 104 pages, 1 page of rights of doctors? The only right of doctor we have had in the regulations which were withdrawn was right to charge money. I mean, that too, under Clinical Establishment Act, we do not have any right to charge in an emergency. So that right alone, I mean, I have a right to safe environment. At least that much you can write ki I have a right to a safe working environment. So please have.
Sir, though I thought I'll not respond, but I think I should. 3 things were there in which the regulation, unfortunately, which the fraternity opposed. I'll become emotional, sir, which I should not. So I'll not go into the details of how we behave. There were 3 things, sir. One, right to charge money was there. For the first time, we introduced. Second, violent behavior. If a patient or the family behaves violently with you, then first time, you cannot abandon the patient, but you can tell him that you go somewhere else. It was not there. It was unethical earlier. And the third thing, sir, which you said regarding?
Abhi aa rahe hain aur, sir. Abhi,
yeah.
List
So I think I'll not be able to answer all the questions because then the whole day will be like this. But I'll definitely sit with Nagpal sir and assure you. The only thing I assure is we are open to any suggestion, criticism, and we are open to change also. No, sir, we can't have.
Sir, वो regulations doctors की हैं, RMPs की हैं. Another very small point, sir, please, when you take these workshops for people who sit in medical councils and give judgments, please ensure that the use of term gross in their judgments can have disastrous consequences for the doctors, because this term gross is not understood by doctors when they are using it, but it has huge implication for the legal community and for the police actions. Another problem which has occurred now, which you raised, and I must address that, we are still India versus Bharat. We have 80%, 90% of our patients who still are dependent totally on us. You are saying regarding patient participation, that in the health education scenario we have in our country, we are extrapolating something from US and bringing it to India. Maybe 30 years down the line this will work, but today some leeway will have to be given before we go for patient advocacy total and patient participation total. I'm sorry to have brought these things up, but I thought it is an opportunity I don't want to miss. Thank you.
Thank you, sir. After a wonderful discussion on medical ethics, now we are moving ahead. The next session will be on Let CPA 2019 Not Turn into a Legal Terrorism. It is a wonderful topic, and for this, I would like to invite on dais chairperson, Dr. Rajveer Arya sir. He is retired professor from SMS Medical College, Jaipur, and he is member of Senate, University of Rajasthan. He is State Secretary of Rajasthan Medical College Teacher Association and also State Secretary of Association of Surgeons of India. Second chairperson would be Dr. Hemant Bhartiya sir. He is Director and Head Department of Neurosurgery, Fortis Hospital, Jaipur. He is past President of Neurosurgical Society of India and past President-elect of Skull-Based Surgery Society of India. Dr. Hemant Bhartiya sir. Third chairperson is Dr. Manoj Singhal. He is MBBS and MD pediatrician. He is practicing since 1992 at Ratna Hospital, Narnaul. And for the topic, we have a wonderful speaker, Dr. Neeraj Nagpal sir. He is consultant physician and GI endoscopist, managing trustee of Medicolegal Action Group. He was secretary and president IMA Chandigarh State Branch, director Hope Gastrointestinal Diagnostic Center, Chandigarh, and authorized. He authored multiple books and research papers and various chapters and journals. And he is a very excellent speaker, and he will prove in next 20 minutes. Over to you, sir.
So with the permission of the chair, I think I'll straight away start. The topic, do you have a slide changer? How did doctors come within the purview of CPA? Initially, there were some judgments which said that doctors should not be covered. There were some High Court judgments which said doctors should be covered. And there was confusion going on, and the entire matter finally came to Supreme Court, and in VP Shanta and others, this was finally settled that Consumer Protection Act, doctors will be covered within the definition of, of service as given under Section 2 of CPA 1986. However, if you go through the VP Shanta and others' judgment, what did it say? It said very, very clearly that only outright cases of negligence, you have to operate on the right side, you're operating on the left. These are the kind of cases, because of the summary nature of the consumer judicial process. So only these cases should be taken up, and cases which required evidence of experts, where arguments were to be made and where evidence was to be produced, these cases should go to civil courts as they used to go earlier prior to introduction of Consumer Protection Act. This exception lasted for around 7 years, and then in 2002 we had a judgment of J.J. Merchant where it was said no, even in cases which require, even in complicated cases where evidence of experts is required, case can still be taken and adjudicated under Consumer Protection Act. There were many arguments which were placed before the Supreme Court why doctors should not be covered under CPA, but the Supreme Court had said categorically that it is not possible to hold that medical practitioners must be treated to be excluded from the ambit of the Act, and the service rendered by them is not covered under the Section 2. We had made an argument, when I say we, it is the advocates of IMA and IMA itself, that the people sitting in the bench in consumer courts do not have medical knowledge. But the Supreme Court answered that and said that in consumer courts, cases come from very different walks of life, and it is not possible to have experts from all walks of life in a court on the bench. So it is not possible to accept this argument that since these people do not have that much medical knowledge, hence medical cases should not come into consumer courts. But look what happens. Our courts are very, very wise and they know everything. Can you read the gist of this judgment? Removal of the gallbladder instead of conducting laparoscopic surgery to remove stones of the gallbladder without the consent of the complainant was incorrect and against medical ethics. No case has been made out that the surgery was essential in a life-threatening situation. And this is not from a district consumer dispute redressal commission. This is National Consumer Dispute Redressal Commission. And then we say that medical knowledge is not necessary for people who are to adjudicate cases of alleged medical negligence. Then we said the procedure is summary in nature. We cannot argue, we cannot defend ourselves. To that also they said, but the answer they had given was only outright cases will be taken, so it is all right even if it is summary in nature. But that, as I showed you, was overturned within 7 years. Now let's come to the crux of the matter. How many consumer court cases do you think are happening in the country? In 1995, I published the first compendium of CPA medical judgments, and we had 113 cases starting from 1960s. I think Trimbak Kodbole judgment, Dr. Pradeep Arora will vouch for me. But since then, there were only 113 cases of medical negligence which were adjudicated in courts in India, and including consumer courts. Here, we did a search from 1st January 2023 till 31st December 2023. National Consumer Dispute Redressal Commission alone decided 261 cases in this 1 year. 54 state consumer dispute redressal commissions, including circuit benches, decided 1,048. Mind you, some state consumer dispute redressal commissions and their circuit benches still do not upload their judgments on the Confonet site. So this number is bound to be more. The actual figure is bound to be more. Now we had to find out what happens in the district commission, because now 99.9% of the cases of medical negligence are coming to district courts. Because we are not getting paid more than 50 lakhs for my services. 50 lakh mein to mujhe kharid lo. Meri services kyun kharidni hai? So, most doctors would not charge more than 50 lakhs. And the bar today is you can ask for 200 crores, but if you have paid less than 50 lakhs, your case will go to District Consumer Dispute Redressal Commission. So it is very important to know what is the number of cases in District Consumer Dispute Redressal Commission, and very few District Consumer Dispute Redressal Commissions upload their judgments. So we took one state, we took the state of Haryana. State of Haryana, State Commission decided 10 cases in this year. All district commissions in Haryana, they decided 170 cases. So the ratio of 170 to 10, which was 17 times the number was in district commissions. The same ratio we multiplied with the state commission, and got the figure of 178816 as the total number of cases which were filed which were decided by district commission. Total number of cases decided by consumer courts, national commission, state commission, and this nearly 20,000. Number of cases pending in courts. Now, this we are talking of only cases which have been decided in 1 year. So the cases, number of cases pending in courts, I have taken approximation only of 2 times. This is very, very efficient courts if the pendency is only 2 times the number of cases they are deciding. To my mind, this would be at least 5 times, but let us be conservative and say 2 times. So that means around 38,000 cases are pending in courts in that year, which means the total number of cases decided and pending in consumer courts for that year would be 57,365. Now, if you add every case which goes to court or to be decided or filed with the police, there are at least 2 cases where the hospital or the doctor has settled with the patient. कुछ दे ले करके हमने जी वो मामला खत्म किया. This figure again comes to 57,000. And do you know that 80% of all disputes arise against hospitals, small and medium healthcare establishments, or corporate hospitals or government hospitals? Single clinics or Ayurvedic clinics or homeopathic clinics, the numbers are very, very small. Majority are interventional procedures for which these cases have been filed. So if 80% of this figure is taken, it comes to nearly 45,000. And do you know the total number of hospitals in India, government and private included? The figure is 69,264. So with 45,000 cases decided or pending in courts, you have nearly 0.662 case against each hospital every year. So this is something which we need to be very, very careful about. And if we have included the out-of-court settlements, this is the kind of figure we get. So point is, what I'm trying to show is the number of cases which are being filed in consumer courts is exponentially increasing year on year. One simple line for which I needed to show you all that data. Also, the quantum of compensation which is being awarded by courts these days is again multiplying exponentially. There is a new formula. Earlier, the calculation used to be what the old calculation was, and it was limited. I'm forgetting the term which was used for that. No. This is restitution integrum, multiplier method. Earlier, it used to be multiplier method, which was used for calculating the compensation. Now they say it is restitution in integrum. And this is the way you calculate. So effectively, if a 35-year-old man is earning 2 lakhs, the figure will go anywhere to 7.28 crores and more if we simply calculate at this level. Is it a scaremongering which I'm doing? We already have Jacob Matthews, we already have Kunal Saha's judgment, which said very clearly that 11.6 crores was awarded. Then we also have V. Krishna Kumar. This is a government hospital. Free treatment, where 2.28 crores was awarded. And mind you, besides this award, you can also be awarded under Article 32, under Article 226, under law of tort, and even while being criminally prosecuted under Section 357 CRPC. There are many learned people in the audience. Maybe I will make a legal mistake. I am a student of law. I am not an expert in law. Though sometimes Dr. Suresh Vashisht and Ashwini will try to pull my leg by trying to show that they are touching my feet. But actually it is only an exercise to show me that they can bend and I can't. So, the pecuniary jurisdiction today is 50 lakhs if a patient has paid me, not what he has asked for. It will come to district. From 50 lakhs to 2 crore, it will go to state. and 2 crore and above will go to National Commission. Which procedure in India costs 50 lakh to 2 crore? Maybe liver transplant, and that too maybe if done in Medanta or one of these places. In my place, in these figures, we buy and sell doctors. I mean, these are not the figures for medical treatment. But are the doctors never at fault? We are at fault. Why we are at fault? Because we are all too intelligent to get together. We are too intelligent to work with each other. We are too intelligent to oppose a draconian regulation or a law which is being brought because it does not have my name on it. When we are talking quantum of compensation, some compensations I'm showing you more than 1 crore or significantly high compensations. This was V. Chandrasekhar, he was a TT champion, and in 1993, 17 lakhs was awarded. We considered that to be exorbitant in those days, and maybe if you calculate that amount for today's worth, it was. But keep looking. Even in a Tamil Nadu hospital which conducted free eye checkup camps, 9 crore plus was awarded by a sessions court. So this is not, what I'm saying is not scaremongering. I have been told by many people that when you speak, we want to give up practicing medicine, we are so scared. तुम डराते बहुत हो. Well, अगर डर जाओ बहुत अच्छी बात है, because 25 साल से तो मैं ऊपर 27-28 years I have been speaking my head off. It doesn't seem to have changed anything, except maybe some people have joined hands and we are a movement which is growing. So you can have any number of cases, and even today I get people who are very surprised and tell me, अच्छा डॉक्टर साहब indemnity insurance भी लेनी पड़ती है. हम सिविल हॉस्पिटल में तो कभी नहीं लेते थे. अब 4 साल से मैं प्रैक्टिस कर रहा हूँ एनेस्थीसिया. Why should I be taking? जब वहां नहीं लेते थे. आप तो कहते हो गवर्नमेंट हॉस्पिटल पे भी CPA लगता है. I have no answer. Again, not only are the courts philosophical, even us doctors, we think we know everything. No one is immune, whether it is a government doctor. Mind you, even R&R hospital, military hospital Delhi, has been prosecuted under Consumer Protection Act. So today, if you ask me, is there any hospital in the country which is not covered under Consumer Protection Act, my answer will be probably none. Why? Because even so-called free hospitals are all charging something from some patients, if not all. If they have put in a CT scan, maybe they are not charging 4,000, they may be charging 800 rupees, but some money is being charged. Maybe they are not charging all 100 patients who come to them, maybe they are charging only the private patients. All right, but even the patients who have not been charged are covered under Consumer Protection Act as consumers. Anybody else is making the payment. It is not the patient. The patient's father makes the patient's insurance company makes the patient's organization where he works makes the patient, ESI, any. It doesn't matter. Everybody is covered under Consumer Protection Act. And there is no limit on what compensation can be asked for. We already have Kunal Saha case where I think first he had asked for 97 CR, 77 CR, which with interest came to 97. And then he increased it when he went to Supreme Court to total 200 CR. And the Supreme Court, in the generosity mood they were in, awarded only 11.6 crores. So I think we should all thank them. And the interest on compensation awarded can be anywhere from 6 to 18%. There is no fixed guideline what interest is going to be awarded and from when. It can be from the date the event occurred. It can be from the date the case was filed. It can be from the date the judgment is delivered. There is no guideline. Any judge, he gets up on the right side of the bed, he can decide 18%. He fights with his wife, he can decide 12%. He does not fight with his wife and he's a happy person, maybe 6%. There is no guideline. There is no fixed way to calculate how much interest is to be awarded and from when. And patient may ask for 3,000 rupees. court is within its powers to award 5 lakhs. So I have had this question asked to me by many people कि डॉक्टर साहब हमारी 5 लाख की इंश्योरेंस है, बंदे ने 1.5 लाख का केस किया है, दे देंगे? My dear sir, if you don't defend yourself for that 1.5 lakhs, it is within the court's powers to award 20 lakhs. And then you will say, I didn't get a chance to defend myself. The courts are within their powers to give compensation what they deem fit, even more than what the patient has asked for. And look at the difference between 86 and 2019. The punishment for failing to comply with the orders of the commission. We have had a doctor in Chandigarh who was awarded 2 years jail sentence because he didn't pay the compensation which the consumer courts awarded. This has been increased in CPA 2019, e-filing of complaints. Not only can you order on Zomato, you can also file a case against me, probably by the same mobile phone or the laptop you are using. This ease of filing a complaint, and if the court does not accept or reject within 21 days, it is deemed accepted. So the number of cases which can be filed have increased exponentially because of this ease of filing the complaint also. Second appeal, 2019 I'm talking about, can now only be on a substantial question of law. Earlier in CPA 1986, it was when a case had to go to Supreme Court. Then it had to be on a substantial question of law. I hope I'm right when I say this, Hitesh or Dr. Pradeep. But my understanding is, earlier you had to go to Supreme Court to fight your case, it had to be on a substantial question of law. It could not be on the facts which have already been taken into consideration by the lower courts. Now, even National Consumer Dispute Redressal Commission, you cannot go unless it is a substantial question of law. And of course, negligence तो नहीं है डॉक्टर साहब, but वो तो poor है patient. आप insured हो, इसको दे देते हैं थोड़ा बहुत. Your generosity is reported as my negligence, Your Honor, which is something I find difficult to live by. Not giving concession to VIPs was the argument given to file this case. This was Justice Verma. He was a Chief Justice, Supreme Court of India, and he was admitted in Vedanta, and 34 eminent people, including very senior advocates. I think Ramjit Phalani was also part of that. They made a complaint where, not to Consumer Court or to the police FIR or to the State Medical Council, to the Prime Minister. The complaint was made to the Prime Minister. And what is the ground of the complaint? That this hospital could provide a 24-hour ambulance for a dharna which was occurring in what Maidan? No, sir, I don't want to give Ashwini more ammunition, so I will finish it. And this case went to Supreme Court, and 10 crore compensation was demanded. It was rejected. I was just told that besides these 14 places where a complaint can be filed, Dr. Hitesh has recently has gone and defended a doctor against whom a case has been filed in Juvenile Justice Act. Now this Juvenile Justice Act is meant कि आपने 14 साल के बच्चे को नौकर रखा हुआ है, उसको बंद करके रखते हो कमरे में, उसको चिमटे से जला देते हो, उससे काम कराते हो. It is meant for these kind of cases. And here, a child who was sucking that nipple type of thing which is put in the mouth, and the doctor had placed a tape and forgot to remove it. Or somehow the nipple came out and the tape didn't. And this was the grounds on which a case was filed in this act, where the punishment is 10 years imprisonment. So there is no end to the kind of problems we are facing. even though there are a lot of legal principles according to which one case, one series of facts should not be adjudicated in different courts or twice, more than twice. But as I say, all these principles are for citizens of India, and doctors definitely are not considered citizens of this country. Everything is in addition to Consumer Protection Act, and as I've already covered, all this is new in CPA 2019, and it has made the problems worse for us. Also, 2002 amendment of 1986 had said compensation awarded is recoverable in land revenues. So if you die and do not have not made the payments which have been awarded, your estate or your heirs will have to pay that. Also, there is substitution of legal heir in case you die during the pendency of your complaint. So this has also been included in CPA 2019, and as part of Civil Procedure Code, it is already there. At least one case is there where we had. Please understand the difference between why doctors were covered was because they said, you are taking a contract for personal service. It is not contract of personal service. Contract of personal service is, Ashwini hires me कि तूने आके मेरी मालिश करनी है, मेरे घर को पोछा लगाना है, तूने, I am his servant. He tells me तूने ये करना है, मैं वो करूँगा. You are hiring, your services are being hired. Patient comes to you and says कि जी मैंने पेट का दर्द हो रहा है. You decide what treatment is to be given, and your services is what he is hiring. He is not dictating कि you treat me this way or that way. But when you look at Samira Kohli's judgment in 2008, what did this say? Ki without the patient telling you specifically that you can go ahead and do hysterectomy, you cannot do that even though you think it is in the patient's best interest. So that means I cannot do anything which my patient master has not told me to do. So it is a master-servant relationship. If it is a master-servant relationship, why am I still covered under Consumer Protection Act? Mediation has been introduced, e-commerce has been introduced, unfair contract, this will also create problems in the times to come. Validity of consent is going to be questioned. I personally don't think CPA we will survive CPA. Medicolegal Action Group had prepared a medical injury compensation bill and sent to the Ministry of Law as well as Ministry of Health and Family Welfare, but unfortunately nothing happened there. And I can only argue, but I cannot win because there is so much preponderance. The masala news to increase TRPs, hence the revenue of electronic media, the print media, advocates, insurers. We tried our level best. We went to Bombay High Court, we went to Supreme Court. Dr. Pradeep Arora also approached the Supreme Court. There was a case filed in Kerala High Court also. All of us lost the case for against inclusion of doctors under CPA 2019. And this was the bill we had introduced, sent to the government for consideration, which was not. Thank you. I'm very, very sorry I have overstepped my time.
Thank you, Dr. Nagpal, for elaborating about CPA. But I have one question, that we all know the problems regarding criminal negligence, CPA. But what's the solution?
So solution is very, very simple. You have to tell me, what do you want? You want to punish me or you want to prevent the problem from happening again? You have to be clear in your mind, because we have a series of case reports where injection vincristine, which is to be given intravenously, was by mistake injected intrathecally. Sorry, other way around. Methotrexate was injected intrathecally when it had to be injected intravenously. And vincristine, which was to be given there, was, so this was mix-up. The question is, you can penalize the doctor by awarding 50 crores compensation, all right. But you have to read that report. Over 10 years, 55 same cases occurred in 6 continents in different hospitals. So when we are having an adversarial thing, ये इसने कॉम्प्लिकेशन की, इसको पनिश करो. It is going to hide doctors becoming open about their complications so that others can learn how to avoid them. It pushes things under the carpet. I would much better prefer an insurance where it is like a medical accident insurance. You have accident insurance for...
Look, Dr. Nagpal, it's all right. It will happen always, complications versus negligence and other things. My question is, what our associations, all associations, have come to conclusion that this, in absence of legislation, in legislation we are made out of the purview of the CPA, but still courts are entertaining those cases. Still we are not sleeping and not asking what should be the...
Sir, there are three ways to fight anything.
Look, I have something to say that I demanded about this capping of the compensation. We should be not more than 5 times of the consultation fees oblique total hospital bill, which when I went for the decriminalization of the medical profession, which was put to the government, and Upchara helped me a lot in bringing that issue also, that medical profession altogether should be out of the criminal purview, from the teeth of the judiciary, police and netas. That is what our aim should be. So we should ask about the capping should be how much capping. If hospital bill is 1 lakh, 5 lakhs compensation cannot be awarded by any court, whether it is civil or it is a consumer protection act. So I think we should come to a conclusion after this conference that what we want to demand from the government so that we can reach to certain...
Sir, the same demand raised...
Highlighting problem is no solution.
The same demand being raised every 3 years does not make it a new demand. What you have asked for was raised more than 20 years ago. I have written documents of that. But when you wish to fight something like this, you have 3-pronged approach. One, which is a legislative approach. Second, which is a judicial approach. And third, which is a disruptive approach. So we have failed in our judicial approach. IMA did not support Medicolegal Action Group when we went to courts on these issues. We could have collectively gone against this. We still have grounds to again go because the grounds we covered were only legislative intent. The other grounds were still left out deliberately so that larger organizations can still take up the matter to court. Sir, all together to tab hota hai na, when I am going to court and I ask people to contribute money because Supreme Court advocates don't come cheap. I get 100 messages and out of them 3 checks I got and 97 suggestions on how to raise money. That is why we don't get together.
Let us, means the organizers are hard pressed for time, but it is very important to have discussions. So the time we will always have we will be always short of time, so the discussion must continue for at least some time, otherwise it is of no use. In continuation to Dr. Rajveer's question of capping the money or the grant, I had a question about the interest. You said 9% or 18% or whatever can be given. Why at all the interest has to be given when the court doesn't give the decision for years and years? Why we should give the interest at all? We have to fight for that.
Sir, court ne jawab, this question I asked one of the Supreme Court advocates on a panel discussion with me. His answer was, the patient needed this money, this 6.5 crores in 1997. We have given the judgment in 2013. You have benefited of this 6.5 crore for these 18 years. So you should give interest. My point is, it is not my choice. And if I have taken indemnity insurance, who is benefiting by not giving the money for past 14 years? It is the indemnity insurer. Right?
So the interest, your argument should have been that the interest, if you want from me 9% or 18%, you take that interest on the amount of the bill which was paid by the patient and what I had earned from that, not the whole earning of mine for so many years or what compensation is to be given. Anyway, let's about to finish this, but you have made it interesting. and lucrative and given good examples. What you have given about the gallbladder example, I would just read one line of the judgment which I received in my case of the judge from Jaipur. विपक्षी हॉस्पिटल एक 5-स्टार हॉस्पिटल है जिसमें मरीज के इलाज के लिए भारी खर्च लिया जाता है. So judgment is based on that. They have awarded him the compensation in lakhs of rupees. So that's what I just wanted to convey. Any other questions? Maybe two questions more. Sorry, Dr. Patidar. Let them.
One question.
But short question, short answer.
Very short. When we explained every bit of thing in informed consent, then why can't we have that I request my doctor to operate upon me, right? Once patient requests me to operate upon me, then obligation from me is over.
No, sir. Obligation does not get over. If you operate without consent, you will definitely be prosecuted. If you operate with proper consent, you may be prosecuted.
Sir, in our consent, I consent to be operated, right? It should be I request to be operated.
Sir, whatever language you use, it is not going to make an iota of a difference. We have tried different languages. There is a website. Dr. Hitesh is running a website. That is the legal consent for procedures, and anybody who, because it is to be a procedure-specific consent now.
Yes.
And the best legal consents I have found is there on their website. So I would request you people to download them, see for your own specialty and procedure, and either emulate that or use that.
Thank you, sir. We are running short of time. So we will discuss further. There is a panel discussion with Nagpal, sir.
Please, sir. Please.
We have panel discussion. You can ask
questions. That is totally different from the panel about criminal part. Sir, a small question. Negligence is a person-based. Doctor is punished for his negligence, and because of that, whatsoever compensation has to be paid should be paid by that particular person. But in a new CPA, it has been covered into revenue collection. Now, is it not against the individual's fundamental right?
It is. Answer is very simple. It is. But you have to seek, you have to seize your right. You have to approach the court to get your right. It is not brought to your doorstep and delivered. And how do you approach the court to ask for your right? You have to make an effort. You have to get good professional lawyers. You have to get people like Hitesh and Pradeep Arora behind you. And then, go ahead and as a collective group. But mind you, getting a good judgment from Supreme Court is at least 2 to 3 crore game. Do not for a moment think that your brother-in-law, his Chacha ji, knows a senior advocate, Dr. Rishi Bhatia is smiling away, but this is what we do. This is what we do. Even the case lawyers I have hired, why I have hired them? Because he is the younger brother of my senior from medical college, and he gives us a discount. Of course, even that discounted money is a lot, but...
Thank you, sir. Thank you very much. Now we are closing the session, and I would like to request chairperson to facilitate sir and Dr. Vijay Kapoor sir, Dr. Sanjay Medirata sir, Dr. Lalit Sharma to felicitate chairpersons.
हमको chairpersons को felicitate करने में आपका time जाएगा, उसमें कोई जरूरत नहीं है. We have to keep with the time, and that is how, if we are not organized in keeping time, then these problems keep coming.
बहुत बहुत धन्यवाद नागपाल साहब एवं सभी चेयरपर्सन्स. विजय कपूर साहब जो PHNHS के अध्यक्ष हैं, और मेदिरता जी जो वाइस प्रेसिडेंट हैं,
डॉक्टर ललित शर्मा स्पाइन सर्जन,
ललित शर्मा जी स्पाइन सर्जन.
And as we are running short of time, there is an announcement. I would like to request speakers to cut short 5 minutes, all the speakers.
एक निवेदन है हम आयोजकों का आप सबसे, कृपया जो समय की सीमितता है उस और विशेष ध्यान दें. कृपया अपने जो सवाल हैं वो सीमित रखें और उसके बाद जो सेशंस हैं लंच वगैरह में उसमें आप स्पीकर से इंटरेक्ट कर सकते हैं। बहुत बहुत धन्यवाद।
Over to Dr. Ashok.
Thank you, Dr. P.P. Patidar, the renowned endocrinologist and the director of endocrine sciences at Jeevan Rekha Multi-Specialty Hospital, for moderating the session in such an excellent way. Now, our next session is on preparing a conjoint defense in a consumer lawsuit, or for that, our moderator is none other than the renowned neurosurgeon, Dr. Rajendra Chaudhary. And Dr. Rajendra Chaudhary's name needs no introduction. He himself is an introduction. He was the ex-president of JARD. He is the presently he is dynamic secretary of Upchar Jaipur also. So, and he know how to manage and how to do the agitations. All these things, he has excellent role in RTS movements. So, Dr. Rajendra, please come on the stage and start the proceedings.
Thank you, all my respected guests and my friends. We are really very thankful from my bottom of my heart that it is such a wonderful meeting, and something new will come out of this meeting. Certain times meetings are there, but what is the final crux gives the significance to the meeting. So we have very esteemed lectures with the very senior people who are well versed in this medico-legal aspect of practice. Though I, being a neurosurgeon, does not know much about the medico-legal aspects of certain things, but I hope the knowledge and the information that we will gather from this meeting will really pay to us in our lifelong practice. So now I would like to invite Mr. Gaurav Agrawal. Dr. Gaurav Agrawal, sir, is actually a medico-legal consultant, as he's saying, and lawyer and professional in forensic medicine and toxicology. And sir is presently working in Venkateshwara Institute of Medical Sciences, Gajraula in Uttar Pradesh, and he has done his MBBS from Maulana Azad Medical College, and after this he did his MD DNB in forensic medicine, and I hope sir will update us regarding his knowledge. And other than this, I will invite as the chairpersons, respected Usha Shekhawat ma'am, who is the HOD of gynecology in Mahatma Gandhi Medical College. Along with that, Pushpa Nagar ma'am, he is the ex-HOD gynecology department SMS, Janana Hospital. And along with this, one more personality who does not need any introduction in Rajasthan, but it's very famous, is Dr. Omendra Ratnu. Dr. Omendra Ratnu has written a very important book, Maharana. It is a very famous book, Maharana, and he is a founder member in many of the societies who is working for Hindus who have finally migrated from Pakistan to India. So I hope these three eminent chairpersons with our eminent speaker will enlighten us with their knowledge. Thank you, sir.
Good afternoon, dear friends, and thank you, Upchar, MLAG, for giving me this opportunity. Time is short, so I'll start right away and skip a few slides. I bring greetings from Delhi, being a practicing medico-legal consultant and lawyer, and a little bit of experience in forensic. I'll be sharing my views and how. See, I'm going to discuss about. I'll come directly to the presentation, the core part of the presentation. Okay, so many things have been covered previously and will be covered in the panel discussion shortly. So, there are two things: civil negligence, criminal negligence. I hope you are aware, right? Civil negligence would include consumer, that is only for compensation. But when we talk of putting a doctor in jail on a complaint by the patient or patient's family and awarding fine from the court, that is what is criminal negligence. So these defenses that I'm talking about, that you can actually, so these are very, very practical. These are not theoretical at all. We have clients in civil courts, consumer courts, and criminal courts. Clients who are preparing their defense in medical council, state medical council or NMC, clients whose defense needs to be prepared for the not only courts of law, but maybe to the CM office, the governor's listening post, or hospital inquiry committee, and maybe social media and whatnot. So these defenses that I'm going to talk about are almost 20 of them. You can use each one or more of them according to the situation. And these are the actual statements. See, this defenses, these are not simply what you learn, but these are the actual statements that courts expect you to write as part of the legal draft or the written statement that you want to submit to the court. All right. So these are the exact statements that I'll be talking about that you can use as part of your defense. So I'll skip to, all this blah, blah, the first few ones, and go directly to, what are the exact things that you can use as your defense. So I'll start with the first one, and that is outright denial. That is, no, I do not owe any duty to the patient. Now, what are these situations when you do not owe any duty to the patient? When the doctor has not seen the patient, not visited the patient, and not consulted the patient. Duty arises even if the doctor has seen the patient for free, as Dr. Nagpal just talked about, for every government hospital. I have a case from, Patiala very recently. The doctor is from a government hospital, a gynecologist, and the case was rejected by the consumer court, but the same thing, same defenses are being used now by the civil court, for the purpose of civil court, so that she can give a good defense to the court and save her, So duty arises even the doctor or hospital forgoes a part of the fee while the patient was admitted under the care. Examples, I'll give you some examples. For example, when a patient's family requests for a home visit, doctor refuses, patient dies. So are you mandatorily required to go to patient's house to conduct a home visit and see the patient? Answer is no. But see, it is like, the gate rule. If the patient enters your chamber, then only your legal responsibility arises. Then your liability arises. If you have not seen the patient due to whatever reason, you are sick, you are under a medication, you are drunk, under a hangover or whatever, you can refuse to see a patient. Second situation is when a patient alleges that a doctor who was part of a team of doctors discussing his case on his bedside, but was not his treating physician, is implicated for medical negligence. This has happened in the past, and therefore this defense will be helpful for you. Third situation could be when a patient is consulting a specialist physician on referral from his family physician, but the patient implicates his family doctor. But the patient implicates his family physician as well for referring to the specialist for treatment rendered by the specialist physician alone for that particular condition. This has happened in the past, and therefore I brought up this example. Fourth situation could be when you do not owe any duty to the patient is when a patient has sought services only for example, measuring blood pressure, and when the BP was high, the doctor did not prescribe any medicine, the patient later died or suffered any damage or injury to his organs, and the doctor was sued. That doctor did not prescribe any medication. Of course, you have to prove that the medication prescribed was not prescribed because the patient came only for BP, right? So these are common situations. One another example lastly I would give is when a patient has sought services only for pathological or radiological investigation but not consultation, and he sues the doctor, the pathologist, for not advising treatment and falling unconscious at home when the results were abnormal. Obviously, it is not the duty of the radiologist or pathologist to prescribe medicines. So, but the patients don't understand, and then it becomes a matter of months and years for the doctor to save his, so that he could, go scot-free and save himself from this situation. What kind of duty is owed to the patient? Duty to exercise reasonable degree. I am going to heavily quote Dr. Jacob Matthews' judgment and some, other judgments which are very, very useful for, because this is what the court expects. So court expects duty to exercise reasonable degree of care and skill, as was held long time ago in this Lakshman Balakrishnan Joshi Trimbak Godbole judgment. So what are you going to write as part of your statement? That I have treated the patient as per general and approved practice. Expert opinions have been taken by me from other eminent doctors from the city, and they have also agreed with the line of management and found no negligence or deficiency in services, as held in Jacob Matthew's judgment. What is the other thing that you can say? That the standard of care that I have used is the care law expects from a doctor. Law does not expect the highest standard, nor does law expect low standards. The standard expected is standard of any reasonable, prudent medical practitioner, and circumstances in which a medical practitioner is placed always determine the standards expected from him. Because the standards in an emergency situation, they are not same as that in an elective situation. Elective, you have time to think. In emergency, you don't have any time to think. You simply have to administer life-saving measures. And it is very rightly held in Jacob Matthew's judgment that the standards in emergency are lower than that of an elective situation. I've used this defense several times successfully in many of our written statements and in criminal courts. I have treated the patient with the best of my skill and knowledge using standard expected of me. Then I have taken all care that was expected from any reasonable, prudent medical practitioner, and therefore there cannot be any element of negligence or rashness in the services rendered. You might think, why am I giving these statements? Because these are the actual statements. So it is part of legal drafting that we do for our doctors. So these are the things. It is not, see, when people come to me, they come to me, ki doctor sahab, ise hi final kar do. But many times these statements are so funny, so weak defense, and one of the most common mistakes that we doctors are making is, we are accepting our fault. We are accepting our weaknesses during the treatment. Never make a statement accepting your fault. I think somebody posted in the group very recently. So there are ways to diplomatically or legally write the same thing without showing that you are hiding the truth. Then when I treated the patient, the line adopted by me was the best option in the patient's condition. So what I am giving you is directly from, very gold standard judgments of the highest courts of the land. I observed all the precautions and adhered to all guidelines as mentioned in the Supreme Court judgment in Martin D'Souza case. It is commonly believed by, the ratio part of this judgment has been held per incurium, that is against the principles of law. But many Supreme Court and National Consumer Commission judgments are still quoting this judgment because it is only the last working part of the judgment. But there are many, many parts in this judgment which still hold true, and it is very much a law of the land, and it can very much be used. Because some people believe that this should not be used, but many Supreme Court's judgments are using this judgment as part and parcel to define what is medical negligence, civil negligence, criminal negligence. So, duty discharge according to prevailing standards, I did nothing that overruled the recommendations of the drug manufacturer. In Medicolegal Ganguly case, they gave 2 to 3 times the dose of methylprednisolone against the instructions or against what was prescribed by the manufacturer, and hence the compensation of 11.6 crore, one of the important reasons. There has been no act of commission or act of omission either by me, that I have done nothing wrong as reasonable prudent doctor would not have done act of omission, or I have refrained from doing anything which a reasonable prudent doctor would do. Then it was a complicated case, and hence in such a situation the doctor must get the benefit of doubt. This is again held in Malay Kumar Ganguly versus Sukumar Mukherjee, the Anuradha Saha Kunal Saha case. Because these are the 4 or 5 cases, the court finally merged them into one, and pronounce the final judgment, but all of them remain valid as of date. The complications, the fourth defense that I'm going to take is, are a normal part of treatment or their therapeutic misadventure, as they call legally, and which occurred in this case are well described in literature. Mind you, these are not absolute statements. You can tell me or crucify me by saying that on complications alone courts have granted crores of compensation. That is fair enough, but still that does not stop you from using these defenses. It may work for you, it might not work for you. But again, these are valid defenses, and prosecution, it is not about scaremongering. It is about showing you what is written on the wall. And what is written on the wall tells you that only, we study those cases which have gone against us. It is fair enough, but these are less than 10% cases. If you take out the statistics, 85 to 90% are those in which we are exonerated. Talking of criminal negligence punishment, it is very, very rare for doctors to go behind the bars. As a part of government duties, being a forensic professional, I would reiterate what Dr. Yogendra Malik said, what Dr. Nagpal said, that courts are sympathetic towards doctors. Ask me, I've appeared in more than 1,200 cases in criminal cases where doctors have been facing trial, and I was inside of the government, and if you look up at the judicial, see, ठीक है, उनको हम एक demon की तरह feel करते हैं, but I might be held in contempt of court, but honestly, they are there to sympathize, especially I'm talking in reference to criminal courts, okay, for punishment. They are there to help you, they are there to protect you. Sometimes a cross questioning against the doctor can go इतना cheap हो जाता है कि doctors start crying in the court, especially both genders, but mostly I want to say. So what happens is the judicial officer is there to protect you, they are there to guide you, they are there to stop the advocate from embarrassing you in front of everybody in the court. So honestly, they are going to help you. Consumer cases, of course, game is altogether, but even then I would say they are in a way sympathizing with you. Of course, they've got, it is, the law is pro-consumer, so and they think that compensation is going to be given by the insurance companies as part of indemnity, so they liberally grant compensations against you. So moving ahead, the things that have gone wrong does not mean negligence has been held in Jakamithi's case. Again, as I said, I'll be heavily using these because this is a gold standard judgment, and these are some things you cannot do without when you are preparing your cogent and logical and sensible and convincing defense in front of the court. It is not a case of gross mistake held in Spring Meadows case. No medical treatment is risk-free. Despite that, things go wrong. Yes, courts understand it. I treated the patient in emergency, and the standard I just shared with you is lower. So see, most of the, if you would ask me what are the gray areas, I would say without hesitation 3 from a gamut of cases that I've handled in the past, about 22, 23 years of experience. First is any patient landing in emergency. All patients do not come in emergency. They come for elective admission, elective surgery. Second is transfer issues. Patient being transferred to another hospital. That is again a very, very, graveyard where you can expect a complaint against you in almost every second or third case. And the third is billing issues. Of course, it is not related to medical negligence, but when they do not, just rightly pointed out, so many judges, so many advocates writing to the Supreme Court that discount nahi mila. So billing issues hai, then they are converted. So the idea is, sharing these 3 points, is that you have to be ready with your staff, your doctors to cater to each and every question, demand arising from patient's family, whether it is about billing or whether it is about transfer of patient or management of patient, whether you have to make free visits in the ICU. I would urge you to please go ahead, because doctor not being available on time or not giving enough time is one of the biggest issue that the patients in this country face. Whether it is a top-notch hospital or even a small single doctor clinic. So how you have to handle this is up to all of us. If we have to give them more time, we have to satisfy them with the with their questions. If we can do it at the point, because when does the medico-legal defense, somebody was asking, it does not start when you receive a summon. It does not start when you receive a legal notice. It does not start when you anticipate there is, when violence has started. It starts whenever you anticipate the slightest of resentment, dissatisfaction, or billing issues with the patient. It is at that point of time your first defense starts. You do not have to wait later कि वो पक जाएगा, उसके बाद फिर देखेंगे होगा तब देखा जाएगा. It is very late by the time. Ask me, I see people crying, doctors, clients coming to chambers कि डॉक्टर साहब जान बचा लो किसी तरीके से. So this is what happens with all of us. Waiving of fees does not take away the responsibility of discharging duties. If we think कि ठीक है patient का bill माफ कर देते हैं, तो शायद तो courts have used these statements in their judgments कि doctor waived of fees probably because he was guilty. So waiving of fees does not help us in any way. I acted as per my medical knowledge. We're talking of error of judgment or error of diagnosis or difference of opinion, and error of diagnosis can never be labeled as deficient services held in Supreme Court. I have added the opinion of experts. We published a study 4 months ago in the GMA regarding, there is a session by Dr. Ashwini on expert opinion. I would urge this house to very seriously go for, Dr. Nagpal was sharing a statistics in the morning, out of 74 cases, only 4 cases had that investigative process where they followed the Jacob Matthews judgment in principle. In 70 they did not. So not only that, that is as part of the investigation process is concerned, but what about expert opinion? Sometimes doctors do not take expert opinion in their favor, patients take expert opinion in their favor, and compensation is granted against doctors. So it is shameful for me as a doctor. I am not favoring my own case because I am too busy, and then I can't cry foul कि मेरे against compensation grant कर दी, मेरी तो कोई गलती नहीं थी. Approach a professional body. Sorry.
Dr. Gaurav, we are short of time, so please hurriedly come
1.5 minutes, 2 minutes. Okay. So I'll quickly end this. So contributory negligence, although contributory negligence does not have much role, and the total compensation held in many cases, Anuradha Saha case and other cases, only 10 to 25% of the total compensation. ठीक है, अगर 1 करोड़ grant किया, तो उसमें maximum हो सकता है 10 लाख से 25 लाख घटा दे, but 75 लाख से 90 लाख तो फिर भी देना पड़ेगा जेब से. But still that does not mean कि उसकी कोई value नहीं है. You still use maximum that is available with you, that can go against the patient as part of the treatment that is acquired or is not following your instructions. So vicarious liability. My junior doctor is found negligent during performance duties, but he is fully competent. For example, senior resident hai, Dr. Jacob Matthews case also, fully capable of independent decisions, independent medical practice, but इसमें भी again जो जितना junior होता है उसकी उतनी compensation कम हो जाती है. It depends upon कि major part किस doctor का है. Case that has already been decided in a consumer court cannot be filed in a consumer court or another area or jurisdiction, and vice versa for civil court. But person can still go to civil court, and Dr. Nagpal told you कि एक law of tort में वो जा सकता है consumer के अलावा भी. That is also he can take double compensation for violation of rights. One can go to civil court for compensation for medical negligence. Being a consumer, he can obtain compensation under Consumer Protection Act. Then limitation of 2 years is there, but courts are very liberal upon that. How I did not guarantee success of treatment. There has been categorically, ruled by the Supreme Court in many judgments. You can use that. A very nice defense in Martin D'Souza case also. Fraudulent concealment. I've used this successfully many times. जब हमारे client डॉक्टर साहब हमको बोलते हैं कि डॉक्टर साहब हम कहते हैं ना कि use this defense इसमें क्या है कि पेशेंट की गलती क्या थी, सपेरेसिव वेरा है, सपेरेसिव फॉल्सा है, तो उसमें बहुत सारी चीजें उसमें निकल आती हैं, नॉट ओनली इन द कंप्लेंट but in the medical records also. And the patient is fond of giving multiple complaints. पुलिस को अलग दी, कोर्ट को अलग दी, और मेडिकल काउंसिल को अलग दी. So अगर तीनों अलग अलग हैं, we are going to use all the contradictions. But doctors tell me कि डॉक्टर साहब नहीं ऐसा मत करो, पेशेंट बुरा मान जाएगा. अब बुरा मान के कोर्ट गया है क्या आपके अगेंस्ट वो? So please use this liberally, and we have used many times. And in 2 very recent cases, I filed, थ्रेट की डिफेमेशन और 2-3 चीजें उसके साथ में बोला, तो वो थैंकफुली दे बैक ट्रैक्ट. सो दीज थिंग्स, एग्रेसिव एटीट्यूड बाय द डॉक्टर इज गोइंग टू हेल्प यू. यू कैन नॉट बी सबलाइम ऑल योर लाइफ. ही इज गोइंग अगेंस्ट यू इन मल्टीपल फोरा एंड यू सी डॉक्टर साहब उसके अगेंस्ट प्लीज ऐसा मत करो. व्हाट एल्स डू यू वांट? सो आई जस्ट सेंड इट इन फ्यू सेकेंड्स. Objections on the constitution of the State Medical Council's Disciplinary or Ethics Committee. I'm sure Dr. Yogendra Malik would have enjoyed it thoroughly, but I'll skip in the interest of time. Informed consent does not give you any immunity. It is simply a contract. But yes, in a criminal court, it gives you a lot of immunity. It gives you a lot of protection, but not as far as compensation is concerned. But yes, if you do not have it, God only can save you. So my point is, countersuit of a criminal complaint against a doctor. I always give a very, very emphatic advice to all my, listeners. When the patient calls 112 to the police against you, you also, even despite that, after that, you must make a complaint to the police. You may say that this is a counter complaint. It is not a counter complaint. It is your complaint, and the police and the judiciary, the courts, the entire legal system has to answer what action has been taken against your complaint. So please remember to make a complaint to the police despite the patients having made a complaint against you. आप ये मत सोचो कि उसकी कोई वैल्यू नहीं है. See, a DCP of the police told me, and I've been using it effectively for many years now. Please take this as a very, very important take-home message. डरो नहीं, कोई डरने की बात नहीं है वायरल फीवर ट्रीट करने के लिए. सो इट इज सिंपली नॉलेज दैट यू हैव ऑफ ट्रीटिंग वायरल फीवर. इट इज अ लीगल नॉलेज दैट यू वर टोल्ड बाय समबडी दैट यू शुड complain to the police. Despite having the patients complain to the police, that will go a long way in saving you. So at the end, Novus sector intervenience, that is something unrelated, happening, and there's so many things that can really help you. And what is the value of all these? That never make a statement admitting your fault on your part. It is never pardonable. Many allegations can be wisely countered. It is the job of advocates. It is the job of medical lawyers to save you. And they'll give you such nice tips. कई बार क्या होता है, केस प्राइमा फेसी रिजेक्ट हो जाए कंज्यूमर कोर्ट से, उसमें भी तरीके होते हैं उसी बेंच से या हायर कोर्ट में जाके और फिर वापस उसी बेंच पर आकर आपको जस्टिस मिल जाए. सो देयर इज लॉट ऑफ होप. प्लीज डू नॉट लीव होप, एंड a little legal knowledge is going to save you a lot from litigations. Thank you so much for listening patiently. Thank you.
Thank you, Dr. Gaurav, for giving us very useful tips and advices. And I think it's high time that the doctors realize that they should not be misguided by the words "Aap to Bhagwan hai." I think it's high time we wake up and come out of that thing and be careful for ourselves. Dr. Gaurav, it was a very nice and very elaborative talk, and we came to know that before answering any lawsuit, this legal act against a doctor, we should know how to answer, knowing the rights of the patient and rights of us also. What are our duties? What are our responsibilities? And this SOPs, and we should give the diplomatic answer, but without hiding the very facts, because otherwise it will be a forgery and digging own graveyard. Thank you so much.
That was a very enlightening presentation, Dr. Agarwal. Thank you so much. A couple of observations. Firstly, a couple of judgments that you quoted the language used is like reasonable skill and a reasonable goodwill from the doctor. I think this is very vague and it can go either ways. So I was not very inspired by these so-called judgments favoring the doctors. So my advice to my fellow colleagues here would be something very oft repeated in our career. Keep your documents completely up to date. Do that yourself or hire an assistant to do that. That's going to save you. It has saved me all my life. I'm a surgeon, my surgical practice. Number two, communicate with the patient. 99.9% patients will never go against you to the courts if you have communicated the consequences of the surgery well to the patient. However, to end this last note on, it's a personal thing because I'm a Kshatriya and by attitude and also by caste, do not take shit from anybody. 6 months ago, they tried to throw some shit at me. Some insurance company dug out about a dozen of cases and they said that these surgeries have been done unnecessarily. And I gave them all the relevant documents. Now I was made to appear before a commission. A commission in which all these jokers with an IS officer sitting on a podium, and I was made to sit on a plastic chair in front of them. So I said, you people have no locus standi to humiliate me like this. Get me a chair and a podium of your level, if not higher than you. Because I'm higher than you by my academic qualifications, by my gray hair. So have some decency when you call a doctor to testify against any kind of a judgment. And you're not a legal court anyway. So one of the young ladies said, "Doctor, why are you so hostile?" I said, "Lady, you have not seen my hostility. I'm being very kind to you because you are a lady. You have the guts to call me and question me and humiliate me like this. You might not be seeing the optics, but I'm a Kshatriya. I'm very sensitive to all this. And I ask all of my fellow doctors to be the Kshatriya. Take out the Kshatriya in you. It's not a caste, it's a character. Do not take shit from these people." And you know what? I said, I'm not going to sit and justify any action of mine. All documents are with you. And then it's a technical thing because he said, this guy had a hearing loss and you operated for a grommet insertion. I said, "Sir, go back to your PG college and do your degree. Are you telling me that an 80-year-old patient with a nerve loss, if he's having effusion in the ear, did not put a grommet in the ear? Are you saying this? Say this." I said, "Put it in writing. Then I'll see to it that your degree gets cancelled." So take the fight to them instead of being very sheepish about us. We are qualified people. But I'll end it by saying that keep your records up to date and communicate with the patient. Your patient who has been well communicated is your best friend. Thank you so much.
So bravo on that, but just to, close the comment on the first one, would it be vague if more than 99% of cases you are exonerated by the court by these very statements?
Yeah.
Why so?
No, not at all.
Because these are, let me finish. These are the words that have been used and repeatedly being used by the highest courts of the land to save your ass. So would it still be vague?
No. I'm not very inspired by this language. That's all that I'm saying.
You know what? Don't need to be inspired. We just need to copy paste and save our ass.
That is taken. I'm saying do your job. Keep your documents up to date.
But on the second thing, I think I would like to copy and paste you in the inquiry. Bravo.
Thank you.
Any quick questions?
Thank you, Ross.
Yeah.
If anybody is having any query, he can ask.
Sir, in your presentation, it's a very nice presentation. You said that there is a duration of 2 years. So please elaborate that. When we can be sure that this patient is not going to sue us, after how many years?
Never. There have been more than 10 years that courts have allowed consumer complaints against doctors. There is something also called as a discovery rule. So in one of the cases very recently happened, judgment came 2023 last year, that the patient discovered the sponge was left after 9 years of the surgery, and they made the complaint, official complaint, another after 3 years. So total about 12 to 13 years later. But the complaint was rejected on the ground that the patient did not feel any symptom throughout that period. But had she felt any complaint and approached the operating surgeon that yes, there was a complaint, that operating surgeon did not take any action, then that complaint would have been accepted even after 13 years. So it depends upon case to case. It starts from the cause of action. That is the first point when the problem was known to the patient. So please ignore the 2-year rule. It hardly is practical. But there have been cases on both sides where the cases have been rejected after 2 years and cases have been accepted even after 12 years.
Sir, we are having lack of time, and I think we should end this discussion here only.
But I'll have to listen to Dr. Hitesh.
Sir, the thing is, for that limitation, I have filed so many cases for limitation. We are now, the National Commission said that the limitation issue has to be settled first. It is because the lawyers are lethargic. You understand that? The lawyers want to go on the merit first. You catch hold of that issue, and I'm having 2 cases at present where the limitation is a problem, and 3rd case we have just yesterday only I filed a limitation issue. And I'm raising this constantly in each and every case.
But the court says कि मेरी power है, I can always.
No, but the National Commission in the first case they said that first settle the limitation issue because he has raised it. So make a separate application of miscellaneous application and you file that. And ask your lawyer to be behind that.
And then only the case will go further.
The indemnity company's lawyers, they are reluctant on this. They say, sir, dekh lenge, hum merit pe dekh lenge. No. You just say no, put your foot down and just be behind that limitation.
That's a very great development, I would say.
And mostly you will get this judgment for this, like on 13th there is a judgment for this limitation.
That's a great thing that will be in our favor.
Yes, sir.
Great. Now
Not only that, even the party of the complainant. One case of sonography where 1.25 crore rupees were given. Recently we have read, right? In similar case at Pune, what we did was the complaint was filed by the husband, same like Nagpur. But I raised the issue that husband is not my consumer. My consumer is the one who has paid me and whose sonography I have done. The opposition lawyer was telling me, sir, मैं sign करा लेता हूँ, कुछ समझ लेते हैं. But I said no, I will not allow this, and we won that case. That case was dismissed because it was not filed by a consumer. So we are not raising the preliminary objections in the case. That is the problem.
And we are not fighting for those objections,
And
even
the
if we
advocates are friends. I was actually threatened also by the bar associations that you are taking up such trivial issues. But for us, it is great issue.
You should have told them I'm a doctor first and later an advocate.
Exactly. That is what is the case. Sir.
Great, Dr. Hitesh. Thank you for sharing.
Now finally,
Thank you
I
for
think
listening.
that we should end this session, and I would like to invite Dr. Lokesh Jindal from Bharatpur, Dr. Rakhi Yadav, and Dr. Ritu Sharma ma'am to facilitate our eminent speaker and our chairperson. Please come on the dais, ma'am.
Thank you, Dr. Rajwinder, for moderation of this session in such a scientific way. Now, our next session is going to be on the bad and ugly about hospital accreditations. And for that, the moderator is Dr. Geetika Jain. She is MS Obs and Gynae, sonologist with keen interest in fetal medicine. She is looking at his interest in medicolegal field. She did her LLB followed by LLM in criminology, and currently she is a legal advisor of Upchar. Dr. Geetika, please tell me one thing honestly. After doing MS in Gynae, sonology, इतनी हिम्मत बच जाती है कि LLB total unrelated फिर LLB, LLM सब कर लेते हो आप? हिम्मत कहाँ से लाते हो? Welcome, Dr. Geetika.
Thank you so much. Thank you, Dr. Ashok. So, इसके लिए I want to answer this question first. So, this had come up so many times in my household. And I told my children कि बेटा तुमको एक opportunity मिली है कि तुम अपनी मम्मा को कह सको मम्मा पढ़ लो नहीं तो fail हो जाओगे. So that was what has been going around in my household. that yes, I've been giving these exams for the past 5 years and I've been clearing them too. So, ladies and gentlemen, it's a great pleasure seeing all of you here on a Sunday noon. And I'm Geetika, and I would be the moderator for this session today. So, coming to the talk for this session, I would like to invite my chairpersons, my most distinguished, eminent chairpersons on the dais. First and foremost, I would like to invite Dr. Ajay Chaudhary, whose name doesn't need literally any introduction at all. He's the president of all Rajasthan Service In-Service Doctors Association, that is the ARISDA. And he's the working president of all Indian Federation of Government Doctors Association. Welcome, Dr. Chaudhary. Second in the line, but is another eminent, let me say, a very eminent personality of ours, is Dr. Vijay Kapoor, who's MD in Internal Medicine, gold medalist. He did his clinical fellowship in diabetology in Jaslok Hospital and from Mumbai. And he's the consultant diabetologist and director of Kapoor Hospital and various diabetes centers in Jaipur. Welcome, sir. You are the president of the Private Hospitals and Nursing Home Society, the PHNHS, and he has done sterling work for the same. Welcome, Dr. Vijay. And third chairperson for today is Dr. Sudhir Kumar Yadav. He is the Honorary Secretary, Rajasthan Orthopedic Surgeons Association. He is a Senior Professor and Unit Head, Department of Orthopedic, SMS Medical College, Jaipur, and with a teaching experience of 27 years in medical colleges and with 10 research paper publications in national and international journals. Welcome, Dr. Yadav. Now, not taking much time, I'm coming to my main eminent speaker for today, Dr. Arora. I would like to give a brief bio. He has literally a very long bio, but I would cut short. Sorry to say that, sir. But he did his graduation and post-graduation from Rohtak Medical College, Haryana. He has a teaching experience of 10 years and has been a thesis guide of PG students in surgery. He has headed the surgical unit in Mahatma Gandhi Institute of Medical Sciences, Sevagram, Wardha, Maharashtra. He has 21 publications in national and international journals. And his few medical allocates to his name are, he did his LLB with distinction. He always pleads and argues in courts in person without the help of any legal counsel, and which is commendable. He has been praised for his knowledge by the Division Bench of High Court and been felicitated by several organizations, that is the Association of Medical Faculties, Vidarbha Surgical Association and IMA Nagpur for legal work for the benefit of medical fraternity. Thank you, sir. He was conferred the T.R. Setu Lakshmi Award by Medicolegal Action Group for the year 2021-22, fighting the legal battle in the Honorable Supreme Court on behalf of medical fraternity. He has fought and won many famous petitions for the right of doctors. To name a few, in 2018, he got relief of mandatory 3-year registration of nursing homes from Bombay High Court. In 2020, the case of capping of hospital charges, which we all know is a very important one, it was won in the Bombay High Court. In 2021, the same case was won in the Supreme Court also. Presently, in Supreme Court, SLP is being heard on the issue of 50 lakh compensation to doctors who lost their lives in the COVID pandemic. And to sum it all up, he's also the master of chess, and he won his Nagpur district level championship in the year 2002. So let us hear this all from the man himself, all that is bad and ugly about hospital accreditation. I welcome Dr. Pradeep Arora. Ladies and gentlemen, please put your hands together. All the people in the house, I would welcome Dr. Pradeep Arora. Welcome, sir.
Thank you very much, ma'am, for this magnanimous, elaborate, and so kind of you to say so many words of praise. I deserve them in half measure, and thank you very much. And I must thank the organizers, Dr. Vijay Batra, Dr. Yadav in particular, and all the organizing team Dr. Neeraj Nagpal of Medicolegal Action Group, Dr. Ashwini, for giving me this opportunity. So, this subject I have deliberated, it is just like swimming upstream, treading uphill, because normally we take accreditation as sine qua non, synonym of quality, that it is supposed to be ultimate quality assurance tool. Can I how to? Okay. So that's wonderful. That frees my hand. So the hospital accreditation is that when a hospital lends itself to assessment by an external agency with regard to its performance vis-a-vis certain standards, which are supposed to be evidence-based standards, although there is a controversy there. You don't really, I'm not able to locate any work done in this regard. But yes, it is supposed to be evidence-based standard. And when I say bad, I mean that it is just a bad proposition. And that is a global question right now. The accreditation is being discredited in the worldwide literature. And when I say ugly, that means it's abhorrent and repulsive, that you cannot stand for a minute. You must get rid of it, because it is in violation of ethics, it is in violation of law, it's a violation of rights, and maybe it's a violation of constitution of the country. So when I am going to ugly part, naturally I will come to those accreditation bodies which work in our country, goes without saying. The dominant player is the National Accreditation Board of Hospitals and Hospital Providers, and I should not hesitate because it's my right. It's a government, it's a body which is sponsored by body which pushes the accreditation in the hospitals. So I got a right to freedom of expression to be critical about it if I feel that there is anything wrong about it. Now I go to the next. We are slave to evidence that we have in front of, whether as a lawyer or as a medical man, or as a, so what is the evidence? Any intervention that we propose on our patient, it must be evidence-based. And why not this one? Narrative review. Narrative review is one when you went through the literature, you read the literature and you draw inferences. Unlike systemic reviews where you take the abstracts, select the studies, frame a question, and then you get the answer. The level of evidence that's generated by systemic review is much higher. But narrative review, for a starter, is not a bad, is a very acceptable thing. So what does it say? 122 studies. 122 studies were taken to view, and then the hospital accreditation was not found to be effective. Then comes the systematic review. That is 2012, now it is 2015. In systematic review also, out of 30 abstracts, out of 915 abstracts, 20 papers were studied, and it was found the accreditation programs require substantial financial and labor investments and distract healthcare teams from their primary clinical goals. Accordingly, so the problem with accreditation is that it concentrates on processes, the structures. Structures means your staff, their qualifications, equipment, the gadgets, infrastructure. Process means what way they function. So the concentration is more on compliance with respect to structure and process rather than outcome. Outcome, in fact, is the third part, which should be the most important part, but is heeded the least. In accreditation programs, usually this part is ignored. The mortality rate, the morbidity rate, 15 days readmission rate, 30 days readmission rate, mortality rate, and all this, the number and patient experience, all these markers which should be part of outcome are not given due importance. And that's why the accreditation becomes faulty, and that's why when you have systematic reviews like this, you find you have the findings which are contrary to our popular notion that it is a quality intervention. And I will read the upper half of this. In summary, we found that the proven role of the accreditation and certification is important in improving patient care. Patient and organizational outcomes remain largely undefined. Accreditation and certification is a thriving industry, and there are many interested stakeholders who may profit on promoting these services despite the lack of robust evidence of their effectiveness. So this is actually what I am trying to say, that vested interests have developed which are sustaining this industry. But if you look at the literature, now there is no hardcore evidence to back the thought that hospital accreditation is really effective in terms of ensuring quality. So finally, hospitals are expanding resources, and this is the lamentable part. And all these studies which I am telling you have been taken into consideration by WHO when it formulated its perspective in 2022. So this is the Cochrane review, and the results are similar. Since that time has been reduced, so I will not go through the key message, but the message is same, that it is not effective. Now, this is a observational study, not a review, but highly powerful study. 3,337 hospitals were included, and 88% were the subscriber to Joint Commission Accreditation Program, and few were from other accreditation bodies. And there was a third category which was non-accredited and were subject to state survey program, which is akin to having state certification here that we have in our country in different states, including Clinical Establishment Act and other nursing homes which are in force in states. So the findings, the conclusions, again, I am cutting short. Conclusions are same. Whether this accreditation body or that accreditation body, doesn't matter. A small difference was seen in 30-day mortality, but not statistically significant. So it does not matter whether the hospital accredited all parameters, and in this study, only outcome measures were taken into consideration. So it's not effective. Now it is a proven thing. Now next week, this is the WHO. Again, I will have to cut short, but the bottom line is, not much evidence is available whether it is cost effective, cost efficient or not. But where evidence is available, it outlines concerns that participation in accreditation program consumes considerable financial resources with an undetermined return on investment, and in resource efficient country which is still aspiring for universal health program, you have to be very economical, frugal and prudent in what you are spending on. In any case, ethically, we are responsible for what we are spending on behalf of patient. We take from patient, spend money. We have to do it prudentially as if it is our money. After all, it is going to be borne by the patient, our poor patients. It is violation of professional ethics if we don't. Now, WHO perspective, I have told you, I will not go into this because the time has been reduced. After this, there was, this is a umbrella review which came after this. Findings are similar, but it remains that there is insufficient evidence. Umbrella review, reviews of reviews, master review. It remains that there is insufficient evidence that hospital accreditation improves hospital quality and positive impact should be interpreted with caution, considered only as associations. No statistical significance has been located. There are other articles too. I will have to cut short. And this is debunking the myth of healthcare accreditation. It is in reference to Joint Commission, whose accreditation program is comparable to full accreditation program of NABH, but not the entry level, and I will come to that hoax part afterwards. Now, Denmark has abandoned accreditation for this reason. 205 to 2015 was their era of accreditation. Now they know that this leads to drowning in manuals and paperwork and have no time for patients. So they have abandoned it. Now this is the cost part I am coming to. This is NABH program. I think most have you experienced it first time. The fee is stupendous. You can't really justify it. It is extortion, it is exploitation, it is exorbitant. So even for the smallest, you have to pay, first of all, 3,000 just to know that what the brochure is about. It is not freely available. You could easily download it. It should have been available for free. But you have to pay 3,000 for that, and that is just, you are just beginning. Application fee is 25,000. For the smallest one, even if you are having 7 beds, you will have to go through this. And then annual fee is 1,10,000. I don't know what it is for. And this is just annual fee. That will recur every year. Then virtual assessment fee, initially. Then there will be surveillance, pre-surveillance assessment. You have to, pay the assessors, and you have to look after their boarding, lodging, etc., everything, which count. In fact, what is mentioned here, according to studies, it is 77% of the total amount of burden that is put on the healthcare provider through the accreditation, because you have to employ people to meet those standards and resources, and all in vain, because it doesn't translate into real advantage as I showed. So these are the band-aids for the assessors, which would be which you will have to pay for. So this I have gone through, this I have mentioned, and then on the top of it's all with 18% GST. Please increase that amount also when you are looking at all this. And you have to sometimes contact the agents. For all you know, they might be fly-by-night operators, because it's a very complicated, cumbersome task. So you employ some professional, there's an additional fee you have to. Mean to say, that is a lot of economic burden. If it was equally useful, then maybe that there could be debate, it is needed or not. But when it is not cost effective at all, putting it on the patient, because it is being put on the patients, they have to pay for it. It is purely, it is unethical. But it is not just in terms of money. The previous slide shows that in terms of effort, time, the resources that you have to recruit, all that adds up to a big value in terms of cost. Now, High Court said in Delhi, when in case of violation, said that why public hospitals are not accredited? Why? Article 21, citizens also need it. So all Delhi hospitals should get accreditation. So it came back to them. And then all institute and all primary institutes, I tell you, they are not accredited. They have started doing it after this judgment. All institute, and they are considering only entry level. And I will come to this point that actually is a hoax. There is a caricaturized, accreditation. It's not true accreditation, because the number of standards and the objective elements have been reduced drastically, and it's a mockery of the true accreditation program, which we compare with the Joint Commission and then claim that our standards are of meet the world standard. So after that, All India Institute thought of entry level. Now they are having certification with respect to certain departments. Yes, when you get the certificate, you get the entitlement to put the logo, which falsely claims patient safety and quality of care, which I have shown through the studies is actually not a truth. Now, I am from Nagpur, and it's a cause of pride for me that All India Institute Medical Science in Nagpur was the first one to get the accreditation. But then for a moment, we had to pause and think that if it makes a news, that means that most of the public hospitals are not accredited, and that is a fact. About Bhopal also, there was news few days back. So only few, and this is the chart which I have taken from the NABH portal only. Brown bar stands for the private hospitals, and invisible, smaller, figure 16, 0, 18, belong to bars which have not even begun from the baseline. That belongs to public hospitals. This is the comparison of the private versus public hospitals which are accredited in each category. So only 1.37%, 0%, 1.7%. So these are the small, minuscule percentage only is public hospital. Why double standard? If it is a quality assurance tool, then public doesn't deserve quality healthcare. No, we know that it has got no relation with quality. We just want to push on private hospitals, make their life difficult, and since this program, accreditation program, NABH, it's a Constituent Board of Quality Council of India. This is this has been started on the instance of cabinet and has got the government backing. So it got to be protected, and that's why it is put on private hospitals. There is one more, this is the National Quality Assurance Standards, which is also accreditation program, reserved only for public hospitals. So only for district and smaller hospitals, not for the tertiary hospital. Now I will come to the last part. This is not the last, as semi-final, that there is accreditation mark. I have to say lot about this. Austerity is observed according to our medical ethics. You may be very good surgeon, very good veteran in your art, but you can't write skilled surgeon, safe surgery, etc., and make a logo. A picture is worth 1,000 words. And if you put in the outer circle red prominently patient safety and quality of care, which is not supported by literature, if you propagate a falsehood, tell the patient that, put out false claims of, quality to the patient, it is criminal because the consent gets vitiated. The patient takes the decision to get treatment from you, the surgery from you because you claimed it. It is visible. So, the consent gets vitiated, and basically you have done a procedure without the consent. The difference between surgery and assault or battery is of one consent only. The difference between conjugal bliss and rape is only of one consent only. And if you make wrong projections, that is really an offense. It is not negligence, it is offense. It is not criminal negligence, it is crime. So no judgment protects you from this kind of thing, misrepresentation. Now it doesn't end there. Surprise, yeah. In 2005, when they started it, there were not many subscribers. There was slow uptake because meeting the standard was very high. The country was actually not ripe for this kind of program. It is a luxury. And then they started pre-agreed program where the standards were reduced to 1/4, objective elements were reduced to 1/4. It was a mockery of the original accreditation, but it caught up very fast for two reasons. Because it was linked to entitled for empanelment. Insurance companies were giving entitlement very easily. In fact, IRDA made a rule in 2018 that NABH accreditation is a must. Later on, it was retrieved after 2 years. But then the subscription rate increased steeply during those 2 years. And then what they said, they were full scheme that there will be NABH program, and since it's a continuous program, it is entry-level thing, and then you will go to progressive level, and then from progressive level back to accreditation. It never happened like there were very few subscribers for the progressive level. People remained at entry level forever. The entry level itself became a distinction, and it was treated at par with the full-fledged accreditation program. Pseudo standards have been created. This is unfortunate. Now, various certifications were created and picked up also. The reason is simple, because you get that interesting, that very useful logo mark that you can put your stationery all over boards, patient safety, quality outcome, and you can dupe your patients with impunity. Law is permitting it, right? As against your medical ethics. Now, these are the accreditation marks. By the way, in US, this Joint Commission from US, the advertisement is not as much prohibited. The criteria are not as strict in the ethics as in our country because of the education level, the emancipation level of our country. But they write modest approval. But in our case, safety, quality of care, etc., etc. And that too, whatever certification, even if you are pre-accredited, you will have a better accreditation mark with a broader font of patient safety, quality care, and entry level is reduced to very small font. So it is very clear that there is a deliberate attempt to create illusions, dupe the patients, and create false standards, double policies, public hospital versus this. So this is all ignominious. Let me take a minute. So then later, there were objections that it is not accredited. What do you mean pre-accredited? Pre-medical cannot have same liberty, same autonomy as the full-fledged medical degree. So they removed the word accredited. Now those who are at entry level, they are not accredited according to terminology of NABH itself. Now they are certified. So, and some people were very innovative, making the perpendicular so that it looks like accredited. Big hospitals were proud of this achievement rather than they had nothing else to show off. But this is to be shown because this is the stamp of patient quality and healthcare. So we are disseminating sham and falsehood in healthcare system, and we are pursuing altogether false standards. So now again same story here. So other certifications, but you have that ring of patient safety and quality of care which is not borne out by the ladies. Very clearly NABH mentions that it is to increase the footfall. You can read it. Now these are the problems. Accreditation is not voluntary. IRDA has made a rule. I told you, government schemes, insurance companies, we know about CGHS controversies going on. Hearing would be there day after tomorrow on 10th. And CGHS rates are more for the NABH. So they are promoting and obligated by court also. When you will not place this material before the court, what I am telling you, how the court would know? Naturally, they would say that if something is meant for quality assurance, why it should not be passed on to public hospitals? So that's why this judgment. But somebody has to go there. Somebody has to explain to the court that, well, this is all hogwash. The literature doesn't support it. Now, what is bad? I have told you systemic reviews don't prove the efficacy, doesn't measure up to outcome indices. You are concentrate on processes only and compliance with that. No evidence of less medical errors. So what you have to set up checks and balances. But if the medical precision itself is not evidence-based, what the medical errors will do? So there is no control over that. WHO perspective is equivocal. Shall lead to more litigations. Yes. You know, a patient would say that I have been harmed because they didn't tell me that their hospital is not NABH. On the contrary, other patient would say that this is the NABH hospital and yet I was harmed. So their projection is wrong. So both ways, you are, the chances of litigations are more. And then it is not voluntary. Accreditation by very concept is to be voluntary and double standard high cost anyway. And what is ugly? Deceptive bogus claims through marks, entry-level certification, pseudo standard, creating monopoly that I told you, and that's why they exploit so much. The fee is so tremendous, and there is no competition. In US, you have 50 accreditation bodies. There is a competition, so the cost comes down. You're surprised what we pay here, accreditation, NABH. Similar are the charges of Joint Commission in US. If you convert the rupee into dollars, it is surprising because if you look at the treatment cost, it is 100 times less as compared to what it is in US. So, abuse of accreditation as promotional tool is no longer a quality assurance tool. It is a promotional tool. And once I contract, I didn't discuss about it much because of paucity of time and whether legal issues. So, conclusion, what do I want? Do I want that accreditation will go? No, I am not saying that. Nobody is saying that. You cannot throw a baby with the bath water. You have to retain the baby. What we want to say is that the paradigm of accreditation program has to be changed altogether. It has to be outcome based, and those parameters which are assessed right now, these are misplaced, and accreditation programs have to be revised. And you, anyway, it has gone blank. Anyway, so you have to accreditation programs have to be improved and have to be more relevant and pertinent to the problems, and there should be flexibility to customize according to the joint. The element of self-accreditation has to be promoted. Monopoly should go. Voluntariness should be, and monopoly and voluntariness can succeed only when you stop making wrong rules that it is a must for insurance or it is a must for higher rates, etc., etc. So no incentivization can be done for a promotional tool which has got absolutely no basis as far as merit is concerned when we study the literature. Thank you very much.
Thank you. मैं बोलूँ एक second?
Please, sir.
With the permission of the moderator and the speaker, this topic is actually very close to my heart, and I have been very vocal about it. मैं 5 minute लेना चाहूँगा क्योंकि this is being the president of an organization which includes all the hospitals. This is something which affects each and every hospital, and we have been discussing and debating on it for a long number of years. Before that, I come from a distinct school of thought, a distinct ideology, and a distinct organization called Private Hospitals and Nursing Home Society. And it is a pleasure to note the same ideology is similar to what Upchar says. So I wish and foresee a synergistic sort of activities in coming times with both PHNHS and Upchar. Number one. Number two, ये जो NABH वाला accreditation है, the point is, जब हमने hospital start किया था, there was nothing of this sort. Then there was a time गिनती के इक्का दुक्का NABH accredited hospitals होते थे, ऐसा लगता था कि बहुत अच्छा है, और वास्तव में अच्छा होता था. Now you see every hospital at every nook and corner of the city, even at smaller semi-urban and rural areas, which are now so-called NABH accredited, or as Pradeep ji rightly pointed out, pre-accredited or pre-entry level. This is a farce, a big farce. Why? Because जब से NABH चालू हुआ, 3 कैटेगरीज हमारे सामने आ गई. एक तो आए NABH कंसल्टेंट्स, सो कॉल्ड NABH कंसल्टेंट्स. ये वो लोग हैं जो डॉक्टर नहीं बन पाए और उसके अलावा भी कुछ नहीं कर पाए. सो दे became NABH consultants, NABH advisors, NABH trainers. These people are now training the hospitals and doctors to get NABH accreditation. Then came the second category, NABH assessors. ये वो लोग हैं जिन्होंने कभी अस्पताल नहीं चलाए, ज्यादातर लोगों ने. इनमें से कई डेंटिस्ट हैं, कई आयुष के लोग हैं, कई मैनेजमेंट के लोग हैं, जो आके आपके अस्पताल को असेस करते हैं कि whether it is suitable for NABH accreditation or not. And the third category is the NABH organization itself. इस NABH की sanctity क्या है? The signatory on the NABH certificate, I am told, is a government doctor working in a government hospital who is certifying your hospital, a private hospital, for NABH accreditation, जिन्होंने शायद अपना खुद का अस्पताल शायद कभी नहीं चलाया होगा. So what is happening? आपने कॉस्ट बेनिफिट की बात करी, इसमें बेनिफिट किसको हो रहा है? पेशेंट्स को नहीं हो रहा है, डॉक्टर्स को नहीं हो रहा है, हॉस्पिटल्स को नहीं हो रहा है. इसमें बेनिफिट हो रहा है एम्पैनलमेंट्स के लिए जो ऑर्गेनाइजेशंस हैं, एम्पैनलमेंट्स के लिए जो गवर्नमेंट कैटेगरीज हैं, RGHS, CGHS, चिरंजीवी, आयुष्मान, और उसमें who are benefiting, who are gaining, who are filling up their pockets are these people, the insurance companies, the organizations जिससे आप एम्पैनलमेंट करा रहे हैं. तो फायदा डॉक्टर्स का नहीं हो रहा है, अस्पतालों का नहीं हो रहा है, इन लोगों का हो रहा है. अगर आपको सर्टिफाई करना है, क्वालिटी सर्टिफिकेशन देना है, तो आप डॉक्टर्स को दीजिए. I have seen कि वो जो अस्पताल का इंस्पेक्शन करने आते हैं, इंस्पेक्शन करने के बाद 3 साल का जितने टाइम का ड्यूरेशन होता है, उस अस्पताल में कैसे काम होता है. वो एप्रन भी नहीं पहनेंगे और टीम के सामने बाकायदा नाम लिखा हुआ पूरा ड्रेस रहती है. उसके बाद 3 साल तक स्टाफ एप्रन भी नहीं पहनता है. और वहां पे आके एक्रेडिटेशन की टीम क्या देखती है अस्पताल में कि इस प्लास्टर के बाहर से ये बिजली का तार बाहर दिख रहा है. सो you have to rectify this. This is what NABH accreditation is. So my submission is, this is a farce. This has to be demoted. इसको प्रमोट नहीं करना है, और हम सबको मिलकर ये प्रयास करना चाहिए कि इस तरह की जो चीजें हैं, क्योंकि इससे सिर्फ अस्पतालों में डिवीजन होता है, पेशेंट्स गुमराह होते हैं, और अननेसेसरी खर्चा अस्पताल का और डॉक्टरों का कई गुना बढ़ जाता है. थैंक यू सो मच.
Thank you, sir. I would like to thank Dr. Pradeep. Sir, please stay there on the dais for felicitation. And your talk was a real eye-opener. Like you told about the private and public practices, there are double standards. Before the felicitation, I have an important announcement that there's a vehicle, RJ14 UD 8277. So this car is there, this vehicle is there in the basement. Another one, 23BH 3575C. So the owners, please take care. There's some difficulty which the others are facing. So please take care of that. So now I would like to invite Dr. Gaurav Gombar, Bikaner Upchar President, Dr. Kundan Dan, who's the Barmay Upchar President, and Dr. Sohan Kumawat, Secretary Sirohi Upchar. We all remember Dr. Kumawat had gone for a 7-day hunger strike during the RTH. So I welcome all of you to kindly felicitate the speaker as well as our distinguished chairpersons. Would the house be kind to give a round of applause? Thank you all. Thank you all so much. It really it boosts up the morale of everyone. Thank you so much. There's a lot of hard work that goes into organizing such a summit, and the speakers, the chairpersons, the organizing persons, and of course the most important delegates. All of you are very important to us. Thank you all for joining us today for this session. Over to Dr. Ashok Garg.
Thank you, Dr. Geetika, for the excellent moderation. Now our next session is on the prevention medical negligence, judgment on the pain of modern medicine, and that is the topic is none other than my esteemed teacher, Dr. S.G. Kabra sir. Dr. Kabra sir has to be the one of my first teacher when we entered the SMS Medical College in January 1993. He was first to take our class of anatomy. And one more thing I would like to share. सर की क्लास होती थी, फुल स्ट्रेंथ होती थी, फिर भी कुछ बच्चे शैतानी कर लेते थे, तो सर का एक छोटा सा स्टेप क्या अवकाश लगा रखी है, पिन ड्रॉप साइलेंस एंड टोटल साइलेंस और सर की क्लास होती थी. सर आई जस्ट वांट वन मोर थिंग, जब 1 साल के करीब कंप्लीट हो गया तो जूनियर्स का टाइम होता था आने का और मेडिकल के लिए आते थे ना कॉलेज में, तो पता था सबको कि बच्चे क्लास अटेंड नहीं करेंगे, जूनियर से रेगुलर चले जाएंगे. तो मैनेजमेंट स्पेसिफिकली का पर्सन की क्लास लगाता था कि कोई भी बच्चा क्लास अटेंड, सारे बच्चे क्लास अटेंड, कोई भी बाहर नहीं जाए, और वो होता ही था. तो विथ दिस नोट आई जस्ट वांट टू टच योर फीट अगेन एंड फॉर दिस सेशन सर प्लीज हैव सेशन. We have the excellent moderator, Dr. Buddhi Prakash Sharma. He is the professor and head of the plastic surgery department at Mahatma Gandhi Medical College, and he is running his Cosmos Super Specialty Hospital. And he has also written one book that is called Narendra Se Narendra Tak, and he delivered the book to our honorable Prime Minister, Dr. Shri Narendra Modi ji, and that's a great honor for us. और एक छोटी चीज और बुद्धि के प्रकाश के बारे में बताना चाहूंगा. डॉक्टर बुद्धि प्रकाश और डॉक्टर विवेक साबू ने जो आरटीएच के टाइम जो फूड पैकेट्स का अरेंजमेंट कराया था, दैट वाज एक्सीलेंट एंड एवरीवन एंजॉयड इट. और मेरे जैसे कुछ लोग तो आते ही से कर में थे कि वो फूड पैकेट खाने के लिए. ओवर टू यू डॉक्टर बुद्धि.
सभी बड़ों को प्रणाम, दोस्तों को नमस्कार. आज जो उपचार और मेडिको लीगल एक्शन ग्रुप ने जो नेशनल मेडिको लीगल समिट है, ये अपने आप में राजस्थान में पहला और अनूठा प्रयोग है, जिससे कि हर चिकित्सक, चाहे वो प्राइवेट हो चाहे सरकारी चिकित्सक हो, इन मेडिको लीगल केसेस से प्रभावित होता है. तो इसके निदान के लिए सभी डॉक्टर्स ने मिलकर ये एक अनूठी परंपरा शुरुआत करी है. इसका हम सभी तहे दिल से स्वागत करते हैं, अभिनंदन करते हैं. मैं अब आमंत्रित करना चाहूंगा चेयरपर्सन डॉक्टर DS भुल्लर, एक्स प्रोफेसर एंड HOD फोरेंसिक डिपार्टमेंट गवर्नमेंट मेडिकल कॉलेज पटियाला. ही इज प्रेजेंटली वर्किंग एज MM मेडिकल कॉलेज अंबाला एज ए प्रोफेसर एंड हेड. डॉक्टर DS भुल्लर सर. सेकेंड चेयरपर्सन आई वुड लाइक टू इनवाइट डॉक्टर जसपाल धमीजा सर. ही इज एक्स डायरेक्टर हेल्थ एंड मेडिकल साइंसेज जयपुर. डॉक्टर जसपाल धमीजा. Next chairperson is Dr. Lokesh Jindal Bose. He is IMA President Bharatpur, urologist and presently treasurer in Upchar State Executive Committee. Dr. DS Buller and Dr. Jaspal Damija. Now I request Dr. S.G. Kabra sir to deliver the lecture. Thank you.
We are running short of time, so I'll straight away come to the topic. The main thing I am so happy to see, I am in this medical legal business for last 36 years. And I am happy to see that now so many senior doctors are taking interest into it. And some of these doctors have acquired legal degrees also. But what I would, and I hope, कौन सी है? नहीं, इसमें से नहीं होगा. ठीक, it's all right. It's all right. Now, the main thing that I would like to say is, please, for all these speakers I have heard and all these ones, a physician practices bedside medicine. He doesn't practice law. And don't force him to practice law over there. It has completely distorted. That is what has been done. That is what the CPA Act has done. And that is what has totally distorted this one. And your narrative also that I would like, that your narrative should also change now. The medical jurisprudence, negligence, medical jurisprudence, the narrative should now change with your acquiring legal acumen. What I mean by that, from medical negligence change, approach that has to be changed is from legal interpretation of medical provisions. That is what you have been doing. From legal interpretation of medical provisions, you have to shift it to medical interpretation of legal provisions. Medical interpretation of the law. Now remember this one, the judicial officers are lay persons. They do not know anything about medicine. They do not even know anything about the human body or its organ. And you have to therefore assist them in taking the decisions. Now, I'll come to some of the judgments in this one. The perverse judgment, that was the basic one, was there. What is a perverse judgment? A perverse judgment is based on no cogent findings. When there are no cogent findings are there, and based upon the conjectures, and ill-applied legal fictions and legal principles, the so-called legal principles. That is what we have been talking about. That is considered as a perverse judgment. And this term that I use, perverse judgment, it is not my term. It is used by the courts themselves, that where there is no cogent finding, and this has been done, that is done. Here are some of the examples of the perverse judgments. Now, V. Krishna Rao, one of the lead judgments is there and presently being followed. Now, let us see. The court's observation in this case was, the patient was a simple case of malaria, treated for typhoid, not for malaria. Now look at the medical interpretation. Let us go to that one. This was a case of falciparum positive patient with 3,900 cubic millimeters of the leukocytosis, ARDS, disturbed liver functions, and yet the findings of the court was that it was a simple case of malaria. Now the evidence on record over here, you see, initially the peripheral blood film, what I am talking to you, we should talk about medical aspects of this one, not legal aspects. Right. Now the initial peripheral blood film in this one was negative, and later on it was found to be teeming with parasites. Meaning thereby, and as you know it very well, that in case of the falciparum malaria and especially the cerebral malaria, these parasitized RBCs are incarcerated into the peripheral blood, and they are not incarcerated in the peripheral circulation and are not available in the peripheral blood film. Now, the later smear showed that it was an MP there. The other tests that were there that you would see, there is a severe leukocytosis there is a liver function tests are disturbed over there, and there is an ARDS is there, and even then they are calling it is a simple case of malaria. Simple. The patient suffered, the fact is, the patient suffered from life-threatening bacterial infection and cerebral malaria. That is a deadly combination. Now, court's observation in this case was that the patient was treated for typhoid and not for malaria. Typhoid and not for malaria. Look at the treatment. The patient was treated initially when he came in a critical condition. The patient was treated with injection monosafe, injection cefran, and injection chloroquine. Now, broad spectrum antibiotics have been given. They do cover the typhoid also, but that is the standard one is there. But even then, the interpretation of the lay judicial person was that it was the patient was treated for typhoid and not treated for malaria, while the fact is, and that is on the record, is that the patient did receive injection chloroquine. Now, this was based upon the lack of the proper appreciation, because the layperson is there. If you ask me, this is one of the most perverse and stupid judgment. But the unfortunate part is that it has not been criticized. It has not been criticized on medical grounds. And these fellows, this judgment in this Justice Ganguly, the arrogant that he was, ignorant and arrogant that he was, he said that there was no need, and there is no need for expert evidence is there. We are competent to do so, and this is the level of their competence is there, and this is what should be challenged. The court's decision that no expert assistance was needed or called for is what has resulted into a gross injustice, and that is being, and they had the audacity even to call that those earlier judgments where they said that the expert evidence is needed, they are in curiam. That means they have they did not know the law, and without the proper appreciation of the law, they have it. Now, the judges, as stated in the Supreme Court judgment, they are laypersons are there. Expert medical inputs must be insisted upon in every case. We must insist medical inputs should be insisted upon, and the medical evidence adduced to aid the judges. Adverse findings must be supported. Any adverse findings that is there, the opposite party must put on record a medical opinion on that one, on the medical expert. Now take another example of this case. This was a Hershey Springs disease, a ganglionic segment, as you know it very well, that it is the child was detected in the early childhood, and it is assessed, the segment that is aganglionic, that is assessed, and it is resected. Now in this child, the treatment was not given, and it was a late 14 years child that was admitted. Now, one thing that I would like to emphasize right in the beginning is, any of these diseases, now this Hershey Springs disease, aganglionic segment, how do I communicate anything to any of these judges? They don't know anything. How can I can give a judgment in such a case? And in this, and look at I'm coming to this one. Now in this case, it was a 14-year child. The entire gut was loaded with accumulated hard fecolids. Virtually it was a septic tank, not responding to anyone. There was a gross malnutrition was there. The hemoglobin was just 4 grams deciliter. He was given 20 units of blood components, blood components, did not respond, deteriorated and died. And look at the judgment. The judgment over here, Dr. Nakwal, the judgment over here, the judgment is that And look at the audacity of the judge, that it was a simple, and this is in the judgment, that it was a simple case of malaria, should have been referred to Ayurvedic physicians who would have treated it with enema. Anemia, the learned judge now says, anemia is very common in this country, and this is in the judgment. This is very common in our country. Ideally should have been treated with, can be treated with iron and folic acid. Why did you give 40 units of blood? Now look at this type of judgment. Is this a judicial decision? That was another. Now I come to the Jacob Matthew case. Jacob Matthew, the celebrated, oft-quoted, and love of the majority that I have been saying. Now this is a legally excellent and superb judgment. Though I have my reservations. What about medically? Let me come to, this was a case of, this was a terminal cancer. Terminal cancer. Terminal cancer patient was admitted in a private hospital for end-stage hospice care. End-stage hospice care. The patient was admitted. The patient, after a week's treatment or then, the patient died. What is the allegation over here is that the oxygen cylinder was not available and patient died because of oxygen deprivation. Now, medically speaking, pure oxygen, what was it? The patient arrested. So what should have been done? CPR should have been done. CPR is done at room air. It doesn't require any pure oxygen or oxygen cylinder. It doesn't. Now, the second aspect of this one, it was a terminal cancer patient admitted for end-stage hospital care. In these cases, we do not resuscitate the patient when he finally arrests. They are usually on what is known as the DNR or do not resuscitate order, do not resuscitate order. They are allowed to die a peaceful death. Now, let me ask you, the case was initiated, magistrate court. They read in it the prima facie evidence of criminal negligence. Now, let me over here say, and I have been hearing this, there is nothing like criminal negligence or civil negligence. Criminal liability is there or civil liability is there. Okay. Anyway, they read the what was the prima facie evidence in this case of a criminal negligence for which the doctor was prosecuted for 10 long years. Even the Supreme Court was entertained this one. Now, what I don't see is medically, how can this be there? Medically. Anybody who is well versed or has the basic knowledge of care of the terminal cancer patients would see that there was nothing wrong. It was the best thing that could have been done to the patient. Yet this one, and we celebrate this judgment. Supreme Court. Now, that was to give some of the examples. I have collected a large number of these examples, and their perverse judgment, that is the book that is published over here. Now, what I come to is, what we have been claiming is, claiming exemption from liability for the acts we do. Now, I would like to bring to your notice over here, there are statutory provisions that provide exemption from legal liability. Statutory provisions are there. We must insist, we must see, and we must seek, and this is our right. There are statutory provisions are there. There are the statutory exemptions and exceptions that are there. The language over there is, now offense. What offense does a doctor commit while treating a patient? Some bodily harm. Some bodily harm may result, then it becomes a negligence. Now, over here, this, but now what are the offenses? Offenses is injury, grievous hurt, or death. Grievous or death. Now all these exceptions that are there, which I will be quoting some of them over here, they are available for every offense. Every offense. And if that is proved, in that case no offense is committed. Now, the basic doctrine is good faith. Good faith doctrine. The law is, and that is what is stated over here, that anything done in good faith is any consequences of an act of a physician which is done in good faith cannot lead to an actionable claim. It is no offense. It is not. The doctrine of good faith is the prime premises where this one, good faith. And that is what we should claim. We should insist what a doctor is doing in good faith. He is doing in good faith. He is not a good faith as it is defined over here. Now, that is what how is the good faith has been defined? That it should nothing is in good faith which is done without due care and attention. Now this is where the trouble arises. Care, duty to care. That is your Jacob Matthew case and all that one. Duty to care. Now this is a legal principle, excellent legal principle. That is all right. But what does it exactly mean? What do I show that I have cared for this one? Now care is their concept of the care is what they expect would be done to him if they have gone to the physician. Now please, here you have to insist. Care for you, I am obliged. Duty to care is there. Yes, I am obliged to attend on the patient. Now what is the care? To attend to his medical needs. That is the care. And I can certainly show that I have attended to the medical needs of this one. So the care has to be redefined, not their legal notion or legal concept or legal fiction of the care. Care is fulfilling the medical needs of the patient. How do we do it? By examining the patient, listening to the history, examining the patient, diagnosing him, and so the diagnostic and therapeutic needs, if they have been fulfilled, then I have cared as per the law. Now, how do I justify the court? See my record, in the patient record that is there. So the best thing is that to satisfy that I have done it with due care and attention is my record, which shows that I have attended on the patient, diagnosed and treated him to the best of my ability. Now remember this one. What you are penalized and the offense is the injury. Injury as it is defined, injury should be illegally caused. It is only an injury to be an actionable harm must have been caused by illegal act. I am sorry. I think I'll just read out the heads of these ones. So the injury to be actionable harm must have been caused by illegal act. A doctor's act is never illegal. A qualified physician, qualified licensed physician treating the patient is never illegal. And immunity to judiciary on the basis of the good faith has been granted. Similarly, on the basis of the good faith, the doctors should also be granted immunity for their medical acts. An act justified in law is no offense. This is the treatment that is provided by the doctor is justified in law, and it certainly is not an offense. These are the exemptions that we should seek and insist in the court. An injury caused by accident or misfortune, or what is said is the error of judgment is no offense. Now every act of the physician is a judgment. The diagnosis, the treatment that you have given, there is all judgment is there. You might have made a mistake. You might have erred in it. The error of judgment is not there. or what occurs because of the accident or misfortune is not. Now the grievous hurt. Now the grievous hurt is defined over there, grievous hurt. But the grievous hurt, for instance, removing a limb, removing a body part, these are all grievous hurts are there. They are offense. But you do it every day. You do the amputation, you remove the kidney, you remove all these ones. Now, because they are permitted in law, they have been done with the consent of the patient. So the acts intended to cause bodily harm, including they are exempted as per this one. Harm caused by competent person who seeks consent, consents for it. Even the grievous hurt can be done, short of the grievous hurt, injury can be caused if a competent person opts for it. Act done in good faith, and this is the last slide that I would like. And this is what we should claim. This was section 88 in the IPC, and it is section 25 and 26 in the new Sanhita. Now remember this one. That is the basic one. Anything done for the benefit of the person in consent and in good faith, any consequences, the doctor is not liable. Doctor is not liable, not responsible. It is the doctor is not liable over there. Now, so what do I prove before the court? Benefit, of course, beneficial intent, and I have done it for the persons this one. Consent. Now the consent, consent taken free of fear, fraud, or these ones is a valid consent. It is a valid consent. Valid consent. I have shown to the court that there is a consent is there. Then, and once this is proved, that is I have done what I have done is in good faith, for the benefit of the person in good faith. The good faith has to be presumed. Interventions done with the consent of to save the life are exempted. You all know it very well. Now, so my submission is that as per the above stated exceptions, a duly qualified and licensed physician, that is, is competent. His competence is proved. By showing his license, his competence is proved. In good faith, that is the good faith definition is honestly. He has done it honestly. It is not malified. Providing treatment to a patient, that is the care, treatment, that is the care, which he believes would benefit the patient, that is relieve him of the symptoms and cure him. With the consent of the patient, is exempted from any liability for injury to the patient. The physician has committed no offense. This is the basic one is there. We should insist in the court that under this section 88, this provides the best protection, and it is possible, always possible for the doctor to say that what he had done was for the benefit of the person. He had taken the consent of this one, and he had done in good faith. There is no evidence that it was malified or it was done dishonestly. I think I'll end it over here.
Thank you, sir, for a nice and crisp presentation. Now, मैं चेयरपर्सन से रिक्वेस्ट करूंगा कि सर को शॉल उड़ाकर और रामलला की मूर्ति देकर सम्मानित करें, प्लीज. अब मैं इनवाइट करना चाहूंगा डॉक्टर अनुराग तोमर, डायरेक्टर नेम्स, डॉक्टर लोकेश अग्रवाल, उपचार एसईसी मेंबर, डॉक्टर अमित व्यास, सेक्रेटरी कोटा उपचार, एंड डॉक्टर ओपी बंसल, प्रेसिडेंट दौसा उपचार. प्लीज स्टेज पे आएं और हमारे चेयरपर्सन हैं उनको सम्मानित करें.
Thank you, Kabra sir, for your excellent scientific talk, and Dr. Buddha Prakash for excellent moderation. Bhukhe bhajan na hot gopala, ye le teri kanthi mala. I think everybody is feeling hungry, so there is a little bit change in the schedule, as the pre-scheduled panel discussion will be done after the lunch. Or now it's the time for the lunch. It's around 1:20, and after 35 minutes, that is 1:55, we will gather here again for the for the next panel discussion. Thank you very much.
तो बिना कुछ भी गए अच्छी नहीं आएगी तो
बल्कि पूरे देश में निजी अस्पताल देश की स्वास्थ्य व्यवस्था की रीढ़ रहे हैं।
छोटे छोटे शहर हो या बड़े बड़े महानगर, निजी अस्पतालों ने हमेशा उत्कृष्ट सेवाएं राष्ट्र को दी है।
लेकिन पिछले कुछ वर्षों से निजी क्षेत्र बहुत सी समस्याओं से जूझ रहा है। राजस्थान में निजी अस्पतालों की समस्याओं को राज्य स्तर पर मजबूती से उठाने के लिए निजी अस्पतालों के एक राज्य स्तरीय संगठन की आवश्यकता बहुत लंबे समय से महसूस की जा रही थी।
अन्य अधिकांश राज्यों में निजी अस्पतालों के ऐसे संगठन पहले से विद्यमान थे, लेकिन राजस्थान में ऐसा कोई संगठन नहीं था और यही कारण था कि निजी अस्पताल संचालकों में वर्ष 2020 आते आते एक अनिश्चितता एवं असुरक्षा का भाव प्रबल होने लगा था।
राज्य के कुछ सक्रिय और ऊर्जावान चिकित्सकों ने इस कमी को महसूस किया। निजी अस्पतालों के राज्य स्तरीय संगठन के गठन का संकल्प लिया
और इस तरह वर्ष 2020 में रजिस्टर्ड संस्था सॉप्सर की सब्सिडियरी के रूप में उपचार का जन्म हुआ।
टीम वर्क, पारदर्शिता एवं सामूहिक नेतृत्व की भावना से शुरू हुआ ये सफर अब राजस्थान ही नहीं बल्कि पूरे देश के चिकित्सक समुदाय में एक जाना पहचाना नाम बन चुका है।
राजस्थान के निजी चिकित्सक संस्थानों का प्रतिनिधित्व राज्य स्तर पर सशक्त रूप से अब दिखाई देने लगा है। उपचार के उदय के बाद अन्य मेडिकल संगठनों की कार्यशैली में भी सुधार हुआ है। आज से 4 वर्ष पूर्व राज्य के निजी चिकित्सकों एवं निजी अस्पतालों की कोई आवाज नहीं थी, लेकिन अब ऐसा नहीं है। निजी चिकित्सकों के लिए उपचार अब एक आवाज बन चुका है।
पिछले 2 वर्षों में उपचार ने हर वो प्रयास किया जिससे राज्य के सभी निजी चिकित्सक एक मंच पर आए। उपचार संवाद और उपचार डायलॉग ने अपनी मन की बात कहने के लिए एक प्लेटफॉर्म दिया।
तो उपचार संवर्धन ने भूली बिसरी प्रतिभा और सुरुचि के संवर्धन का अवसर दिया। उपचार समृद्धि ने चिकित्सक साथियों को बेहतर निवेश के तरीकों की जानकारी दी, तो उपचार पर्यटन ने उन्हें अपनी यात्राओं की योजना अच्छे से बना सकने के लिए एक प्लेटफॉर्म उपलब्ध करवाया।
उपचार मैत्री के माध्यम से महिला चिकित्सकों को एकजुट किया, तो उपचार संवेदना ने चिकित्सक साथियों की आवश्यकता पड़ने पर यथासंभव सहायता की।
कानूनी मार्ग से हल करने की दिशा में उपचार ने सरकारी योजनाओं के बेहतर क्रियान्वयन के विषय पर राजस्थान हाई कोर्ट में याचिका दायर की, तो चिकित्सा सेवाओं को उपभोक्ता संरक्षण कानून से बाहर रखने के लिए देश की सर्वोच्च अदालत में एक SLP भी दायर की।
उपचार परिवार के सभी सदस्यों को कम प्रीमियम पर इंडेमनिटी कवर दिलाने के लिए सिक्योर नाउ से अनुबंध किया, जिसका लाभ अब तक 300 से अधिक साथी ले चुके हैं। सोशल मीडिया पर उपचार की सशक्त उपस्थिति ने उपचार को अन्य किसी भी एसोसिएशन से अलग बनाया।
पिछले 4 वर्षों में उपचार ने निजी अस्पतालों से जुड़ी विभिन्न समस्याओं पर लगभग 40 बार विभिन्न अथॉरिटीज को रिप्रेजेंटेशन दिए। हर छोटी बड़ी समस्या को ट्विटर के माध्यम से भी मुहिम के रूप में उठाया।
किसी चिकित्सक के साथ हिंसा हो या फिर लाल सूट की डॉक्टर अर्चना शर्मा की दुखद मृत्यु।
उपचार ने हर कदम पर बिना किसी स्वार्थ के अपने चिकित्सक साथियों का साथ दिया। वर्ष 2023 में राइट टू हेल्थ के विरोध में हुए ऐतिहासिक आंदोलन में उपचार ने महत्वपूर्ण भूमिका निभाते हुए राजस्थान ही नहीं बल्कि पूरे देश में चिकित्सकों की एकता की अद्भुत मिसाल प्रस्तुत की। इस आंदोलन को दशकों तक याद किया जाएगा। इस आंदोलन से उपचार को राष्ट्रीय स्तर पर पहचान मिली। पिछले कुछ वर्षों में चिकित्सक एवं अस्पतालों को मेडिको लीगल समस्याओं का सामना करना पड़ रहा है। इसी को देखते हुए उपचार ने मेडिको लीगल एक्शन ग्रुप के साथ मिलकर इस मेडिको लीगल समिट का आयोजन किया है ताकि चिकित्सकों को मेडिको लीगल विषय पर जानकारी देकर उन्हें और सशक्त किया जा सके।
उपचार की सक्रियता का ही असर है कि कमजोर हो चुकी मेडिकल यूनिटी अब वापस दिखने लगी है।
उपचार ने सभी चिकित्सकों को एक मजबूत प्लेटफॉर्म उपलब्ध करवा दिया है। अब हम सभी को इस अनूठे संगठन को बुलंदी पर ले जाने के प्रयास करने होंगे।
आइए हम सब मिलकर इस महान प्रोफेशन के खोए हुए गौरव को वापस लौटाएं। आइए हम सब समस्याओं का स्वयं उपचार करें।
नहीं हो पाएगा यार। वो हॉस्पिटल, वो लोग, वो OT,
हेलो, सभी पैनलिस्ट से निवेदन है कि यदि उनका लंच हो गया हो तो कृपया मंच पर अपना स्थान ग्रहण करें। It is a request to all the panelists, if they have finished with their lunch, they may please take their seats on the stage. We will shortly begin.
हेलो, डॉक्टर जैकब मैथ्यू, डॉक्टर नीरज नागपाल, डॉक्टर प्रदीप अरोड़ा, डॉक्टर गौरव अग्रवाल, डॉक्टर विपिन चकर, डॉक्टर हमीदा बानो. Please, all panelists are requested kindly come upon the dais. Please take your chair. I am again repeating the name. Dr. Jacob Matthew, sir. Dr. Jacob Matthew, Dr. Neeraj Nagpal, Dr. Pradeep Arora, Dr. Gaurav Agrawal, Dr. Vipin Chekar, Dr. Rishi Bhatia, Dr. Rishi Bhatia, and I request Dr. Raj Shekhar Yadav kindly moderate the session.
So welcome again, once again welcome back after the lunch session, and this is time for panel discussion on the criminal culpability in medical negligence, and for that the moderator is none other than Dr. Raj Shekhar Yadav Bose. और राज शेखर यादव बोस का इंट्रोडक्शन में क्या दूं, वह स्वयं अपने आप में एक इंट्रोडक्शन है, और मैं तो एक इंतरा इंट्रोडक्शन दे सकता हूं कि डॉक्टर राज शेखर यादव एक व्यक्ति नहीं है, एक व्यक्तित्व है. ही इज नॉट ए पर्सन, ही इज ए पर्सनैलिटी, एंड आई हैव हाईएस्ट डिग्री ऑफ रिगार्ड इन माय हार्ट फॉर हिम. और ये रिगार्ड मेरा आज से नहीं है, हमारे पीजी डेज से है. बॉस से हमारे थर्ड ईयर हुआ करते थे, मैं और अवनीश फर्स्ट ईयर रेजिडेंट हुआ करते थे, तो बहुत बार बॉस ने हमें डांट से बचाया. मेल वार्ड में राउंड चल रहा होता था, चीफ का मूड होता डांट लगाने का, अशोक को डांट लगाने का. जैसे ही लगा बॉस को राउंड डांट लगाने का टाइम है, तो बॉस बोलते सर ये पेशेंट ने 5 दिन पहले अल्कोहल ली है और अशोक ने बायोप्सी कर दी है, लीवर बायोप्सी, और रिपोर्ट अवेटेड है. पूरा राउंड बिल्कुल शांति से निकलता था. फिर टर्न होता था फीमेल वार्ड का, तब अवनीश जी का नंबर आता था डांट का. तब लग जाता था बॉस को राउंड डांट पड़ने वाले अवनीश जी को, सर ये एनीमिक है, अवनीश ने बोन मर करी है, बहुत बढ़िया बोन मर एक्सप्रेशन किया है और रिपोर्ट अवेटेड है. पूरा राउंड बिल्कुल शांति से. सो ये महानता रही है बॉस की, और बड़े लाड चाव से रखा है हमें. सो विद दिस ब्रीफ नोट आई इनवाइट डॉक्टर राज शेखर यादव बॉस फॉर द प्रोसीडिंग्स.
नीचे आ रहे हैं वो भी. हाँ है सर, बैठो आप भी बैठो प्लीज. So, good evening everyone. Complications, calamities, accidents and misfortunes, they have been associated with medical profession since antiquity, and they are bound to continue despite advancing technologies. To help and rehabilitate the aggrieved, recompense mechanisms are being constantly evolved and modified on humanitarian grounds all across the globe. They deserve to be hailed and appreciated. But the alarming upsurge in criminal implications of doctors by attendants after any mishap to extract more than what would be available as civil remedy should be a cause of concern for law stalwarts, social ideologues, and medical professionals. It is of paramount importance to have a precise differentiation between error of judgment, medical accident, complication, civil medical negligence, and criminal negligence. This session has been planned to have a better understanding of the criminal culpability in cases of medical negligence. And I am delighted to have a galaxy of medical legal experts for this panel. A quick introduction. We have with us, starting from the right, Dr. Pradeep Arora, medical doctor, pediatric surgeon, lawyer. He has himself implemented many cases in the court and has been appreciated by judges. Then we have Dr. Neeraj Nagpal sir. He is physician and convener of Medicolegal Action Group. Then we have Dr. Gaurav Agrawal. He is medical doctor and lawyer, medical legal expert. Then we have Dr. Vipin Chekar. He has come from Mumbai. He is MD, DNB. He is also a lawyer, LLB, and he is pursuing LLM in criminology. Then we have with us Dr. Rishi Bhatia. Jacob Matthew नहीं है? I invite Dr. Jacob Matthew because without him no discussion can happen. जो culpability का issue है वो तो Jacob Matthew से ही शुरू होता है और उन्हीं पे ख़त्म होता है. Okay, welcome sir. So let us start the discussion. My first question is to Dr. Neeraj Nagpal sir. Sir, to a layman, negligence is negligence. But for a doctor, it makes a huge difference whether the charges against him will fasten civil liability or criminal liability to him. Even medical experts who are called upon to give their expert opinion in courts have often failed to differentiate civil from criminal medical negligence. So please tell us how to differentiate between civil and criminal negligence with precision.
Layperson to differentiate civil from criminal negligence is difficult. And this is why I was telling...
Sir, just interruption. I invite Dr. Dipali Pathak and Professor Datta, a chairperson. Please, sir, join the stage. Cheers, sir. Kante ji. Dr. Jacob Matthew, please, we are waiting for you. वहाँ chairperson.
यही लगा दो एक बात है. अरे वहीं लगा दो. राजपाल जी
Sorry for the interruption. So, Dr. Nagpal, please go ahead.
To differentiate civil from criminal negligence is difficult, and especially so for lay people. And when I say lay people, it also includes doctors, especially doctors who are sitting on medical boards, deciding on negligence of other doctors, because at times they mention something or some words, especially if the word gross is mentioned, it creates a big problem. And what Jacob Matthew judgment has brought on, or the Suresh Gupta versus NCT of Delhi, actually before the Jacob Matthew judgment, Suresh Gupta's judgment was the one which differentiated criminal liability from civil liability, and this was extrapolated and expanded in Jacob Matthew's judgment. So basically, earlier and even till now in IPC, you do not have the word gross written anywhere. And in Bharati Nyaya Samhita also, the term, I don't think gross term, usme bhi nahi hai. But this is what has come up, that only cases of gross negligence. Now, how to define this gross? The definition which is differently given, and one of the definitions I liked in one of the judgments I'll read out, it says that the doctor cannot be held criminally responsible for even for death of patient unless his negligence or incompetence showed such disregard for life and safety of his patient as to amount to a crime against the state. Because a criminal act, जो FIR आप पे लॉन्च होती है, वो डॉक्टर प्रदीप अरोड़ा वर्सेस नीरज नागपाल नहीं होती. वो डॉक्टर प्रदीप अरोड़ा वर्सेस स्टेट ऑफ महाराष्ट्र, वो डॉक्टर नीरज नागपाल वर्सेस स्टेट ऑफ महाराष्ट्र. So a criminal act is an act against the state, and the punishment being given is because it is considered an act against state. So the level of negligence has to be quite high to call it criminal negligence versus civil negligence, where all sorts of things are covered. But even for civil negligence, I mean, error of judgment we say is not not to be considered negligence, but then we have so many cases where even for error of judgment, Dr. Kabra's talk was full of those examples. But to differentiate between civil and criminal, the enormity of negligence, the total disregard, the degree has to be much higher than that for civil negligence. And at least we have one judgment where it is mentioned very clearly that if the State Medical Commission and the National Medical Commission have not found negligence, then there is no point in pursuing the criminal case which has also been filed. Meaning to say, the bar for civil negligence is lower. So if civil negligence is not there, criminal cannot be there. But supposing a criminal case has been filed against you and you are exonerated by the criminal court, this does not mean that a civil case or a consumer case cannot and will not be filed against you, and you will not be penalized by the consumer court. I hope I'm right, sir.
Yeah.
I think let's go ahead with basic definition of what criminal negligence is for the general public, which is written. It's that it refers to a legal concept where a person acts in a grossly negligent manner. And as sir has mentioned, the word that is gross and negligent is not defined anywhere.
Yes.
But with a good defense lawyer and with proper advocates, all this thing which we say, all cases some of the cases which we've lost because we as doctors, honestly speaking, we as doctors have not had the time, as somebody mentioned also, that we are too busy, and then when it backfires on us, we say that the case we've lost. We ourselves on a take-home message have not given ourselves the time to read our own case. Nor are we willing to shell out a couple of lakh rupees when earning crores of rupees a year to have a team of lawyers. We are all indemnified with particular insurance companies. But once you step into the insurance company, they give you your lawyer, and we do not want to spend on our lawyer for the best of the lawyers. Because the company that is there has indemnified a lawyer for only 50,000 for bail or 40,000. But the real rate that is going on for real good bail lawyers is anywhere between 1 lakh to 2 lakh rupees. But at the end of the day, if you want to save yourself, you need to understand one thing very, very clearly, is that the lawyer has to be yours. You spend 1 crore rupees or 50 lakh rupees or 75 lakh rupees, whatever is the whole case that is going to, and each company is going to pay you the money that is back. So why don't you get the best of the legal team, best of the lawyers that is there to fight that case? Now coming down to this thing that, as sir mentioned, of gross legal negligence, is that this criminal negligence should result in serious harm or death to another person. Now this serious harm or death is again vague. This needs to be defined when we are defending the particular case. What is really considered serious harm? What is considered as grievous hurt? What is considered in the IPC language? Now, this criminal language or criminal negligence also involves a reckless disregard for the safety and well-being of others, demonstrating a severe lack of care. Now, Jacob Matthews' judgment and all have mentioned those 3 points: lack of care, duty of care, and breach, and other things that are there. So they have very clearly mentioned in this Jacob Matthews judgment, and that has been a trend. Now coming down to one step further is why these things are not being implemented. The basic take-home message which I feel for all of you is to have good cordial relations with your next door neighbor so that he doesn't give an expert opinion against you. Next, you need to have a good relationship with your concerned SDPO or the PI or whatever, your local police station that is there. And once a mishap occurs, you need to ensure that the mob that is collected is handled in such a way and the political parties do not enter into it. And last but not the least, this criminal negligence typically involves a failure to foresee and avoid reasonable, foreseeable risk, and it may result in criminal charges. Thank you.
I think gross itself has been, Jacob Matthews' judgment clearly said, will mean to mean rash and negligent act. That is one. Secondly, you tell me, if one of us amputates right limb instead of left, is it gross or not? Knowing fully well the facts of the case, removes right kidney instead of left, which was to be removed, elective surgery, no emergency, is it gross or not? So courts have given some examples, but then it is for us to also, deliberate what is severe, because in that case, can we have, I'm like, kind of trying to balance both the things. What is the highest severe degree of negligence amounting to criminal negligence, and what is pardonable or error of judgment? I think Dr. Hitesh wants to make
Sir, there is one judgment where it is said, for negligence they have given definition. The oldest definition is to do something which a prudent doctor in similar situation will not do. But for gross negligence they have said to do something which no doctor on the earth is expected to do. That means if something is given in the textbook, it is a civil or a general negligence where you read the complication of hysterectomy, suppose. So it is mentioned bleeding, infection, injury, this, that. But show me one textbook which mentions operating Sita instead of Gita. It is not there. During the kidney example you gave, Operating right kidney instead of left is not a complication mentioned in the textbook. Forgetting mop inside is not a textbook complication written in the textbook. That means no doctor on the earth is expected to do that. That is a gross negligence. If something is given in the textbook, then it is a simple negligence.
And many examples they have been given in Jacob Matthew judgment. Complete recklessness, complete indifference toward patient. It's like staging a war against the state.
No, sir, my point is something different. When we talk about VP Shanta and others' judgment, what were the examples given for including cases for consumer
Gross
records?
negligence. Yes, it was gross negligence.
There was right versus left, there was leaving a mop. All this VP Shanta and others said is consumer court civil negligence.
Yes.
So how come this became from civil to criminal?
They say, at that time there was no concept of gross. You understand? And they said only such type of negligence can be fought in a case. So
I'd like to interrupt here. Let us move to the next question, and we'll keep on discussing all these things in next question. So,
very important question, and I think I have some contribution to make in this regard. You see, this is a very important question, differentiating between civil and criminal negligence. We have to be very clear in our mind. Judiciary is not so far. If you read Jacob Matthews, you know, the description of civil and criminal negligence keeps on is interwoven. You know, it switches on to civil, comes back to criminal. In fact, Martin D'Souza judgment, the judges also got this impression that it deals. But then, in Martin D'Souza, in para 51, what the court writes, what these distinguished judges write, they say that this has been explained in Jacob Matthews' judgment from para 12 to 16. But then it is not possible to differentiate always. For example, if somebody has left mop in the abdomen, whether it will be gross negligence or not, and also in the same para 51, the court is wondering, if suppose instead of mop, instead of cloth, sharp instruments are written, would it make difference? So this kind of clarity is there even with the highest those in judge, highest places in the judiciary. Now I will tell you what my take is on this. And I have drawn it from the Jacob Matthews judgment only. It writes that Lord Dipcock, gave this particular feature, which I think is very important. It says that from the circumstances of the happening in which criminal negligence is imputed to have been occurred, there must be a moment when the consequences of imminent harm are apparent, and still the offender continues with his act of omission and commission. And I think this only differentiates between civil and criminal negligence. Now continuing on this, Dr. Neeraj Nagpal has rightly pointed out that during this VP Santa judgment, it is clearly mentioned when Harish Salve on behalf of IMA said that it will be, it will harass the doctors. Then he said, no, only selected cases, conspicuous cases, which cases make the headline in the newspaper, and then cited certain example. Wrong site surgery, wrong person surgery, giving anesthesia gases, all those things which Dr. Hitesh is saying is gross negligence. Just let me finish. So when a wrong site surgery is done, it is totally inadvertence. It is totally inattention. At no point time has come when the offender knew that he is doing a wrong thing and didn't take the remedial measure. Therefore, I would defend it as a civil negligence and not. And VP Santa has taken it as an example of a serious civil negligence. He said it's a serious civil negligence, so that type of cases would be taken under Consumer Protection Act. For example, this another case in which I pleaded in the Supreme Court. You know about this Ratnagiri case, Deepa and her husband Sanjay, Pavaskar. Now, what was the story in this? They operate a case, they go to a conference, and patient returns the same evening of some is uneasy and she's not feeling well. They admit the case, asked their sister who was not trained. They had said, okay, you give fluid, and they felt that the symptoms were not much. How would they know that she is having a big embolus in the inferior vena cava, which is going to embolize and cause her death after 6 hours? Nobody can foresee it. So this was not criminal negligence. It was not culpable negligence, and it was not culpable homicide. By the way, Bombay High Court adjourned adjudicated that it was culpable homicide and she was prosecuted under 304 and her application for anticipate bail under 438 was rejected. It was went to Supreme Court and I pleaded there. Very rarely they allow any pleader in criminal case because it can prejudice the main litigant. Because if I say something, then it's a criminal case, the stakes are very high, their liberty is at stake and I may prejudice their chances. But when they went through the contents, and I made all these points, and including the fact that what they have done is being done all over the world, giving prescription or giving some treatment on the phone is not a culpable homicide, what is being made out by in the High Court judgment, right? And even moreover, they had seen the case, they knew all about the case. Yes, what they did was actually not even negligence. But then, certainly it was not culpable homicide. Certainly it was not culpable negligence. And that was made up and anticipated.
Thank you. Dr. Jacob Matthew, I think everyone here wants to hear you. And you have changed the history of medical negligence for the better in India. You faced great trials and tribulations. Your venturesome expedition that started from treating Jeevan Lal at Miss Brown in the year 1995 till your exculpation in the year 2005. Do you think that direction given in your judgment regarding FIR in case of alleged medical negligence of doctors are followed by law enforcing agencies correctly?
If you don't mind, I would like to put in a word about the first question which had been asked about civil and criminal negligence. Because the talk has been about the word gross, but actually speaking, in Indian courts, the talk should be about recklessness, because that is the point which has been emphasized in the landmark judgment. And there is a difference, there is a reason why, because gross is still being used both in Indian courts as well as in courts abroad. But it is recklessness which actually makes the point of difference. Why recklessness? You know, when this was explained by the person who gave the reason behind recklessness. He said that laws were brought in, criminal laws were brought in, and it was being used against anybody and everybody. But when medical professionals came under this Criminal Negligence Act, then judges felt that it is not correct. Medical professionals, they are in an act of doing good, but something inadvertent happens and a patient dies, and you're saying that this is criminal negligence. You are punishing the person for a lawful act which has had disastrous results. So he said that unless and until there is some intent which is shown, we cannot call it criminal. So how did he make this point? He said outright intent. If you want to do a crime, you want to kill somebody, you have planning, you have done the intent. So he said the word should be reckless. Why reckless? Because when a person is reckless, the person refuses to recognize the risks which are involved, which are having grave consequences. Or even if the person recognizes the risk, still the person goes ahead and does it. So in recklessness, you come to a state of mind which is as close as possible to saying that there is an intent behind it. And that is why in this judgment, it was the word recklessness which has been used, and it is recklessness that we should also be using in our discussion to talk about criminal negligence. The moment you say recklessness, we will differentiate what our Indian law says in our land from criminal negligence which is being talked about abroad. So I would stress on the fact that it has to be recklessness, because recklessness shows an intent, a hidden intent, even though, you know, the exact words which the judge used was
deliberate action.
Recklessness is an act, is where you are recognizing murder, but yet there is something unlawful about it, and you are not able to define what that unlawful aspect is. And that unlawful aspect is the recklessness which is shown as an indifference to life. So that is how I would differentiate.
Well said. Dr. Vipin Chekar, there is a quote from Dr. Jacob Matthew judgment. Conviction for any substantial criminal offence requires that the accused person should have acted with morally blameworthy state of mind. Recklessness and deliberate wrongdoings are morally blameworthy, but any conduct falling short of that should not be the subject of criminal liability. So my question to you is that how do courts decide whether the act falls in the category of recklessness or not, and what's the role of factor of mens rea in determining criminal negligence?
So when you talk of criminal, the first thing that we are taught in college is mens rea. I'm not very good in what you call remembering, so I thought I'll just jot down exactly what that mens rea means. Mens rea basically means a guilty mind. And whenever a criminal they examine कि उसके दिमाग में क्या चल रहा है, that is the guilty mind which is known as mens rea. So the purposefulness of that cause, उसने क्यों किया, किस तरीके से किया, murder किया तो whether it was planning, it was not planning, the way he has acted, what were the prerequisites for that, that is all considered as mens rea. Whether he did it recklessly as sir mentioned, whether it was negligent, whether it was purposeful, all this comes in the category of mens rea. So when you talk of criminal negligence, it is basically determining the criminal negligence of that person's mind that is there, who's conducted that act recklessly that is there. And this mens rea basically establishes what sort of a recklessness he has done and what was the purpose of his recklessness, whether that prudent doctor, as Hitesh mentioned, would be able to do it or not. So that's basically the guilty mind that's talking about mens rea in this cases of criminal negligence. Basically it's sort of a psychological this thing that is there कि वो आदमी ने वो काम किया तो किस basis पे किया. So the court and the police try to investigate that case in the such a sense that what were the factors that made him do and what was the situation that was he in by virtue of which this reckless act was done. I think that is my say about mens rea actually.
You want to add, sir?
You had asked this question to Jacob also, कि whether the guidelines given are being followed. So in 2016, Medical Legal Action Group under RTI had taken information from all police officials of Punjab and Haryana, asking them how many cases of section 304 and 304A you have filed against doctors and in how many cases you have taken medical board's opinion. So we got a reply that in 74 cases they had filed 304 or 304A, and only in 4 cases they had taken medical board opinion over 5 years since the act was the guideline for the past 5 years. So we went in a PIL to Punjab and Haryana High Court. They issued guidelines, all that thing happened. Now recently, this was 2016, 17, 18, the case was in court. Recently we got data from all over the country. So we have received data now from different states, but obviously everybody has not responded, but from different districts all over the country, and this is recent data. And here also we are getting cases where doctors have been charged, no medical board opinion has been taken. So to answer your question, this is 2023-24, and from 2005 this judgment has come in, and even now 19 years later the guidelines are still not being followed.
Exactly, sir. Even in Rajasthan, only after death of Dr. Archana Sharma, we have SOP. Till 2023, we didn't have any standard operating procedure for police officials. You want to add something?
Yeah, I want to add, I'm handling a picture of Maharashtra, where I've gone at least for more than 500 to 700 police station visits. Now I'll tell you very honestly how this actually functions in the ground level. You have an incident in your hospital, supposing an inpatient death that is there. Now the relatives reach the police station to file a complaint against you कि मेरा patient मर गया है. The police that is there takes the machinery into action and they apply the charges, whatever is the best, in my language, in whatever buddhi that they have. They will consult one of the other people. They will take out some 10-15 history papers. 304A लगता है कि नहीं लगता है, 304 लगता है, उनके मन के हिसाब से जो भी उनकी बुद्धि है, they will consult a crime PI, they will put that column that is there and they will book you. Now before booking they are supposed to follow all these norms. Now, where do the doctor's picture come into this? Each police station of your area should be sensitized towards all the acts that are there as to what exactly is there, and then let them take the action. Unfortunately, now in Maharashtra, with the Maharashtra Police Academy in Nashik, all the current one-star officers who are coming, APS, PSIs, senior PIs and the ACPs, they are being trained not to take action against the doctors till that medical board opinion comes. So things are changing, but the thing can be changed only when Rajasthan organization or your group of doctors go and have a tea at 4 o'clock in the police station where they have the time designated for that. Do some charitable work for them, get a one-to-one closure with them, get a one-to-one action with them. But if some political party steps in, we all have had it, that time personal relations, nothing much, is only the central ministry which is there, which helps, and that is the reason why doctors are being made a scapegoat. So the only take-home message which I can give is you need to sensitize your police station of your jurisdiction that is there, wherein the police officer is made aware of that. We've published a book in Association of Medical Consultants where I was the president. It contains the MTP Act. Hitesh has also written a chapter on that. We have the POXO Act, we have the Medicare Act, and we have the Jacob Matthews judgment, and we have the Martin D'Souza judgment. So all these judgments have been compiled into one book. All the acts are there. There is a synopsis by advocate and justice also regarding each act that is there. Once this act has been synopsized, we inform the local police station that kindly sensitize have some leniency towards doctors that is there. Once you are faced with a doctor having some sort of a negligence, please go through the act, please go through what column is applicable to the doctor, whether PCPNDT Act really comes under your jurisdiction or not, whether so many acts that are there, Medicare Act that is there, comes under your jurisdiction, and then please apply the column which you feel is sensible. Hitesh and all is very smart enough to squash a lot of FIRs, but that requires lawyers like Hitesh and Neeraj Nagpal to do, which is in scarcity or Gaurav who's there, So again, I bet I conveyed what I want to convey, that you need to sensitize your local police station. If you are in good books, आपके problem होने के पहले ही वो senior पे आएगा, आदमी 4 जना के mob जो रहेगा आपका hospital में handle हो जाएगा, सब चीज handle हो जाएगा. It's only a question of maintaining good relationships and good respect with your concerned officers that are there. उसके बाद में आपकी लगने वाली है, in my language तो लगने वाली है, you cannot do anything because there must be some pundlik over there who's going to call some top person above the ACP or that is there. And once you have an issue that is there, please contact the writer of your local police station, and I bet there will be a better solution than all this. ये जो violence वगैरह, Maharashtra you have not seen any violence. I'm telling you. Meera Bhayandar area from which I am there is no violence at all. There is no nothing. It's such a secure area कि हमारे इधर कुछ होता है, so there are 25 doctors immediately, and all of them know all of people करके, and then nothing happens there. There is no political party also of the 10 political parties who will interfere because all of us are interconnected with each other, being presidents of MNS, somebody is president of Congress, somebody is president of the VHP, somebody is president of this. तो किसी डॉक्टर के पास कुछ प्रॉब्लम होती है, बोलते नहीं चेक कर, मेरे पार्टी का बंदा है करके हैंडल कर ले, मैं भी आ रहा हूँ, दूसरे पार्टी का बंदा आएगा हैंडल करेगा. दिस थिंग डजंट एस्केलेट टू दैट लेवल जहाँ पे पुलिस ऑफिसर 304 लगाएगा.
Got your point, sir. Local medical associations have a great role to play. They need to sensitize the police, local police, as well as they need to have a local strong unity so that in case of any situation like this, they could counter. I have a long list of questions here, but due to time constraints, I can't include all of them. But I'd like to invite Dr. Vijay Batra, sir. He wants to say something. Sir.
दो छोटे सवाल हैं, मैं रिक्वेस्ट करूंगा एक एक करके पूछूंगा. डॉक्टर गौरव अग्रवाल सर बैठे हुए हैं. सवाल से पहले मैं थोड़ा सा इलस्ट्रेशन देना चाहता हूँ. यूजुअली केसेस ऑफ क्रिमिनल मेडिकल नेग्लिजेंस आर लॉज्ड अंडर क्लॉज 336, 337, 338 एंड 304A. जैसे मैं तो जजमेंट में लिखा हुआ है, कॉमन है ये. 337 simple injury by rash and negligent act. 338 causing grievous hurt by rash and negligent. 304A causing death by rash and negligent act. इसमें कुछ illustrations भी दिए हैं जो आपके लिए समझने जरूरी हैं. सुरेश गुप्ता केस, सेप्टोप्लास्टी का छोटा सा ऑपरेशन हो रहा था. Instead of a cuffed endotracheal tube, a plain tube of small size was put, and blood trickled from nose to the lungs, and it caused death. एक केस आता है जिसमें आईवी लैरिगो दे दिया IM की बजाय, and the child collapsed in the very lap of the mother. एक केस आता है जिसमें एनेस्थीसिया वाज नॉट गिवन प्रॉपरली, इट वाज सम अंडरडोज एंड पेशेंट डाइड ऑफ पेन ड्यूरिंग रिडक्शन ऑफ अ फेमर फ्रैक्चर। एक केस आता है जिसमें एनेस्थीसिया की ट्यूब डिस्कनेक्ट हो गई एंड पेशेंट डाइड। इस तरह से जैकब मैथ्यू केस में जितने भी इलस्ट्रेशन दिए हुए हैं दे वर ऑल रिलेटेड टू अल्टीमेट डेथ ऑफ द पेशेंट। उस पर सुप्रीम कोर्ट ने क्या बोला? द एक्ट वाज नॉट रेकलेस, द एक्ट वाज नॉट ग्रॉस, it was not a crime against the state, it was compensable, it was not intentionally done, there was no conspiracy and collusion with somebody as to call it as a criminal negligence। अब मेरा सवाल गौरव सर से यही है कि डेथ के केस में अगर क्रिमिनलिटी नहीं है तो फिर 337, 338 तो मेडिकल प्रोफेशन के लिए लागू होने ही नहीं चाहिए, दे शुड बी रिमूव्ड फ्रॉम, दे आर बीइंग रॉन्गली अप्लाइड। इसमें मैं कहूँगा थोड़ा सा।
So yes, Dr. Batra, you are right that way. Yes, because we deal with in forensic also every other day in 336 IPC, 337 IPC and 338 IPC. I've always maintained that these are wrongly applied against doctors. But then this is lack of knowledge on the part of prosecution, including the investigative agency, the police, the misuse of power as well. But yes, you know, when we try to understand this, why this is happening, these are two reasons. But, you know, when we try to go deeper into this, what everybody's been talking about, we are on the same platform that yes, first is, you know, it's a spectrum from no crime to a maximum crime. You know, from no intention to maximum intention. From no act of crime or no intention whatsoever to the highest level of mens rea in case of murder, you know, or rape kinds of crimes, which are at the highest level of the spectrum. So probably at the lowest again would be no act, no crime whatsoever, no mens rea, no guilty mind. Then accident, you know, bas ho gaya, accident is accident. Then probably when we go up on the spectrum, there is recklessness, which is the courts call it gross, and they mean it to be, you know, rash and negligent act. But then it is recklessness. There is no intention. Okay, which ultimately amounts to so-called criminal liability or criminal negligence. And then of course there is proper good amount of mens rea, guilty mind for the biggest of the crime. No? So yes, you are right in saying that. I would agree with you, these are wrongly applied, but then who is going to fight? We all have to fight towards this. Come to think of it, Dr. Vipin Chekar raised a very, very nice point. We have the exact situation in the state of Delhi. Violence happened against hospital. We went to the Deputy Commissioner of Police. Okay, you tell me first of all, you are all Rajasthan people. There is this Medicare Act in some states. I don't want any panelists to react, please, for a moment. There is this Medicare Act in some states in the country. Do you have it in your state, yes or no? How many? I want to see a raise of hands. 1, 2, 3, 4, 5, 6, 7, 8. The others do not know. I would take it. So if we do not know, how the hell are we going to tell them that there is law in this state? Rajasthan Medicare Act in 2008, August 2, it was promulgated. If we do not know, हम उनको कैसे बताएंगे? दिल्ली में डीसीपी को नहीं पता था एक्ट है, बोला अगर ऐसा कानून है तो डॉक्टर साहब दिखाओ, हमने निकाल के दिखाया, कहता अच्छा ठीक है, उसने केस रजिस्टर किया. It is a non-bailable, very, very, very powerful weapon in the hands of doctors, and it is shame on us if we don't know about it. So that was one point I was raising, that we need to be aware about a little bit about what can save us. So I
Thank
think,
you, Dr. Gaurav. Dr. Batra, sir. Next question here.
Sir, एक मिनट. I think we
ये भी
need
check
to
out
understand
also
one
actually.
thing very clearly. You cannot fight the appropriate authority. Okay, only एक तरफीरा आदमी जाके fight कर सकते हैं जिसको बाल बच्चा नहीं है, कुछ नहीं हो. Only a vagabond can go and fight his authorities. They have the supreme power to put whatever goddamn sections you apply. Drunk driving में आपको पकड़ेगा और बाजू में दूसरे आदमी को पकड़ेगा, आपके ऊपर चार्ज लगाएगा culpable homicide, amounting murder. दूसरे मिनट में दूसरे देखेगा, दूसरे बच्चे को छोड़ दिया है उसने. आप पेपर में पढ़ोगे, वो उसको अरेस्ट नहीं किया, बेल गिवन, बट दूसरे आदमी को बेल नहीं दिया, वो कोर्ट में जाके खड़ा है. So this is all part of the system which we are there. It is impossible to fight the people in authority. Kindly understand that. What we can do is we can sensitize them, be at good books with them, be humble with folded hands कि सर जो है आप देख लीजिए, I really am, I mean to say it's not negligent. These things do happen and you will refuse to believe, I have gone through 2-3 cases of mine in the court. वो जज उधर खड़ा रह के बोलते तुम डॉक्टर लोग ना तुम लोग ऐसे ही करते हो. पुलिस स्टेशन में पहला चीज यही बात करेगा वो कि तुम डॉक्टर ने मेरी माँ को ऐसा किया, मैं उधर गया, मेरे को आधा घंटा रुका करके मेरे से पैसे ले. करेक्ट मी इफ आई एम रॉन्ग. So these are facts which are there, sir. And what they said, of course, the judiciary is not biased. But वो पहले आपको ताना मारने वाला ही है. So at the end of the day, we also need to introspect ourselves. कि कितना हम अपने ओर से मेहनत कर रहे हैं कि अपने तरफ से अपना घर सिक्योर करने के लिए सेंसिटाइज कर रहे हैं ताकि उनको समझेगा कि एक्ट दिया है उनके पास.
So very quickly, so now we cannot say that ठीक है हमें MBBS में नहीं पढ़ाया, we do not know law, we are doctors. What the hell? Why should we talk about it? Dr. Malik is left, but I would have said this that now forensic medicine is not a second prof subject. That is one. Dr. Buller is here. Now second forensic medicine toxicology is a third prof subject. It starts in second prof but ends in third prof. It is long. Now the hours are from 100 to 175 hours. Medical ethics and medical law has been increased, in a huge manner in MBBS curriculum. Do you know this? No, we do not know this. So medical curriculum since 2019 onwards, 6 saal ho gaye, it has been drastically changed. And this is a important thing that has come in medical law. So our students know much more law than we do. So we need to catch up with them. That is why the value of these sessions. Dr. Raj?
एक लीगल डॉक्टराइन जो मैं ला एक्सपर्ट तो नहीं हूँ लेकिन फिर भी कुछ जो पढ़ा है ऑडियंस के लिए हेल्पफुल हो सकती है, तो ये है कि an act which goes beyond civil negligence, act which goes beyond civil negligence invariably involves death. इसका मतलब मरीज अगर जिंदा है तो आप पे क्रिमिनल लायबिलिटी नहीं लगनी चाहिए. दूसरा सवाल प्रदीप अरोड़ा सर से करना चाहूँगा मैं, that is about the effect of new BNS on the principles laid down in Jacob-Matthew judgment.
Yes, there is hardly anything to celebrate. There are many downsides, in fact. In the newer version, there are many downsides. For one, in eyes of a layman, it has criminalized medical negligence afresh. By mentioning it specifically in 106, it has brought to the attention of a common man that medical negligence is eminently imputable in the criminal law. This is the biggest problem with this. Second problem, everybody knows that earlier it was imprisonment or fine, now it is imprisonment and fine, and shall has been used with respect to both. There is only one respite, that with reference to fine, it is written they should be liable to fine. When these kinds of words are written, then it gives discretion to the court to spare it. But we are more bothered about the punishment part. Third problem, which is not discussed, I have not seen anywhere pointing, there is yet another which everybody knows, that it has been mentioned there, that the definition of registered medical practitioner is the one who is registered with National Medical Commission Act 2019. So it includes allopathy, but not other branches. So this is how it is now, the position is different from, that doesn't affect us, but then affect the doctors with other disciplines. Now fourth, which is very important and which causes me concern, because immediately we are not recognizing it. But you see, the law evolves through the litigations. In litigations, judges interpret it and then give it a new meaning. There is a potential problem in this draft. Now if we read the draft, do you have draft? Anyway, I try to recall. Whoever causes death of a person by rash and negligent act, not amounting to culpable homicide. No, not this. This is not culpable homicide. Shall be given a punishment of up to 2 years and shall also be liable for a fine. But if the act has been done by a registered medical practitioner, now underline what I am going, in a medical procedure, it writes medical procedure. Now what is the definition, what is the meaning of medical procedure here? Writing a prescription, by the way, a lawyer can always contest, it is not a procedure, sir.
this negligence has occurred in course of writing a prescription. So this is not a medical procedure. Its act specifically mentions that the act so-called has been done, should be done in course of a medical procedure. So that means that it makes those who are facing criminal negligence charges as a result of a wrong prescription. So then they will be liable to be jailed for 5 years. This way it can be argued this is the potential problem with the draft as it exists today.
We would like to end this session, but before ending, I would like to invite Dr. Anup Hajela. He wants to ask some question to some panelists.
So good afternoon, I am Dr. Hajela from MP. What happened in MP after the Jacob Matthews case? We took the copy of the Jacob Matthews case to our Principal Home Secretary and got an order delivered to all the collectors of MP. And the same order was then given to the DGP of MP, and he issued orders to all the SPs and the Thanas of the MP. And at the same time, we got that Jacob Matthews decision, and we had given all the copies to each and every member of our association in 2010. And 2008, we had a Doctors Protection Act also, by the help of our Chief Minister. In this, there were various punishments. So through that we made posters that this act has come, and under this act you can be behind bars, and this was now has been implemented way back in 2012. So we made the public aware that if you do something wrong inside the hospital, you will be behind the bars. This act has come into existence. So, and regarding the Jacob Matthews case, this has to be given many times. We have taken out orders many times because the new police personnel who come and take the Thana charge, they forget about it. So every 4 or 5 years we take out a copy and send it to the Thanas and the collectors as a sort of reminder. So it is our duty, the association's duty, to go on telling them this act, and at the same time.
Sir, I would like to ask, how much is the maximum punishment in MP Act, MP Medicare Act?
MP Medicare Act, I think it is 2 years.
So,
and it is
I have a question.
But
I have a question. Recently,
it is not available from the police station. It is not available from there.
But is it so that if maximum punishment in any act is if 3 years, then it becomes bailable and police can is not?
So this act basically is specific act, and the specific act has got specific punishment. You cannot take this in conjunction with the other IPC that is there. That is what they mentioned.
And
it is bailable only by the session code, but not bailable by the police.
Here in Rajasthan, we are facing a situation where police refuses to arrest the culprits.
That is there always. Now the whole issue again is very simple.
Yes, sir, what you are telling, we have implemented in MP. We have a Tatkal group, and we have a copy of the act on our mobile. As soon as there is violation, we all reach over there, and we reach to the doctor before he lodges a complaint that this is the act, and you have to arrest these people according to this IPCs and according to this act. So they are getting arrested.
In Maharashtra, we have a task force.
Decreased in MP, sir. Thank you, sir.
In Maharashtra, we have a task force. Now coming down to what sir said, 2008, 2010. Now we are in 2024. Kindly note the officers change every 2 years. So it's an ongoing process for all of us. And every time, please don't expect the association to do everything. I have been head of organizations for 7 or 8 organizations, risen to the president post, and now I have the retired post. But every time you cannot expect the president to go and do all these things. It is the duty of each one of you to take responsibility for your own this thing. Na? You also have to do. How many times have you all gone to vote for an association? Not one. There is hardly any voting. You all select the leaders that to come. You all blame the leaders that the leaders are not doing anything. So we are all in a vicious cycle. Please don't blame. Every time the associate, each president has his vision. He completes his vision. He does a good job. Which legacy has to be carried on by the next coming president after 2 years. Which is not being done. So kindly ensure that these things are done. And what his sir has said, this has been done in Maharashtra. Maharashtra mein aap dekhiye. The level of negligence that it is very low, sir. It is very low. We have a task force in all the organizations that are there, a WhatsApp group that goes, everything of this is done. तो आपके पास जो बोलते हैं ना कि 304 उसने ये लगाया जो भी लगाया बॉम्बे में लगाने को तकलीफ है सर. आई एम टेलिंग यू इट्स नॉट इजी कि कल्पेबल होमिसाइड लगा के उसको अंदर डाले. ऐसा होने वाला ही नहीं हो बिकॉज बहुत 150 लोग बैठे हैं वो लगने देंगे ही नहीं उधर क्योंकि वहां पे 10 डॉक्टर लोग पहुंच जाएंगे उधर, उसमें से 10 में से 4 जन पुलिस ऑफिसर के खास दोस्त रहेंगे. तो ऑलवेज दैट थिंग इज देयर. लास्ट बट नॉट द लीस्ट, ये जितने भी आपके वायलेंस के एक्ट वगैरह हुए, गिव मी वन प्लेस वेयर द डॉक्टर हैज स्टूड बाय दैट पर्टिकुलर केस. देयर इज zero data of all the violence that has occurred करके. Doctor is not ready to press the charges. He is not ready to ensure that the Medicare Act in Maharashtra or whatever the act in a particular state is put to the definition level. They do not have the courage also to put that sections which are there in the Medicare Act. They apply IPC sections. They do not apply the Medicare Act. Now why they don't apply? Because their authority is in power. You should have a force wherein 10 people go with an advocate to the police station. That's the only thing that can help us. You say that we do not have money, take an advocate, he charges 10,000, 15,000. But ensure that he is there, ensure that he talks politely to the concerned officer and see that Medicare के कलम जो है लगे. और बाद में वो डॉक्टर का दम होना चाहिए कि वो खड़ा रह के झगड़ा करे कि इसने मेरा तोड़ा है, मेरे को 20 गुना जो कुछ भी फाइन मेरे को मिलना चाहिए, वो मिलना चाहिए. कुछ नहीं होता है. We just sit on the dais, we make lot of this, have conferences of 1,000 people, but at the end of the day कुछ आगे होता नहीं, because जिसको झगड़ा हुआ है वो नहीं होती. It's just like a rape victim जो रहता है वो. रेप विक्टिम जब तक स्ट्रांग होके लगाएगी नहीं सामने आदमी की, तब तक उसको कन्विक्शन नहीं होगा.
Thank you. It was a wonderful discussion. I wish we had more time. But before going ahead with the felicitation part, I would like to. You have any questions, sir?
Sir, one point I want to make here, which is to puncture the hopeful balloon. The Jacob Matthew is a 3-judge bench. Lalita Kumari, state of UP, is a constitutional bench. What has that said? A police official may conduct an investigation before lodging an FIR for medical negligence. May conduct an inquiry, and the report has to be submitted within 7 days. So Jacob Matthew judgment actually has been overridden by the Lalita Kumari judgment. If somebody really gets down to getting that implemented, it will become a problem, because that is a constitutional bench and this is a 3-judge bench.
One last question from you, and then we will go ahead with the felicitation.
Very specific. After BNS application on the 1st of July, what will be the status of Jacob Matthews case?
This question was asked, and I think we already dealt with
this. We are not very clear, sir.
It's still applicable.
It's wrong.
So that apprehension in the social media that Jacob Matthews' judgment has lost value after 1st July when BNS comes into force is wrong. It still remains valid after 1st of July. It will remain valid till a parliamentary law in this
or a 5-judge judgment or a 5-judge bench decides something else.
Till somebody challenges it.
No, sir.
Till it goes back to the court.
No.
I will tell you why. I will tell you why.
Very specific, sir. Very specific. IPC is repealed. It is not amended.
Please try.
So it is a new law or act altogether.
Sir, it is still not come in the open domain, so there is no point wasting time.
I will tell you why. I will like to
let the blueprint come, and then we can talk about what is there. This has gone back to the judiciary for this thing. Once it comes into the picture, once the parliament passes,
I will request the panelists that let us issue a statement on this, because yesterday also when we were in the Mahatma Gandhi Hospital, this question was raised. I request all of you to release a statement regarding this, which will be enough to clarify.
Please try to understand one thing. I would like to answer the previous query, because that is not completely answered. Jacob Matthews, please. Jacob Matthews deals with two things. One belongs to substantive law, the other belongs to procedural law. The substantive law part is that the negligence ought to be gross to be held as criminal. This is the substantive part. This is determines the crime. Larger part of the Jacob Matthews is procedural in nature. So it pertains to the Criminal Procedure Act and not IPC. So it is a procedural direction. Procedural direction remains the same. What new act defines is the crime itself. It doesn't deal with the procedure. So the procedure still remains the same, because as directed by the Jacob Matthews judgment. Regarding this Lalita judgment, you see, I was under different impression. In fact, when I read Lalita judgment, I got the impression that Lalita judgment, constitutional bench judgment, endorses Jacob Matthews. Although it writes at a particular spot, it says the word may, but it fully endorses the Jacob Matthews judgment. So how you carry the argument in the court on this behalf, that will depend upon you. But I am sure that
this can be argued either way, and I felt better after reading Lalita. In fact, that now it has got backing of a constitutional bench also.
Sir, I think we are...
has been repealed. If CPA 1986 is repealed and CPA 2019, you are still finding doctors covered under CPA, then your argument, basic argument is becomes an invoice.
Sir, I'd like to end here, and before going on with the felicitation part, I'd like to have few comments from Dr. Jacob Matthew, because originally this session was planned as a talk by Dr. Jacob Matthew, but at the last moment we converted into a panel discussion to get maximum out of this hour. So, few words from you, sir. You have come from on our request. Please come here. And I request Dr. Vibha Chaturvedi and Dr. Renu Ojha to felicitate after this few words by Dr. Jacob Matthew. Please write. That's your comment. Number.
Good afternoon, everybody. It's a pleasure to be here, and I thank the hospitality which has been extended to us. It has been excellent. If any one of you would remember the spirit of the constitution of Upchar, you know, it says that both society and the medical professionals have to go together. And it is at the end of the constitution of Upchar that this statement has been given. And the spirit of the landmark judgment is also the same. The society needs us, and the medical profession exists to serve a vital role in society. It is a relationship which is built on trust, and neither should work to erode that. Law and punishment are a moral requirement in society, but society should not seek retribution through arbitrary use of the law. At the same time, the medical profession should show due diligence and care to uphold the trust with which society places their lives in the hands of medical professionals. We need a tolerant society and a humane medical profession. I will stir a little bit of a controversy here. Most of the things have already been talked about and discussed. So, I will come to just 2 points. All the discussion has been about civil negligence and criminal negligence. The question to be asked is, does the criminal prosecution of medical professionals, does it serve to regulate healthcare? On a symbolic or objective term, criminal law is to provide deterrence, but medical negligence is an unintentional act. And medical errors, by their very nature, cannot be avoided either. Hence, prosecution does not serve the purpose of preventing medical negligence. Does it improve healthcare delivery? Fear and apprehension of prosecution leads to defensive practice. Doctors are opting out of high-risk services. The non-disclosure of adverse events, which actually harms the learning process, which is essential to prevent future patient harm and improve healthcare delivery. It fails to take account of the interactive error-prone the environment in which medical negligence occurs, due to its rigid focus on individual blame and accountability and punishment. It does not improve the efficiency of the investigation process, and neither does the process enforce consistency and fairness in the delivery of expert medical opinion. The only thing that it happens to cover is compensation in a retributive punishment, but even that is at a cost. Cost of time, cost of money, cost of mental trauma, and of course, the medical professional, it ruins their career and he becomes a social outcast. So, what is the solution? Do we still keep fighting with the legal system, or do we have to look for some other solution? There is a solution which is being tried out in certain countries, and those are based on certain principles. One is that there's a high deterrence of prosecution of medical negligence. And we have that high deterrence. Like I said, it is recklessness. And only if recklessness has been proved can you say that there is criminal negligence. We are lucky to have that particular high deterrence. Theoretically, it's a high deterrence. And we should not be having cases of criminal negligence for every case that comes up. The second is that there is an appropriate social insurance for medical negligence. And the third is that the investigation of adverse events does take place, but it is pursued with the purpose of learning from all the mistakes that are made so that future patient harm is avoided, and it will improve the safety of healthcare delivery, and it will restore the competence of medical professionals. Actually, a summit like this is the best time to discuss something on this nature, because some of the best medical legal minds in our country are gathered in this room, and they can develop the framework of a system whereby insurance will cover medical negligence and a parallel investigation process will serve the learning and corrective process. Let us unitedly work towards that possibility. Are we mature enough to talk about a social insurance to cover medical negligence? Is a big question, but that is the best way to force. It is the best way to force the government and the society to talk about medical negligence, medical errors in a healthy manner, without pointing fingers, without trying to find blame. That is the only way that we can take it to the society and we can change the system. Thank you very much. It's been a pleasure.
Thank you very much. It's so nice to have you here in Rajasthan. You came from Kochi, spared so much of time on our request. Thank you so much. And now I would like to request Dr. Vibha and Dr. Renu Ojha to felicitate Dr. Dipali Pathak. And I request Dr. Rajesh Sharma. Rajpal, Dr. Rajesh Sharma to felicitate Dr. Datta sir. I would request Dr. Avnish Ojha to felicitate Dr. Vipin Chekar and Dr. Rishi Bhatia. Dr. Buddhi Prakash, please help him, assist him.
So after this excellent panel discussion, now it's time for the topic medical legal audit, and for this topic the moderator is Dr. Parag Goyal He is from 95 batch from JLN Medical College, Ajmer, and he is senior pediatrician and practicing. So,
I'd like to request Dr. Batra sir to felicitate Dr. Jacob Matthew.
So I may now request Dr. Parag to moderate the session, please.
नमस्कार ऑल ऑफ यू. पोस्ट लंच सेशन यानी लेजी लम्हे. तो एक छोटी सी 2 लाइनें. आइसक्रीम और गुलाब जामुन का स्वाद, आइसक्रीम और गुलाब जामुन का स्वाद जवान पर अभी तक रखा है. ए गुलाबी नगरी, हमने तेरे जायके को अच्छे से चखा है. तो चलिए हम फिर से सेशन हमारा शुरू करते हैं और रोलर कोस्टर राइड पे आपको लेकर चलते हैं एक मजेदार सेशन के लिए मेडिको-लीगल ऑडिट. बट पहले मैं हमारे सम्मानित चेयरपर्सन्स को मंच पर बुलाना चाहूंगा. हमारे पहले चेयरपर्सन्स डॉक्टर धीरेन्द्र कुमार सोनी, प्रोफेसर एंड हेड फिजियोलॉजी डिपार्टमेंट, DAV डेंटल कॉलेज, मॉडल टाउन यमुनानगर. ही इज ऑनरेबल सेक्रेटरी IMA हरियाणा, फाउंडर ट्रस्टी ऑफ MLAG. एक बार जोरदार तालियां डॉक्टर धीरेन्द्र कुमार सोनी के लिए. हमारे दूसरे चेयरपर्सन डॉक्टर गिरधर गोपाल गोयल, MS जनरल सर्जरी, वर्किंग एज एडिशनल सुपरिटेंडेंट, SMS हॉस्पिटल जयपुर. डॉक्टर गिरधर गोपाल. नेक्स्ट चेयरपर्सन डॉक्टर राजेश शर्मा. ही इज HOD मिनिमल इन्वेजिव एंड रोबोटिक सर्जरी, जनरल सर्जरी डिपार्टमेंट, CK बिरला हॉस्पिटल. डॉक्टर राजेश शर्मा. और मैं जोरदार तालियों के साथ हमारे स्पीकर सर को बुलाना चाहूंगा. वो बहुत ही ओजस्वी वक्ता हैं, एडवोकेट डॉक्टर हितेश जे भट्ट का स्वागत कीजिए. ही इज MBBS MD इन ऑप्स गायनी, PGDM LS LLB. He is medico-legal consultant of various hospitals since last 23 years, like Wadia Maternity Hospital, Mumbai, Central Railway Hospital, Mumbai. He is past chairperson, Ethics and Medico-Legal Committee, FOSG. He is author of many books like Consents in Ops and Gynae, Law Doctors Must Know, and he has delivered more than 1600 talks. सर को बस मैं मंच दे रहा हूं, बट सर की तरफ से एक आखिरी 2 लाइनें सभी श्रोताओं को. तेरी हर उबासी पे मेरी आह सी निकलती है, तेरी हर उबासी पे मेरी आह सी निकलती है, नींद से गाफिल पलकों पे मेरी चाह पिघलती है. तो प्लीज आह ना निकले, सर के लिए सिर्फ वाह निकले. एक बार जोरदार तालियों के साथ हमारे नेक्स्ट स्पीकर का स्वागत करिए. थैंक यू सो मच.
Hello. Good afternoon, everyone. See, usually when I say good afternoon, those who are awake and alive, they respond back. So, good afternoon. Yes, I just wanted to check whether if you are awake and alive. See, my topic is medico-legal audits. That is what I am doing. I have seen in my practice that we are not aware about the weapon which is there in our hand, and that is our medical documents. When people used to come to me for a defense, if something is not written, how can I defend them? I was feeling helpless, and that is how we started with medico-legal audits. So, we are in a times where people have high expectations, low patience, zero trust, and that all can lead to medico-legal issues. And medico-legal issues can happen like this. See, if you expect something to be normal, and suddenly it comes out to you as a horror. That is what happens. You open thinking that it is appendix, and it comes out as a ectopic pregnancy. the results. Many times, the patients, they expect results like this. Just see this video. But we can't deliver like this, right? Also, sometimes you may kick the wrong ball, thinking that it is a vessel you are fulgurating and it is actually a ureter. And the medico-legal problem starts. The medico-legal problem starts by so many various such reasons. So as long as things are good between you and patient, this is the situation. But minute something goes wrong and patient will start dancing on your head. Why this was not done? Why that was not done? Why this person was not called? Why did you not do this? All these questions will come on your head. And in law, two things are required. One is documentation, one is presentation. Presentation is a job of your lawyer. Lawyer will present it in a proper manner, but he requires a backing of documents. If it is not there, whatever he says to the judge will be of no use. If there is, because truth always requires a support, lies doesn't. That is the reality. And our documents can save you. Just see this video, how it is helpful. See, it is not on contraception. The message here is prevention is always better than cure. So you have to prevent problems from happening. So, medico-legal audit, an insight. The minute we talk about documents to anybody, the doctor who is in this situation starts giving expression like this. He may operate for hours, but he will not write for 5 minutes. That is the problem. So why it is needed, what is it, and what is our analysis? Why? I will not take much time because Indian Evidence Act is like that. We have to have, our case paper is our primary evidence. I am going little fast because my time is cut. But my important observation about this, what is my important observation? In most of the legal cases, the evidence is in the possession of the complainant or the victim or the prosecution. Suppose a wrong check is given to you by somebody. You are holding that check. If a wrong document is done by somebody, as a forgery, somebody has sold you something, a flat was given, the document you are holding. If there is a knife, there is murder weapon, it is either with the prosecution or it is in the tummy of the person who has actually been killed. So weapon is always with the other party. While in medical negligence, the most important thing, our most important evidence, what is that evidence? The document, and that is in hands of a doctor. We are in possession of that document. So, this is most important thing. And that is why, when you have that weapon, or you have that evidence, which is going, the entire case will be built upon that. So, that has to be perfect. So, it leads to two things. It is very difficult to refute anything which is mentioned therein, because it was always in your possession and you only have written it, right? But, you can always make it proper and perfect to your benefit. So, it is double-edged sword. If you have committed something on the paper, it is difficult to refute. I cannot say I was not in my senses, I have written something odd. But at the same time, it will help you. So how document helps? One man, he spent his entire evening with his beautiful girlfriend like this. And when he went home, before entering his house, what he did, he applied some mud on his shoes and he rubbed some grass on his t-shirt to have some stains. And when he must be from Rajasthan, sir. We don't have these big houses in Mumbai. So he had big garden outside. And his wife asked him one question. Where were you? And as you know, men are always very honest, very truthful, very noble, very gentle. He told that, darling, I was with my girlfriend. She said, I can see the mud on your shoes. I can see the stain of grass on your t-shirt. Don't try to fool me. You were playing golf with your stupid friends. This is the importance of evidence. And our documents are our evidence. So always you must have proper evidence. Now, What is included in our audit? What we are doing? We are doing licensing. Whether license is what all licenses you have, whether your compliance for that license is there or not. Providing formats of the case papers, registers, consents, day-to-day advice. We stop so many things from happening. ये patient ऐसा मांगने आया है, दूं क्या, मत दे. ये ऐसा मांग रहा है, मैं ऐसा करूं क्या, मत कर. या तो कर दे, या ऐसा कर. We give day-to-day advice. Audit of actually written cases. We always go and we check what doctor has written, what was the diagnosis, what was the treatment done, how follow-up was conducted, training to the staff, visit to operation theatre. We also give suggestions. We sit with the junior doctors who is actually taking consent. How, what he is telling, what he is not telling, what he should have said, what he should not have said, all this. We help in medico-legal situations and cases. And we provide MOUs for the contracts, samples. So how audit helps? Like in PCP, there was one recent incident. I did audit in October. That center was having only PNDT license, but there was no compliance. The forms were not filled, register was not proper, because in South they felt that there is no much problem. But there was a Mandia place near Bangalore where sex determination happened, and the team came from center, and they searched for all the centers. The center which we are auditing, that center was spared. Rest 10 centers got legal notice, or 2 of them were sealed. So this is what is the importance. They were prepared because of this audit. Timely advice we are giving, whether to do post-mortem, not to do post-mortem. In maternal mortality, the committee gives clean sheet based on the documentation. Because when something happens, they send us the document first. What medically they have to do, they know. But they send us the case, we go through the case, we ask them to write that तूने ये किया, मुझे इतना बताया, please लिख इसमें. They will tell the story for 1 hour, but when I ask for the case paper, it will be one single paper. That is not correct. So we have to make our documents perfect. Self-declaration. We also provide self-declaration. There was one recent incident where patient had convulsion during anesthesia. And in the history, doctor had written no history of anything, because she did not reveal that to her husband when during the time of marriage. We are giving self-declaration form also. The relatives are telling now to the doctor that, sir, हमने तो बताया था, आपने नहीं लिखा होगा. They were telling that. But she forgot that 9 months back when she came, we always give one self-declaration form, जिसमें patient ने खुद ने लिखा है कि जब OPD में बैठते, we are giving this self-declaration form, where patient will have to write what medicines they are taking, what illness they have. उसमें सब उसने no लिखा था. हमने कहा देखो तुमने भी no लिखा है. So we can avoid certain problems by this kind of exercise. I will not narrate many incidents. And also, the last point was the staff. Whenever our visits are there, staff may not be doing much proper documentation because you don't have time to look into it. So the staff who is practicing like this, after the visits started, we go and see the hospitals every month or every 2 months or every 3 months as per the contract. They start practicing like this. They become little serious. They know that there is somebody who is watching the documents as well. So that is the importance. What are our observations? I will tell you our observations also. History taking. This has happened when I was a student. I was in internship. One of my colleagues, we got a patient in emergency where there was a history of fall. A child had fallen from the tree and there was fracture. So he wrote everything, that history of fall 3 hours back, history of pain, history of swelling, all this he has written. But in the family history he wrote, there is no family history of anybody falling from the tree. That fellow is in now America. But this type of histories we are writing, and it is actually happening. Keep husband and wife's case paper separate. I am auditing many IVF centers. They write medical history of husband in one single case paper with one single registration number. That I had very difficulty to get it changed. If I said you are giving one registration number to both of them, if 502 number patient will die, who will die, husband or wife? So you have to be very careful. These two are separate individuals. You have to make separate case. And in one of the case, I did not put picture intentionally, but it was mentioned in the female history. In the coital history, it was mentioned twice a week. And male history, it was mentioned 5 times a week. I said, how will you explain this? You may not give them child, but you will give them divorce. So please write something properly. These are real incidences, sir. This is the case paper I have put here. Everything ticked. Without application of mind, remove contact lens, remove this, remove this. She was not wearing contact lens. So court will take it as without application of mind you have written something. Right? So you have to apply your mind. Here you write the temperature. You read the temperature written by the nurse, 35.7. Right? So one more incident, I will tell you. See, this type of writing can create confusion. Don't push, pull only, or it is don't pull, push only. We don't know what to do with the door. Same thing happened in one case. It was a diagnosis mentioned. Actually, the diagnosis was G1 P1 with left breast abscess. What was written in the case paper? G1 P1 left with breast abscess. It changed the meaning, right? But small things, if something big happens, the impression in the judge's mind is they are writing all this whenever the case is filed. Because this opposite lawyer cannot say that doctor was all diligent, everything was perfect. Only at this moment he has done negligence. What he will say, what our wives are telling, all males will agree. तुम शादी से ही ऐसे हो, तुम पहले से ही ऐसे हो. If she will say that you have done today something wrong, आज ही तुमने तौलिया यहाँ पे रखा है, you will not believe. तुम पहले से ही ऐसे हो, then they make you believe. So here also the lawyers, they are doing the same thing. They are telling ये इसमें भी ऐसा किया, यहाँ पे भी ऐसा किया, OPD में भी ऐसा किया, यहाँ पे भी ऐसा लिखा. That means they are not applying their mind. That is what they want to prove. So time written by anesthetist, surgeon and nurse are different. That also, and there is a case also I will tell, diagnosis is not justifying the treatment. Right? Like diagnosis mentioned as fibroid uterus. Plan of treatment, ovum pickup. Now in fibroid uterus you will not pick up ovum. You will pick up fibroid. You have to write primary infertility with fibroid uterus and you will do ovum pickup. So we are not conscious what diagnosis we are writing. Operative notes are very short. And when we used to be a resident, we used to write patient taken in the operation theatre, painting, draping done, the doctor with cap and cap, gloves, mask, incision was kept, 2 centimeters above the pubic symphysis, abdomen was open in layers. But when we become senior, hysterectomy done. That is the operative notes. Right? So that should not happen. Important information or taste which is suggested, that should be mentioned. If patient has not got it, then also that also should be mentioned. Counseling and points of discussion should be mentioned. Post-operative follow-up is very poor. Sometimes the times are not matching. The time which we are writing in post-operative notes are we are sitting somewhere and we are writing. Recently, only just 3-4 days back, I saw one case where patient was under anesthesia from 10 a.m. to 11 a.m. and the doctor had written post-op findings at 10:30 and conscious, cooperative, responding to commands. How can he be so? So these are the mistakes we are doing. And judges and advocates, the opposite advocate, they don't know about medicine, but they know about time. One patient can't be discharged thrice. Right? Nurse will write patient went home at 2. Doctor will write patient discharged at 4. In the case paper, in the discharge card, discharge time written at 6. Now if patient is found dead on the road and your discharge time shows 6, actually patient has gone at 4, you are still liable. Because patient is under your custody from that time to this time. You are guardian of the patient during the admission to discharge. So anything happens to the patient, you are responsible. If patient is found dead on the road, you are liable. So please make all the times same. Chronology is not maintained. That also is very difficult. So we are very poor at record keeping. That is what is my observation. Incomplete consents, blanket consents, signature not taken, negative consents not taken, and consent is very important. And I will tell you what is, I will not go into the detail of the consent, but what this villain is doing with the heroine in a Hindi film, hero does the same thing. Only difference is of consent. I am talking about marriage. So the difference is of consent. This is what is consent all about. There is a Goa case where an anesthetist had written patient had hypotension in spinal anesthesia. He had written termine 15 milligram was given. Patient who had PPH and patient died. Or amniotic fluid embolism, something of that sort was there, sudden death. But the nurse had written that 150 milligram of termine was given. Now, they have taken this point that you have given this termine more, that is why the patient has died. So, it is very difficult to disprove then. So, nurse has to write what she has given. She should not write what anesthetist is giving. Vital charts are incomplete. So, our handwritings. That is also a last thing. Handwritings are very poor. We evolve in handwriting like this. See, the same thing the person is writing in 10th class, 11th class, 12th class, MBBS, junior doctor, senior doctor and specialist. And this is what is happening. Please keep someone to write on your behalf or hire computers, but at least, and short forms. NDTIC. Have you ever heard this? Not done timed intercourse. This is what is the short form they are using. TNT. Do not touch. The doctor is writing such things. TTC. Trying to conceive. And unnecessary improvisation. There is a case, I told them to write complete plan. I said you write ovum pickup followed by ICSI with husband's sperm. They added word, they wanted to add the word ovum pickup followed by ICSI with husband's ejaculated sperm. He said, sir, there are two types of sperm, ejaculated sperm or ICSI or TESA we do and we take the sperm. But what they are writing in the case paper, ovum pickup followed by ICSI with ejaculated husband's sperm. I said, uchhal ke le rahe ho kya husband ko? We are not thinking what we are writing. So if your case paper is proper, things are proper. See, when you are in the practice, you are like this with the patient. You both are happy, you are enjoying in your practice. But minute something goes wrong and patient will start waving at you. Patient will show it, go to consumer court, civil court, medical council, and they will wave it at you. But if your case paper is proper, if your consents are proper, your documents are proper, you can wave it back to her. This is what is the importance of proper medical documents. And just 2-3 slides more. Always take good documentation is a good defense, poor documentation is a poor defense, no documentation means no defense. Never alter the records. You have to have signature, name, date, time. We are not taking this. And the last part I am talking about is, after listening to this talk, you may feel that some pressure, right? You feel that there is a lot of pressure on us and he is telling too much to do. But some amount of pressure is necessary in life to bring out miracles, right? So you must have some pressure, then only the miracles can happen. And if you are well prepared with the documents, if you are well prepared with your license, well prepared with your documents, well prepared with everything, the authority also will be very slow before coming to you. In medico-legal case, you have to take medical advice, legal advice and medico-legal advice. All three have to dance together because the advocates who are general advocates, who are not specialized in the medical field, and there are so many sitting here, right? They are there for right medico-legal advice. The advocates, they can't understand the medical language. Those who are not into medico-legal practice, there are more than 10,000 laws. It is like ENT surgeon treating vaginal discharge. He is dealing with the discharge but from different organ. Similarly, there are advocates but they are dealing in a different law. There are advocates, I don't know banking law, I don't know the company law, I don't know labor laws. So there are different laws for which they have specialization. So one board was mentioned, was put up here, only tennis shoes allowed. And one lady went there with only tennis shoes. That is what happens with the advocates who don't understand our language. Also, advocates don't understand our action. See, this girl, she's in some foreign country and she needs something, right? And you also know what she needs. Just see her action. But he did not understand the action, right? So advocates don't understand our action also. So, last slide. If you want to be medico-legally safe, you can take various professional options. You can start your band, you can become photographer, you can join Bollywood, you can join some Baba, or you can join Dawood gang, right? But ultimately, you have to run away and leave medical practice. That is not possible, right? We have to be in medical practice. So I always say that you may learn some asana to diagnose your own piles if you follow Baba Ramdev. But it is impossible to be out of medico-legal problem while being in a medical practice. My teacher used to tell that if you have not perforated a single uterus, you are not performing enough MTPs. I am telling you, if you don't receive a single notice, you are not having enough OPD. Please increase your OPD. So don't fear. You may look for the things very far off, but actually it is very near. Similarly, whenever you need me, I'll be just round the corner. Just continue your journey, not only walking but dancing like this baby. Have stress-free practice. To have stress-free practice, you must practice to remain stress-free. Thank you very much for patient hearing. And never fear litigation. Tell your patient, मत पूछ मुझे कि मेरी पहचान कहां तक है. मत पूछ मुझे कि मेरी पहचान कहां तक है. तू बदनाम कर, तेरी औकात जहां तक है. Say this. Thank you.
थैंक यू सो मच सर. इतने सीरियस इशू को आपने बहुत इंटरेस्टिंग वे में बताया. एनी क्वेश्चंस फ्रॉम ऑडियंस? अब मैं हमारे सम्मानित चेयरपर्सन से रिक्वेस्ट करूंगा कि सर के सम्मान के अंदर एक रेप्लिका और शॉल प्लीज.
I think this was the most fantabulous performance today by him. Fantastic, sir. Thank you.
मैं स्टेज पे बुलाना चाहूंगा डॉक्टर लालचंद ढाका, डॉक्टर राजेश कटेवा और डॉक्टर रोचक तातेड़ जी को हमारे सम्मानित चेयरपर्सन्स के सम्मान के लिए.
Hello, hello. Sir, Dr. Hitesh Bhatt is known as the Amitabh Bachchan of our Foxy.
Yes, definitely.
So most of the slides were from, from that department only, I think.
डॉक्टर लालचंद ढाका, डॉक्टर राजेश कटेवा एंड डॉक्टर रोचक तातेड़, प्लीज कम ऑन स्टेज.
सभी लोगों से आग्रह है, अपने इस कार्यक्रम के पश्चात गाला डिनर और म्यूजिकल नाइट का प्रोग्राम रखा गया है, तो सभी अपनी स्पाउस के साथ जरूर आए और रुके, कोई जाए नहीं. इस प्रोग्राम के बाद शाम को जो म्यूजिकल नाइट और गाला डिनर होगा उसमें आप सब आमंत्रित है अलोंग विद योर स्पाउस. थैंक यू.
दिनेश शाह साहब का अर्थ ये है, इस प्रोग्राम का मतलब ये पूरा समिट जब समाप्त हो जाएगा उसके उपरांत एक गाला डिनर है, इस सेशन के बाद नहीं है.
Really an excellent talk, and after this talk there is time for the next talk, that is evidentiary value of the and practice. For next session, the moderator is Dr. Atul Gupta. He is neonatologist and pediatric surgeon, director in pediatric surgery at Neo Clinic Children's Hospital, Jaipur, and he is specialist in pediatric minimal invasive surgery and rigid bronchoscopy. More than that, he is an extraordinary literarian also. Dr. Atul, please.
चेयरपर्सन डॉक्टर और डॉक्टर अनुराग. मैं जानता हूँ. A very good afternoon to all of you. एक फॉर्मल इनविटेशन से पहले मैं आप लोगों के साथ एक कल रात की इंसिडेंट शेयर करता हूँ. कल रात को 11 बजे हमारे पास एक न्यूबॉर्न आया, 2 दिन का बच्चा, हीमोग्लोबिन 4, मैसिव ब्लीडिंग PR विद बिलियस एस्पिरेट्स. बच्चा बहुत सिक था, वेंटिलेटर पे लिया, इमीडिएटली मैनेज किया, एंड देयर वाज अ पॉसिबिलिटी ऑफ वॉल्वुलस विद कंप्लीट और नियर कंप्लीट गैंग्रीन. फैमिली को बताया, वीडियो काउंसलिंग हुई, बच्चा काफ़ी सिक है, द ओनली पॉसिबिलिटी ऑफ सर्वाइवल इज इमीडिएट सर्जरी.
सो 1-2 घंटे में ब्लड अरेंज करके ट्रांसफ्यूज करके लाइंस डाल के लेप्रोटमी ली एंड देयर वाज कंप्लीट स्मॉल बाउल गैंग्रीन। रेसेक्शन किया, फैमिली को इंट्रॉप दिखाया, वीडियोस दिखाए, फोटो दिखाई, एब्डोमेन क्लोज किया और उनको पुअर प्रोग्नोसिस के बारे में काउंसल किया। रात को जैसे तैसे सुबह तक अभी स्थिति कंटिन्यू बिगड़ती गई और अभी 2 मिनट पहले मेरे पास एक फ़ोन आया कि हम एसपी ऑफिस से बोल रहे हैं कि डॉक्टर साहब आपने क्या किया, पैसा भी ले लिया और बच्चा भी मार दिया। तो अब इस स्थिति में सवाल यह है कि हम काम करना तो नहीं छोड़ सकते, ये तो डे टू डे प्रैक्टिस में चीज़ें आएंगी ही आएंगी। अगर मैं उस सर्जरी को सुबह तक रेफर करता तो हो सकता है मेरे मन में भी यह गिल्ट होता कि जो इंटेस्टाइन बच सकती थी रात को वो मैंने रात को नहीं बचाई। लेकिन उसका तरीका सिर्फ एक तो यह है कि हम डॉक्यूमेंटेशन पूरा रखें और अपनी स्किन को, अपनी चर्बी को मोटा कर लें, वैक्स कोटेड हो जाएं। थोड़ा सा आपको मेरी बात अजीब सी लग रही होगी लेकिन ये आज के ज़माने में बहुत ज़रूरी है। डॉक्यूमेंटेशन पूरा करके काम नहीं छोड़ना है। थोड़ा सा अगर अपन स्पिरिचुअली चलें तो ये चीज़ 100 साल पहले भगत सिंह ने भी कह दी थी, अंग्रेजों के टाइम में, जब उनको फांसी से एक रात पहले बोला कि आज भी माफ़ी मांग लो तो फांसी बच सकती है। तो उन्होंने यही कहा कि उन्हें है ये फिक्र हरदम के नया तर्ज़े ज़फ़ा क्या है, उन्हें है ये फिक्र हरदम के नया तर्ज़े ज़फ़ा क्या है, और हमें है शौक के देखें सितम की इंतहा क्या है। उन्हें है ये फिक्र हरदम के नया तर्ज़े ज़फ़ा क्या है, दुख दर्द क्या है, और हमें है शौक के देखें सितम की इंतहा क्या है। दुख से क्यों खफा रहें, दर्द का क्यों गिला करें, सारा जहां दुश्मन सही आओ मुकाबला करें। तो एनीवे ये चीज़ें हमारे साथ आती रहेंगी और आज की कॉन्फ्रेंस इसी पार्ट में थोड़ा सा डिफरेंट है। मैं हमारे ऑनरेबल स्पीकर का आप लोगों के साथ इंट्रोडक्शन शेयर करता हूं। ही इज डॉक्टर अश्विनी कुमार सेतिया सर, ए रिनाउंड गैस्ट्रोएंटरोलॉजिस्ट, senior consultant from Medanta Institute of Digestive Sciences. He was formerly adjunct professor of gastroenterology, ESI Medical College, Faridabad, and he is a medico-legal consultant and advisor. He is a visiting faculty in Maharashtra, Aurangabad, Mahindra University of School of Law, Hyderabad, and editorial consultant of The Quint. He is author of many books on medico-legal issues. He has got several publications in many international journals. Dr. Ashwini Kumar Setia sir. Our honorable chairpersons are Dr. Sumita A. Jain madam. Ma'am is currently principal in Dausa Medical College. She is ex-head of the Department of Surgery, SMS Medical College. She was in charge of Women Oncology Group of Birla Cancer Institute. A warm welcome to Dr. Sumita A. Jain madam. Our next chairperson is Dr. Anurag Dhakar sir. He is senior professor and unit head in the Department of Orthopedic Sciences, SMS Medical College, and nodal officer and in charge of Trauma Center of SMS Medical College. And our third chairperson is Dr. Suresh Vashish sir.
Dr. Suresh Vashish is from Gurgaon and he is past president of ASI and is the leading surgeon of Gurgaon, Dr. Suresh Vashish.
Good afternoon, ladies and gentlemen. It is customary to thank the organizers by the speaker.
How did you start without me asking you?
Prabhu.
No, chair. They have appointed me a chairperson, so I will ask you to start. Now you can start, please.
So as I'm mentioning, it is customary to thank the organizers. But as I stand before you today, I thank all the audience on behalf of the organizers because I am the secretary of Medicolegal Action Group, which is co-organizing this. Although we have not done much, but my thanks and gratefulness goes to the Upchar team, especially Dr. Yadav, Dr. Khetani, and Dr. Batra. So before I start, I find it is a onerous task for me speaking after Hitesh Bhatt. Inimitable style, and also after, the research shows that the sleepiness creeps in 1 hour after lunch, and it is exactly after that. So it is my endeavor to this afternoon is to keep you awake, especially on a topic which I find myself like one of the 6 blind men, not one of the 6 blind men, but the only blind man who's exploring this elephant. And when I researched, I found that I have taken ear as the fan and the spear and etc., and found that my topic is more dry than the pachyderm skin. Not wasting much of your time. So we have to find that there are multiple facets and dimensions when we talk of evidentiary value of expert opinion. I have split the topic in exactly the same words. So what do you consider expert opinion? Medicine being an imprecise and inexact science of uncertainty and art of probability, expert opinion cannot be taken as cast in stone. What is evidence? Is scientific evidence published in international journals applicable to Indian patients? Balance of probabilities in opposing expert opinions. Many a time, judges disregard expert opinion. Can an expert opinion only be his opinion, the expert's opinion, based on his eminence in the field? While I am at it, I must seek your pardon for certain repetitions that may creep in because of the contextualization of the point that I want to make. Now, who's an expert? I think all of you know who's an expert. Wives are always the expert. But legally speaking, experts are people who have been trained or are skilled to have knowledge, experience, or education in a technical or scientific discipline. They must be within a recognized field of expertise, and their opinion must follow reliable principles. Please note, their opinion must follow reliable principles. They should have a specialized knowledge. I would quote Jacob Matthew, which has been quoted ad nauseum. Medical negligence cases involve complex medical concepts that are beyond the understanding of a layperson, which includes plaintiffs, judges, and opposing advocates. Expert witnesses, who are usually medical professionals with expertise in the relevant field, provide specialized knowledge and insights to the court that help in understanding the medical aspects of the case. This is a legal language, so I'm very sorry, I have to quote it verbatim. They help establish standard of care that a reasonable and prudent medical professional would have provided under similar circumstances. They testify whether the defendant deviated from his standard or leading to the alleged harm or injury. They also find whether the alleged negligence directly caused the patient's injury or harm, because there has to be a nexus between the harm done and it has got to be a consequential damage of the negligence. They evaluate the medical records, etc., and then establish a link between the defendant's actions and the patient's condition. What is the difference between fact, opinion, and expert opinion? A fact is something cognizable by the senses, such as sight or hearing, whereas opinion involves a mental operation. What is opinion? Opinion is estimation or a belief or an assessment. It is a view held as probable, not definite. What one thinks about a particular question or topic. It is an assessment short of grounds of proof. It is a formal statement of reasons for the judgment. A formal statement of professional advice. That is what is opinion. That is why you say medical opinion. Expert opinion, on the other hand, is a judgment or testimony provided by a person with specialized knowledge, skills, or experience in a particular field or subject matter. Expert opinion is relevant when the court needs it to form an opinion about foreign law, science, or art, identification of handwriting, or identity of finger impression. Now, under Section 45 of Indian Evidence Act 1872 and Section 39 of Bharatiya Sakshya Adhiniyam, the expert opinion is defined. Although the Bharatiya Sakshya Nigam is not yet come into force, it will come by 1st of July. So I'll stick to Section 45, which provides that when a court has to form an opinion on a point of science, please mark these words, the opinion of a person especially skilled in such science is considered relevant. A relevant opinion is not synonymous to the opinion being conclusive. Experts' opinions are not binding and are only advisory in nature. There are multiple cases where you find such things that the judges have rejected the expert opinion or discarded. The expert opinion should be consistent with the facts and circumstances of the case. If an expert opinion contradicts an eyewitness or documentary evidence, it will not have an upper hand over direct evidence. Expert testimony is admissible only on the principle of necessity. जरूरत है तो ली जाएगी, नहीं तो नहीं लिया जाएगा. An expert's report shall be addressed to the court and not to the party on whose behalf he is examined. So report will be given to the court. Expert opinion is only corroborative evidence. It must not be the sole basis of conclusive proof. Very, very important thing is that an expert witness must be subjected to cross-examination in the court. And his opinion is admissible only when an expert is examined as a witness in the court. Unless the expert gives an appropriate reasons for his opinion and being tested during the cross-examination of the opponent party, it cannot be admissible. Please note that. Now, what is the real function of an expert? It is to put before the court all material so that the judge, even though not an expert, may form his own judgment or his own opinion, which is the only relevant opinion at that time, using its own observation of those materials. The general rule is that the opinion of the judge only is relevant in deciding the case. It's not your opinion. However, Section 45 is an exception to this rule as it permits the expert's opinion to be relevant in deciding the case in some particular situations. However, there are certain gray areas. I cannot see the clock. There are certain gray areas. The jurisprudential concept of negligence defies any precise definition. What is negligence? Opposite of diligence. How can you quantify that? Jacob Matthew versus State of Punjab states, is there a difference in civil and criminal law on the concept of negligence? We have debated that ad nauseum. Whether a different standard is applicable for recording a finding of negligence when a professional, in particular a doctor, is to be held guilty of negligence. Remember that same expert opinion may be viewed differently under varying definition of negligence under different laws of tort or criminal. What is the weight of evidence? The court considers various factors in determining the weight of evidence given to the expert opinion, which include the expert's qualification and experience, but more importantly, objectivity and coherence of their testimony with the evidence presented in the case. Very important thing again is that past court decisions in India have established precedents and the ratio kicks in regarding the admissibility and weight of expert opinion in medical negligence case. medical negligence malpractice cases sometimes involve disputes over the validity or weight of expert opinions present in the courts. There are multiple reasons for that, and they are differing interpretations of medical evidence, questions about credibility or impartiality of experts, because they are done day in and day out. Disagreements regarding the relevance of certain expert opinions to the case at hand. And judges evaluate the evidence presented before them, including expert opinions, and they reach conclusions not on the basis of the expert opinion. They reach conclusions based on the applicable laws and legal principles. Please remember, applicable laws and legal principles which you do not know anything about. The courts have full powers to derive its own conclusion upon considering the opinion of the experts, which may be adduced by both sides very cautiously. The very important point again is that opinion could be admitted or denied. Whether such evidence could be accepted or how much weight should be given lies within the domain of discretion of the court. It is discretion of the court whether to accept or refute that. So, an opinion or an expert opinion, something like this, that I don't know whether it is visible to you, that it is my considered opinion that drowning occurred due to a faulty room humidifier. Now that is stupid, right? So judge will certainly reject such kind of things. Now, disregarded expert opinion. Why would that happen? The first reference was made to Bolitho test in India in 2001 in Vinita Ashok versus Lakshmi Hospital. They said that if it can be demonstrated that the professional opinion is not capable of withstanding the logical analysis, the court would be entitled to hold that the body of opinion is not reasonable or responsible. Which means they have brought in the element of logic here, which was the element brought in first time in Bolitho in England. Bolitho has earmarked the erosion of medical protectionism, which gives greater effect to judicial discretion. So we have been talking about Bolem, but to a certain extent, even Bolem has been diluted. However, a dissenting judge in Bolitho judgment, Lord Wilkinson, said that it would be rare that courts would find competent medical experts to be unreasonable. There are certain challenges to expert opinion. For paucity of time, I'll just go through them, which are conflicting expert opinions, admissibility of evidence, judicial discretion, bias or credibility concerns, and legal standards. As I mentioned earlier, the judges must apply legal standards and precedents to determine whether the alleged malpractice occurred. Usually the courts do not substitute their views. Courts do not substitute their views for the view of the experts. Each case is unique and judicial decisions depend on the specific facts, evidence and legal arguments presented. We come to a very new area. New area is artificial intelligence. Role of AI as an expert as a topic has evoked considerable interest lately. However, Indian laws currently have gaps where it comes to determining the liability related to AI-induced medical services. Hence, the evidentiary value of artificial intelligence-induced expert opinion is dubious because laws have not kept pace. The opinion of an expert must be of corroborative nature. I have told you earlier, if the opinion contradicts the unimpeachable eyewitness or documentary evidence, then it will not have the upper hand. Experts are admissible as a witness, but they are not to make conclusion as it is. That is a function of the judge. What is the value of medical evidence? An expert witness, however impartial, please see that. An expert witness, however impartial, is seen to be biased in favor of the party who calls him, because otherwise he would not be called. Therefore, judges are supposed to be cautious and decide on the basis of balance of probability. Medical evidence isn't direct, and therefore the value of such evidence lies only on the extent to which it supports and lends weight to the direct evidence of the eyewitness. The Supreme Court of India has clearly said that it is the duty of the court not to occupy the role of expert by themselves. So therefore, Supreme Court of India has said that the value of the expert opinion in the eyes of the court for medical cases is heavy. Now we come to another issue. Opinion given by a medical board versus EMRB or State Medical Council. The medical board constituted by the Chief Medical Officer of the district is typically considered an expert opinion only. These medical boards usually comprise these specialists, as you know, and their assessments and opinions carry weight in legal proceedings related to the medical negligence cases. That is why it is highly advisable that if the case is filed against you in State Medical Council, you should defend it with all your might. Courts often rely on these conclusions, as I mentioned. The SMC and EMRB, National Medical Council, shall have the same powers. Please remember, they have the same powers as are vested in civil court under Code of Civil Procedure, but they are there only in certain aspects which I have enumerated, but I will skip that. That means they are not civil court themselves. They have powers only in certain aspects. So designated committee gives expert opinion and passes an order. This order so passed would therefore be called as quasi-judicial order. Now, how to challenge an adverse expert opinion? Review the expert opinion. You must go back, see what is the adverse opinion against you. You must review that expert opinion. Identify the weaknesses or inconsistencies in that. And on that basis, seek another opinion of another expert or another body of experts. Prepare counter arguments, write them, and present those counter arguments. But you are legally rightful in cross-examining and challenging the credibility and reliability of another adverse expert's opinion. Must document and preserve that evidence. I am not talking of documents of the case. I am talking of the documents of the legal proceedings, so that you can refer to them and you can counter them at the time if the opinion is adverse and is against you. Approach the challenge of an adverse expert opinion strategically and methodically. My last 2 or 3 slides. Doctors are scared to give expert testimony. Why is that? Because they feel that there is lack of confidence in preparing the report as per stringent requirements of the court procedure. And they generally feel, like most of us do, who has the time to waste for going to the courts on multiple hearings? What if I am cross-examined and I fumble? What if my testimony is rejected by the court? If the defense loses the case, I may be the one to be blamed. I don't want to spoil my relationship with the party in case malpractice had actually occurred. Ladies and gentlemen, to conclude, the experts help establish the standard of care and opine on causation. Expert opinion is considered relevant, but relevant opinion is not synonymous to the opinion being conclusive. Expert opinion are not binding and are only advisory. A contradictory expert opinion will not have an upper hand over the direct evidences, and weight of an expert opinion is determined by experts' qualification, experience and objectivity, as well as coherence of the testimony with evidence which is presented. And the courts have full powers to derive its own conclusion upon considering the opinion of the experts, but usually the courts do not substitute their views for views of the expert. It must be corroborative. Experts are admissible as witness, but they are not to make conclusion. opinions of boards set up by CMO are only expert opinion, but their assessment and opinions carry a lot of weight. As I mentioned, the orders passed by EMRB and State Medical Council would be quasi-judicial order, and I must urge that doctor must come forward to go give expert opinion. A little diligence is all it takes to save your colleague. Thank you very much, ladies and gentlemen. As there is paucity of time, you can write to me or you can ask me questions later. Thank you so much, sir. Thank you for permitting me.
Excellent, Ashwin, as usual. And it is so self-explanatory that actually there are no questions, but I have other questions which I'll ask you later. Great, great.
Thank you, sir. Very well explained about the expert opinion. Now I invite Dr. S.M. Yadav, sir, to felicitate Dr. Ashwini Setia, sir. Dr. S.M. Yadav, sir. Dr. Priya Goyal will felicitate Dr. Sumita Jain, madam. Dr. Gajraj Yadav and Dr. Dinesh Yadav will felicitate Dr. Anurag Dhakar, sir, and Dr. Suresh Vashisht, sir.
हेलो, इस कार्यक्रम के लिए जो कि हम सभी चिकित्सकों की एक वक्त की तात्कालिक आवश्यकता है, मैं डॉक्टर कांतेश खेतानी और उपचार के अन्य पदाधिकारियों को और जो मलंग है उसकी भी सभी पदाधिकारियों को बहुत बहुत शुभकामनाएं और बधाई देता हूं। धन्यवाद।
Please attention, please. Those who have not collect their certificates may collect one by one from registration counter. Thank you.
नमस्कार, हेलो, नमस्कार, खमा गणी। मैं डॉक्टर विवेक साबू इस सेशन का मॉडरेटर। टॉपिक फॉर दिस सेशन इज इंडेमिनिटी इंश्योरेंस, व्हाट शुड वी लुक इनटू, बाय डॉक्टर सुरेश वशिष्ठ। डॉक्टर वशिष्ठ को मंच पर आमंत्रित करने से पहले इस मंच की शोभा बढ़ाने के लिए आमंत्रित करना चाहूंगा हमारे चेयरपर्सन को, डॉक्टर सुनील गोखरू सर, प्रोफेसर एंड हेड डिपार्टमेंट ऑफ यूरोलॉजी, RNT मेडिकल कॉलेज उदयपुर, डॉक्टर सुनील गोखरू सर। उनका साथ देने के लिए उनकी धर्मपत्नी डॉक्टर अर्चना गोखरू, एसोसिएट प्रोफेसर डिपार्टमेंट ऑफ कार्डियोलॉजी, RNT मेडिकल कॉलेज उदयपुर। She is fellow of Indian College of Physicians, having more than 20 publications in international journal, and many more. Madam Gokru. चेयरपर्सन अपना स्थान ग्रहण कर रहे हैं। इसी दौरान मैं आमंत्रित करना चाहूंगा क्रांतिकारी और ओजस्वी वाणी के धनी डॉक्टर सुरेश वशिष्ठ। जब वो रूटीन में बोलते हैं तो लोग सुनते जाते हैं। आज मैं उनसे कहूंगा थोड़ा सा टाइम का ध्यान रखें क्योंकि उनको भी निकलना है शायद। ही इज ए कंसल्टेंट सर्जन जनरल एंड मिनिमल एक्सेसिव सर्जरी, मेडिको-लीगल एडवाइजर, डायरेक्टर मंगलम हॉस्पिटल गुरुग्राम, परमानेंट मेंबर बोर्ड ऑफ एडवाइजर। ओवर टू डॉक्टर सुरेश वशिष्ठ सर। थैंक यू।
मैं डॉक्टर संजीव देसाई साहब से कहूंगा कि प्लीज टेक द सीट ऑफ द चेयरमैन।
Oh, what a blessing! What a blessing! चैन की नींद सोना है तो जाग जाइए और अपने अपने चाय कॉफी के कप लेकर के आगे आ जाइए क्योंकि मैं आपका बहुत ज्यादा टाइम नहीं लूंगा। मेरे जो लेक्चर का काफी सारा हिस्सा हमारे मोटा भाई ने ले लिया, तो मैं तो वो वाला आदमी हूं जो गाय का प्रस्ताव याद करके गया था। बारिश का आ गया तो दिमाग लगाया कि बारिश कल उमड़ घुमड़ कर बादल आए, छम 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 बारिश हुई और बारिश होने के बाद में घास उगी, घास चरने गाय आई। गाय के 2 सींग होते, गाय के 1 पूंछ होती, गाय के 4 पैर होते। गाय हमको दूध देती, गाय हमारी माता है। इसे करके तो बड़ा मुश्किल काम है और एक्सपेक्टेशन बढ़ा दी साबू साहब ने। ना तो मैं कोई ऐसा वक्ता हूं, ये डिस्क्लेमर है, और ना मैं कोई इतना पढ़ा लिखा हूं, ना कोई मैं एक्सपर्ट हूं। मैं चोर हूं। बढ़िया बढ़िया चीजें जो मेरे को लगती हैं वो चोरता हूं, फिर परोस देता हूं। तो आपकी निराशा यदि आपको हो तो मुझे क्षमा कर देना, क्योंकि मैं षड्यंत्र का शिकार हूं। पहले तो आते ही हितेश भट्ट कहां गया? भाग गया। हितेश भट्ट ने आते डिप्रेस कर दिया मेरे को। बोले तुम इसका भी मेंबर है, इसका भी मेंबर है। मैंने कहा हाँ। तो बोले दोहरी सदस्यता में पता है ना जनता पार्टी की सरकार गिर गई थी और डुअल मेंबरशिप नहीं चलेगी। मैंने कहा मैं क्या करूं, मैं राजस्थान का हूं, उपचार का मेंबर हूं, एमएलएजी का हूं, क्योंकि डॉक्टर नीरज अग्रवाल प्यार करते हैं, लेकिन सिर्फ प्यार करते हैं। उनको पता है ये आदमी जस्टिस नहीं करेगा टॉपिक से, इसलिए मेरा टॉपिक सुबह था, उसको शाम को करवाया। शाम को करवा करके फिर हर एमएलएजी की कॉन्फ्रेंस में आई एम ऑलवेज इन्वाइटेड फैकल्टी, लेकिन मेरा टाइम 35 मिनट से शुरू करते हैं और छोटा करते करते 4 मिनट पे ले आते हैं। तो मैं इसको 1 मिनट में खत्म कर सकता हूं, लेकिन मैं जो कहना चाहता हूं आज जरूर कहूंगा। और आई एक्सप्रेस माई सिंसियर ग्रेटिट्यूड टू माई गुरु डॉक्टर पीके कोहली, हु गेव वैल्यूएबल इनपुट्स along with Dr. Rajshekhar, छोटा भाई और मोटा भाई डॉक्टर नीरज नागपाल, एंड ऑफ कोर्स द मोस्ट वाइब्रेंट एसोसिएशन आई हैव सीन, द उपचार, एंड जो ग्रुप्स की बात कर रहे थे दिन में, एमएलएजी जे ग्रुप, तो जैसे होता है ना एनवायरमेंटल ग्रुप, ये हमारा मेडिकल एक्टिविस्ट ग्रुप है। जो इससे जुड़ता है उसका भलाई होता है कुछ ना कुछ, और भला होगा। एक और डिस्क्लेमर है कि मैं डॉक्टर नीरज नागपाल का एजेंट नहीं हूं, और पहली बार ये मेरे को ऐसा टॉपिक जानबूझ के औंधरा पुंधरा टॉपिक देते हैं, तो मैंने बहुत मेहनत की, पढ़ना पड़ा मेरे को। मैं एक्चुअली लिखा पढ़ा हूं, जो लिखा होता है वो पढ़ लेता हूं, तो सामने बांस देता हूं। तो इस पे मैंने एक्चुअल में मेहनत की और कुछ नई चीजें मैं निकाल के लाया हूं जो मैं आपके सामने प्रस्तुत करूंगा। तो इसमें व्हाई देयर शुड बी इंडेमनिटी इंश्योरेंस, वो हो चुका कवर, नीरज नागपाल ने बता दिया। What, who, whom, how much, and what to read between the lines and out of box suggestions. So, यदि मैं एक छोटे से एक शब्द के अंदर में चाहूं तो उसको खत्म कर सकता हूं इस टॉपिक को। वो क्या है? Insurance is a subject matter of solicitation which insurance is to be asked for and not sold and not bought. Please state the term and condition of the document. क्या समझ में आया? ये सॉलिसिटेशन में बेचा नहीं जाता, ये सब कुछ वो एक लाइन में इतनी चीज बोल देती, ऐसे ये इंडेमनिटी इंश्योरेंस है जो समझ में नहीं आता है। इसलिए मैंने तो भैया प्रोफेशनल लोग रख रखे हैं, डॉक्टर नीरज नागपाल को फोन करता हूँ, मेरे को चाहिए, और अपने को देख करके खाली साइन करता हूँ। मैं एक्चुअली नहीं पढ़ता, क्योंकि एक शाना पढ़ा लिखा आदमी है, उसको हमने किस लिए बना रखा अपना चीफ? हाँ, वो बैठा हुआ भी है, लेकिन मैं एजेंट नहीं हूँगा, ठीक है। सो द फेजेस ऑफ रिलेशनशिप, क्वचित अर्थ है, क्वचित धर्म है, क्वचित मैत्री, क्वचित यश है, कर्माभ्यास है, क्वचित देश है, चिकित्सा नास्ति निष्फला, नारायण नमस्कृतम नरम से नरोत्तमम औषधम जाह्नवीतोऽयं वैद्यो नारायणो हरि। ये हम वो संस्कृति की बात कर रहे हैं जब एक्चुअल में भगवान का रूप था, लेकिन डॉक्टर्स को क्रेडिट कभी नहीं मिलता है। सुषेण वैद्य was a very very learned physician of Ravan, but when लक्ष्मण जी got that शक्ति बाण लगे उरी लक्ष्मण तीर्थ प्राण तजे सुतर, वो है क्या लाए संजीवनी, लखन जी आयो, क्रेडिट हनुमान जी को जा रहा है। वैद्य जो जिसने प्रेस्क्राइब की उसको क्रेडिट नहीं है, फार्मासिस्ट को, केमिस्ट को, या जो अपना डिलीवरी बॉय होते हैं जो कुरियर वगैरह, उनको सारा क्रेडिट दिया जा रहा है। तो पहले फिड्यूसरी रिलेशनशिप थी, मास्टर सर्वेंट, फादर सन, गुरु शिष्य, जिसके अंदर इफ ए पेशेंट डाइज और सम अनटुवर्ड इंसिडेंस हैपेंस, भाई टाइम बहुत कम कर दिया मेरा तो। सो उस टाइम इट वाज टेकन एज एक्ट ऑफ गॉड, गॉड्स विल, भगवान की मर्जी थी साहब। डॉक्टर बहुत अच्छे थे, डॉक्टर ऋषि भाटिया ने बहुत बढ़िया ऑपरेशन किया, बहुत शाने, पर हमारी किस्मत खराब थी। देन आफ्टर दैट इट बिकेम कॉन्ट्रैक्चुअल, वी आर अंडर द कॉन्ट्रैक्ट एक्ट, दिस इंडेमनिटी इज अंडर कॉन्ट्रैक्ट एक्ट। तो हमारे करार हो गया कि भाई तुम सर्विस प्रोवाइडर हैं हम, और तुम जो है सर्विस सीकर हो और या कस्टमर हो। एंड नाउ इट इज मोस्टली एक्सप्लॉयटेशनल। जब हम उसको एक्सप्लॉयट करते हैं तो उसको बदल दिया है कि वैद्यराज नमस्तुभ्यम यमराज सहोदर, यमस्तु हरति प्राणानि तमस्ते प्राण धनानि से। तुम यमराज के सगे भाई हो, यमराज तो सिर्फ जान लेता है, तुम जान भी लेते हो, पैसे भी लेते हो। दिस इज वेरी अनफॉर्चुनेट। सो आई विल स्किप दीज स्लाइड्स, बट few things which were missed. The new CPA 2019 is more consumer friendly. Why? Because there is a system of alternate dispute resolution mechanism which we can use for our gain. Then enabling filing from place of residence of worker or work of the consumer. Then the consumer commissions have the power to review their own orders, and the reduced court fee, and there is no penalty for false and frivolous complaints. So the alarming facts I will tell you, note the cases. There is exponential rise in the number of litigations, 400% increase after 2014. There are 4 lakh cases of deaths per year due to medical errors. 80% of the cases they involve surgery, when the obstetric and gynae taking top, 29%, followed by orthopedics and surgery at 22% and 17% respectively. 34% of consumer court cases, nearly 1/3, they involve negligence of hospital or doctors. And state-wise, it is the Punjab, followed by West Bengal, Maharashtra, Tamil Nadu, respectively. There is 110% increase in the cases of medical negligence in India. Every year, a case study at Nagpur, probably by Dr. Arora, it has revealed that 90% of all cases in medical negligence involve hospital, and 12% of total cases in the consumer fora, they are of the medical negligence. So this was the reason that in spite of the parliamentary intent, वो डॉक्टरों को खुश करने के लिए हमको कर देते हैं कि हम इनको बाहर रखेंगे, पासवान साहब ने दे दी, बट हमारी कोई कोऑर्डिनेटेड कोई स्ट्रेटेजी नहीं होती है, तो ये सारा बेरोजगार हो जाएगा, सिस्टम क्रैश हो जाएगा। वकील कहाँ से कमाएंगे, उनको क्लाइंट्स नहीं मिलेंगे, इसलिए इनको रखना जरूरी था to stabilize and keep our economy growing. And doctors are probably the only professionals who face the risk of financial liability in the course of practicing their profession. अभी ये जो सारे केसेस डॉक्टर नागपाल ने बताए, उसके अलावा 21 मार्च से आज तक 6 केसेस हुए, जिसमें 3 स्टेट कंज्यूमर यूपी के हैं, जिसमें 2 करोड़ का कंपनसेशन मिला पीपीएच में, और साहब लैब कोली में 40 लाख का, और पीपीएच हैदराबाद के अंदर था, उसके अंदर भी मतलब लैक्स में मिला है। Though it is an observation that an unscrupulous section of the people are prone to use the slightest opportunity to sue the doctors and hospitals, but they just say, आप जाएंगे तो आपको मदद मिलती है as a consumer. So indemnity insurance is a contract where the indemnitor, that is insurance company, agrees in exchange of a premium, that is consideration, to indemnify the insured doctors and bears the financial and legal responsibility in the event of a setback, adverse event, accident, error or other issue that may lead to loss, damage, injury to third party up to a limit. So the scope is to provide financial cover for the losses, litigation cost, liability from the year of the date of commencement, does not cover criminal liability, covers cost only up to the limit of the sum insured, and limit is fixed per accident AOA and per policy AOI. So it safeguards and provides peace of mind to the doctors against any third-party litigation for malpractice and negligence cases, and it is quite economical. My son is in Florida. I was discussing with him. तो जो हमारे यहाँ पे premium है इंडिया में, that is actually peanut, but it is going to increase. So now, if we consider compare from the West, it's quite reasonable. मतलब आप 50 रुपए ऐसा कुछ है ना 1 लाख का कितना 1000 का 50 रुपए ऐसा कुछ है वो इनको पता है टेबल का मतलब इस in 10,000 to 15,000 you can get a cover for 1 crore. Of course, it depends on your specialty. It provides coverage for your unqualified staff and technicians and ward boys. There is no separate legal subscription required, and it acts as a boon if used properly. But it could be bane. How it could be bane, we will just discuss. So it applies only to claims arising out bodily injury and or death of any patient caused or alleged to have been caused by error, omission or negligence. Policy through an intermediary लेना चाहिए, ये बेस्ट रहता है, bargaining power बढ़ती है if you take as an association, and they are quite expert. Cover U is there, MLS is there, IMLIA is there, Association of Medical Specialty, AMC is there, Medical Consultants is there. There are lot many groups, and it is definitely better because the premium is less, the protection is better, and they include extra, points and extra, in the policy, extra benefits, which could be of help in the long run. So what is retroactive date? Always check in your policy. Claims arising because of the acts done before the retroactive date are bluntly denied by insurance companies. So such acts which occur during the period of insurance and result in a claim being first made in writing against the insured during the policy period as stated in the policy schedule. So retroactive date का मतलब ये कि जिस दिन आपने पहली पॉलिसी ली और वो uninterrupted चलती रही, भले उस इंश्योरेंस के पास है या दूसरी कंपनी में आपने पोर्ट किया है, that needs to be continuously made. If it is breached, if there is a break in the continuity, then the previous coverage will not be there. And it is always wiser to take a separate errors and omission policy for your clinical establishment, which costs nothing. It's not only the personal insurance of the doctors, but the institution, particularly important for the small single-owned or say two-specialty husband-wife running a hospital. So it is always a good idea to take that insurance. What is AOI and AOA? The claims are incidence-based, so event-based. Any one incidence in a year, that is any 1 year, and any one accident. So this ratio could be 1:1, 1:2, 1:3, 1:4, and it is not advisable to go for others except 1:1. It is better to have an additional policy. Out-of-court settlement option should be there in your indemnity policy. Preferably, there should be no capping on it, and breach of confidentiality, loss of documents, and defamation cover we can get included. Usually, none of the indemnity policies cover claims arising out of fraud or dishonesty. Run off cover, आप यदि अपना retirement चाह रहे हैं, plan कर रहे हैं, तो you can take the policy for 3 years. so that if during that period you are protected if some case arises. But for surgeons it may be not true, because आज मैं किसी बच्चे का ऑपरेट करता हूँ 2 साल का, बच्चे को इंग्वाइनल हर्निया है, और उसके बाद में जब वो एडल्ट हो जाता है, उसके जब बच्चे नहीं होते दिखाता है, वो कहता है जी मेरी तो वास जो है उसकी ब्लड सप्लाई नहीं है या वास नहीं है, कुछ भी whatever it may be the reason. So he can just, because it is revealed now. Discovery is at that age of 21. तब तक हो सकता है हम मर जाएं, लेकिन यदि मैं जिंदा रहा और उस टाइम यदि केस हो जाता है, तो then that I will not be covered by that policy unless I have informed them. And then continuity, as I told you, the policy has to be live. Once it is broken, then all the benefits of the previous years are gone. Then we can get it including the mandatory security deposit as per the new act. If you are not satisfied with the verdict, you can file, but it is a hefty deposit, so we can get this thing included in the group insurance, and we can get the discounts and other benefits as I earlier mentioned. Who fills the application form? You yourself. मैं नहीं भरता, बात अलग है, क्योंकि मेरे को पता है, I trust a person, but it must be in your handwriting. You must read all the terms and conditions so that there is, because minor errors. ये इंश्योरेंस वाले बड़े एक्सपर्ट होते हैं, वो बैठे रहते हैं तलाश में कि कोई एक गलती दिखे और हम उसको डिनाई कर दें. क्लेम डिनाइल के अंदर बड़े एक्सपर्ट होते हैं. वो डॉक्टर नीरज नागपाल से भी ज्यादा सालों लोगों ने रख रखे कि डिनाई कैसे करना है. हाउ मच कवर? ऑन एन एवरेज नाउ द ट्रेंड इज 40-50 लाख से कंपनसेशन शुरू होता है, करोड़ों तक जाता है. तो इफ यू आर ए सर्जन, I will say something like 2 to 5 crore depending upon your practice and the type of patients. And if you are a general physician, and still if you are working in ICU and other critical care, any procedure if you are doing, take a good cover because it costs nothing. Ensure that unqualified attendants are covered. ये कई बार लालच देते हैं, डॉक्टर साहब का सस्ती पॉलिसी कर देता हूँ, and for few hundreds, I think it is 7.5% extra over the rack rate, we must get it done. All doctors need coverage. Now who doesn't need coverage? Hitesh Bhatt, he doesn't need coverage because he left medicine and he has joined the law. So if you are practicing, you have to take the cover. Whether you are intern, whether you are resident, whether you are government doctor, whether you are PHC, ESC, CSC, private, hospital, corporate, whatever. So these 3-4 slides are important. I am running short of time because time has been reduced. But this is a matter of association. This is important for the leaders of Upchar and IMA. So if you wish, I can discuss because these 3-4 intricacies. Dr. Rajsekhar, ये आपके उपचार के लिए मैं एक सामग्री दे रहा हूं जिसको आप उठा सकते हैं. तो should I continue? जोर से बोलो, चालू रखूं? Okay. Claims made policies only cover claims made of non-circumstances that you become aware could reasonably be expected to give rise to claim that arise during the period of insurance. So the acts or omissions may have occurred in a prior period, and as long as the act or omission was after the retroactive date, the policy will extend to those prior acts also. बहुत लंबा है. What is a non-circumstances? This is very important. ये 3 slide आपको फोटो भी ले सकते हो. A non-circumstance could be defined as any act, situation or circumstance which a reasonable person in the insured's professional position would have thought might result in someone making a claim against him or her. Therefore, if a claim arises after the inception date of the policy from a fact, situation or circumstance that the insured knew or should have known at a time of commencement of the policy that might give rise to a claim. अभी नहीं जा सकते, 5 मिनट रुकना पड़ेगा. Inspiration नहीं मिलती ना. It would normally be excluded as it arose from a non-circumstance. And it is all the more important to notify all non-circumstances. Why? Because by notifying all non-circumstances that might give rise to a claim during a policy period, an insured can get the benefit of the statutory rights under Section 43 of Insurance Contract Act 84, and Section 43 provides an insured with a statutory right to notify a circumstance. So it is very important to notify also. You can port from one insurance company to other, but if you have some non-circumstance, you notify to that also. and it's better to give in writing. So there are so many things which are not covered. It depends on the insurance company. Now private companies are also coming. I will not go into detail. There are exclusions. I will not go into details. Inclusions could be because of bargain, defense cost, third-party damage, breach, confidentiality, loss of documents, claim arising out of professional services. Mistakes you should avoid. Don't take only personal insurance. Always along with that take error and omission policy. Don't opt for cheaper policy. Don't take too small a coverage or a single policy. Try to get 2 or 3 policies. Not informing insurer is a big fault. Not taking coverage of unqualified staff, as I earlier said. And don't be in euphoria. मेरे तो आज तक केस नहीं हुआ है, मेरी तो सब मरीज जो है भगत है, मेरे पैर छूते हैं, ये सब नहीं रहना चाहिए. You should be vigilant about retroactive date, and you should not be careless in filing the proposal form. Now, can we, because हम लोग लड़ते हैं एसोसिएशन में, एक बहुत बड़ा एसोसिएशन हमारा राष्ट्रीय स्तर का, उसमें सारे नेता ही हैं, वो मैं नाम नहीं लूंगा, सबसे बड़ा है, तो उनकी अप्रोच अलग होती है, हमारी अप्रोच अलग होती है, सब ये लिप सर्विस करते हैं. तो मैं कहना आई प्रपोज दैट ऑल दीज इमिलिया, मेडिकोलीगल सोसाइटी ऑफ इंडिया, MLAG, कितनी सारी सोसाइटीज हमारी हैं, ये सब मिलकर के कैन दे collectively bargain with the insurance companies, bringing out a tailor-made policy which suits and fits that jacket, be fitted to every doctor, that is Chikitsa Kavach. Can I propose to have a federation of medical legal bodies of India? Dr. Nagpal? Jana nahi tha. So current system of liability in torts, it involves high administrative cost, judicial process takes years, derogatory comments and media, they lead to doctor-patient relation deterioration. There is no penalty for false or frivolous complaints. There are no set guidelines about calculation. Many decisions are reversed and re-reversed in appeal or revision. Many times the process itself become a big harassment, punishment and stress. So should we plead for mercy? जैसे हमारा बहुत बड़ा एसोसिएशन गया, जब ये CP अपने भारतीय न्याय संहिता के अंदर जो था, सेक्शन जिसकी बात हो रही थी आज 635, तो उसमें ये था, अरे साहब 5 साल की तो बहुत ज्यादा कर दी. तो ये बजाय कहने की कि why there should be inclusion, and जैसे गृह मंत्री ने कहा था उसको हटाओ, आज जोड़े साहब 5 से वापस 2 की कर दो. That should not be the approach. क्या मतलब ये कहें कि जी कम कर दो, हमारा compensation थोड़ा कम दिया करो. Why at all? So out of box thinking, and the necessity of reform is permanent, and this is the proposal. What it could be, there could be a mandatory screening by a medical negligence board before a complaint of medical negligence is being admitted. Mandatory penalty for false and frivolous complaints of the medical negligence. Consider no fault liability in medical negligence. This will ensure quick disbursement of compensation without exploitation, in contrast to the current scenario. So no fault liability is quite in practice in Finland, Sweden, New Zealand, Canada and Australia, but and particularly in New Zealand and Sweden it is working fantastically, and in India also it is being practiced in Motor Accident Act and clinical trial regulations. As fault or negligence is not on focus, it will improve reporting and hence reducing the issues. In no fault liability, the claims need to show that medical error was a causative factor, but for the resultant injury, irrespective of who is to blame. Although the application of no-fault system differs slightly in each country, but we can devise our own ways. Both tort litigation and no-fault systems, they share the same goals: compensate victims of injuries and debtors substandard care. So when the claim is being filed, compensation is granted or denied on the basis of a patient's eligibility. Although the medical causation is necessary, it is not the only condition. Compensation will not be paid for an unavoidable injury or if the injury is a consequence of risk assumed in order. So the basic social insurance schemes, they cover persons for medical expenses. They likewise, the amount of reimbursement from other insurances that can be deducted, and this can be formulated. This is little detail, I will not go through. So it could be a simple, filling of form. Then there can be, representation from the parties. It goes to medical negligence board. They decide if the compensation is being awarded. It's okay. So कहने का मतलब ये है कि जैसे आप टिकट करवाते हैं रेल का, आपका 1 रुपया 2 रुपया कट जाता है, ऐसे किसी भी पेशेंट का हम ट्रीटमेंट करें और उसका एक इंश्योरेंस उसका हो और फिर वो कॉर्पस बनता रहे, फिर हमारी बॉडी सारी एक हो, उनके डिफाइंड रोल्स हैं, कितना कंपनसेशन होगा, कितना इंटरेस्ट होगा, कैसे दिया जाएगा, लाइफ के लिए क्या करेंगे, लॉस ऑफ वर्क और वेजेस के लिए क्या करेंगे. सो एवरीथिंग कैन बी, आई थिंक, डिसाइडेड एंड डिटरमिन्ड एंड कैन बी स्ट्रीमलाइंड इफ वी विश, इफ वी फाइट यूनाइटेडली. इफ पिछले साल हुई थी फाइट, सड़कों पे आ गए थे सारे, सरकार को झुकना पड़ा, तो आप झुका सकते हैं. आई एम थैंकफुल टू सुरेश and Dr. Kamal. I am sorry, sir. I am just leaving, taking your blessings. Thank you so very much. मेरे को तो नहीं दिया ना, नहीं मेरे को तो आंसर देना नहीं आता.
थैंक यू सर. आपका जो टर्म्स एंड कंडीशन छोटे छोटे शब्दों में लिखी होती है, आपने उनको बड़ी अच्छे से समझाया है. जो चिकित्सा कवच आप बता रहे हैं सर, दैट शुड बी मैंडेटरी. अगर ऐसा होता है देन वी कैन क्लब इट टू रजिस्ट्रेशन. कोई एक एमबीबीएस स्टूडेंट अपना क्लब मींस कि हम हर डॉक्टर को बोलें कि दे हैव टू टेक इंडेमनिटी.
वो तो मैंने खाली नाम दिया है. दिस इज इंडेमनिटी इंश्योरेंस being negotiated with an insurance company with our terms because our number matters. हमारा नंबर होगा तो प्रीमियम भी कम होगा, एक्स्ट्रा बेनिफिट्स भी हम उसमें ऐड करवा लेंगे, उसकी कंडीशन हम अपने मनमाफिक करवा सकेंगे. दैट इज माय सजेशन.
करा सकते हैं सर. हम अपने स्टूडेंट्स को भी बता सकते हैं कि जैसे अपना मेडिकल रजिस्ट्रेशन जरूरी है, गवर्नमेंट ने किया हुआ है, हम अगर बोलें कि ये भी जरूरी है, दे शुड डू इट.
वो तो फिर एनुअल प्रीमियम होगा, इनका सब वहीं से सेंसिटाइजेशन होना चाहिए.
यस.
Excellent presentation, Suresh. Suresh was my junior in medical college, and I have known him as a good orator since college days. And now I see that you have blossomed excellently as an orator. It was a fantastic presentation, Suresh. And
Sanjeev, I am meeting after a long time. He is my senior from Jodhpur, and he is a very renowned ophthalmologist. Thank you, boss.
थैंक यू कौशिक सर. थैंक यू सो मच. मैं स्टेज पे मौजूद सभी सम्माननीय डॉक्टर्स का फैसिलिटेट करने के लिए आमंत्रित करना चाहूँगा. सबसे पहले डॉक्टर सुनील गोखरू के लिए डॉक्टर अक्षय मीणा. डॉक्टर अक्षय, प्रेसिडेंट किशनगढ़ ब्रांच उपचार. डॉक्टर संजीव देसाई का इंट्रोडक्शन रह गया था, मैं उसके लिए माफी चाहूंगा. डॉक्टर संजीव देसाई एक रिनाउंड ऑप्थेल्मोलॉजिस्ट हैं और राजस्थान ऑप्थेल्मोलॉजिक सोसाइटी के अध्यक्ष हैं. उनको फैसिलिटेट करने के लिए मैं आमंत्रित करना चाहूंगा डॉक्टर अमित व्यास फ्रॉम कोटा. डॉक्टर अर्चना गोखरू को सम्मानित करने के लिए मैं आमंत्रित करना चाहूंगा डॉक्टर पूजा साबू, कंसल्टेंट गायनेकोलॉजिस्ट, जयपुर. और लास्ट में डॉक्टर सुरेश वशिष्ठ को सम्मानित करने के लिए माफी चाहूंगा. Most welcome. थैंक यू सो मच. वापस स्टेज का संचालन डॉक्टर अशोक गर्ग के हाथों में.
थैंक यू विवेक फॉर एक्सीलेंट मॉडरेशन. विवेक के बारे में छोटी सी बात बताना चाहूँगा. कल मैंने सब मॉनिटर से मैं पूछा थोड़ा सा ना अपना शॉर्ट इंट्रोडक्शन दो सो दैट आई कैन ब्रीफ ऑन द स्टेज। भाई ने एक लाइन लिखी जो किसने नहीं लिखी, मैरिड विद 1 वाइफ विद 2 किड्स। बंदे का कॉन्फिडेंस देखो, ही लुक्स सो इनोसेंट कि अभी कोई प्रपोज ना कर दे। So for next session on the next session is on a snitch in the patient's data may be dangerous, and for that session the moderator is Dr. Ajay Singla from Abu Road. He is laparoscopic and general surgeon at Mahavir Surgical Hospital, Abu Road, Siroi, and he is also a state advisory board committee member of Upchar. So Dr. Ajay, the stage is yours.
Thank you very much, Dr. Ashok. It's a beautiful topic. A snitch in patient's data may be dangerous. Play safe, stay safe. So I would like to call Dr. R.M. Chavda. He is President of North Delhi Physician Forum as a chairperson. Dr. R.M. Chavda. Dr. Ghulam Ali Kamdar, General Secretary, Upchar, Jodhpur. And Dr. Giridhar, General Secretary, Fana, Karnataka. Now, our speaker for today is Dr. Suresh Badamat. He is a professor of psychiatry, head Forensic Psychiatry Unit, Telemedicine Center, Adult Psychiatry Unit, and Digital Academy, National Institute of Mental Health and Neurosciences, NIMS, Bangalore. He is MBBS, MD, DNB, and there are a few more stars in the galaxy, like postgraduate diploma in medical ethics and law, postgraduate diploma in human rights and law from National Law College. Also, he did a PhD in law from National Law School. He had 405 publications in national and international journals, including editor of 13 books. Have won many awards. Notable ones are Sir C.V. Raman Young Scientist Award and Professor Raghuram Young Teacher Award. He is a TEDx talk speaker also. So there is, sir, please, stage is all yours.
Thank you. Yeah, thank you very much. With the permission of the chair, I can start, sir. Okay. How many of you are using EHR, electronic health records? If you are using EHR, EMR, if you are keeping the data on the computer, this presentation is for you, because I'll be discussing about Data Protection Act 2023, which was recently gazetted. So I'll be discussing about the various concepts and also how. The data means basically which is there on computer, which is related to the patient. Or it can be you have already kept the data on paper, now you are transferring onto the computer. So we are talking about digital data. Some of them are personal patient's data. Non-personal. What is non-personal means basically if you are carrying your mobile phone and that phone is giving information to the Google telling that in this road how many people are there. So those non-personal data, and finally the critical data where the data is used for altering the sovereignty of the country. It can be related to military, it can be related to the election which has recently, in the previous election, somebody tried to manipulate. So these are the data, but we need to understand between two important concepts before we enter into this. One is privacy, another one is security. Privacy means we are sitting here, all of us, we have our own mobile phone. How my data is private. Privacy means with regard to the individual. Security means security of the perimeter, security of the whole data. So that's the difference. Privacy is for individual, security is for the complete data. Another example I can tell you is you have data of your patients. The individual patient's data nobody can see, even your colleague. That is privacy. What is the security features you have adopted to the computer, that is security. Moving further, the complete is called as data protection. I will not go into the details of this. This is basically European principles which have been adopted into this legislation. Moving further, this is how the evolution of our DPDP Act, which was passed by the Parliament. And one of the important landmark Justice Puttaswamy's judgment came from Bangalore, which was appealed to the Supreme Court, whether Aadhaar card biometric, is it fundamental right? And in this landmark judgment, Constitution bench clearly said that, yes, privacy, data privacy is basically a fundamental right. This is regarding to Aadhaar judgment. From that day onwards, the Supreme Court was asking what you have done to get this legislation. So then the legislation went on. So this is the various route it went. I will not go into the detail because we have little time. So I am introducing directly to the Digital Personal Data Protection Act, which has a very little penalty, which is around 250 crore rupees. Okay? So how it will come and how it can ruin your practice. Moving to this is the legislation which came in recently. These are the chapters, but we will be concerned about the first 4 chapters. This is where the whole scenario lies. Rest of this is a procedure, having the board, all those things. So now moving to what is the need for this legislation? The need for legislation was we need to have the data privacy. At the same time, we need to allow for innovation. Imagine AI is coming or is already has come. If you are going to protect the data completely, not allowing to see anybody, then we will not have any artificial intelligence. So this is basically a marriage between innovation and regulation. The best example I can give you is, because many of you are OBG gynecologists are here, the way ART Act has been come, Surrogacy Act, the regulation has become so high, suddenly everything is falling down. Similarly, Transplantation of Human Organ Act, where the regulation is very high, the transplantation has come down. But here somehow they have tried to marry this, but we will discuss about whether it is right or wrong. There are various definitions. Data, it's event, we all know. The personal data is individuals, patients' data. Here I'll be using something called as data principle. The principle is patient. The data whom it belongs. Suppose you have an Amazon app, you are the data principle. With regard to the hospital, the patient is the data principle. Next comes is data fiduciary. Who is the data fiduciary? Who is going to collect? The doctors and the hospital are the data collector here, so they are called as data fiduciary here. And comes to data processor, who is going to process the data, who is going to analyze, or who is going to store. What is the processing means? This is the definition of the process. Process has very lengthy definition, collection, analyzing, all these things, retrieval, alignment. So that is processing. Even if you store somewhere else in the cloud, it is also called as processing. Moving to the data protection officer, I will be discussing that. Digital office, where the office is there, where you need to have an officer. And personal data breach. What is data breach? Is mentioned clearly. It is not just a hacking. Accidental exposure. Somebody else is able to take it or is unable to authorize access his own data. All this comes into, even destruction is considered as breach. So it is not just only hacking. The whole definition of breach is here, because on this basis only the compensation will be given. Coming to where does this law apply? It applies inside India, outside India also. What does it mean? Imagine we are, of course, the data generated in India, so that data will be applicable. But imagine you have a mobile phone, iPhone, the data is sent to US, their server. So again the law is applicable there also. So any goods and services, goods sold, imagine you have a Dell computer, the data is something is going there. Or you have devices, 95% of the devices what we use in the hospital, some or the other data goes to the other country. That means it is applicable there also. It's not just the data which is originated in India, but also which goes outside because of certain goods and services. Services means best is Microsoft Office. It is a software you are using. So all those, again, it is applicable there. And it is not applicable for social media where you are uploading your own data. or you are processing your own household data, that is not applicable here. So that's what the application is not here. Moving to processing of the data. Again, the data principal has to give the consent. Basically, the patient has to give the consent to use the data, or if the person is child and disabled, family member has to give. So now the question is, if your son, tomorrow, I think in another 2-3 months, the law will be applicable. Your children, if they are using Facebook, they are below 18, you have to give consent. That is how the law has been written. But anyhow, it is not applicable. But again, especially for the social media, coming to the processing of the data, this is where the whole crux remains. It says consent of the data principle. The patient has to give consent, or the parents, if they are children. Legitimate use has been made here. What is this legitimate use? Here, if the state or the institution provides services, imagine it may be other services or the cylinder services, any services is been provided, then again, it can no need to take any consent. It will take the data. The government will take the data. Or even maybe COVID vaccine they are providing free of cost. They may ask some data you have to give. Or else don't take the service, full stop. Similarly, data like birth and death related data. There also, it is a legitimate use, no need to ask for consent there. By the virtue of law, what is that? By the virtue of law, the NMC Act says that you have to retain the records for 2 years or 3 years. Or by the virtue of MTP Act, it says you have to keep for so many days. So that data, if you have to keep, means you have to keep. If the patient says destroy the data, because here the whole data says that the patient or the data principal has a rights that please remove, means they have to remove. That is like, suppose you have Amazon app and you say I don't want this. If you send him, please remove my data, they have to remove. That is how the data has been, this law has been written. Coming to exemption, court, crime, all those related, they have given the exemption. There no need to ask the data principal or the patients or anybody, because I'm using patient here because we are discussing about the hospital. Moving to the legitimate use of data, especially with regard to doctors. The two important is, if it is required by the law, even the patient says delete, it cannot be done. You have to be obliged by the law. And in case of medical emergency, you can use the data, retrieve the data, and taking measure to provide medical care. So these are 3 areas where we can use the data, but if something goes wrong, you will be held responsible. But again, the consent is not required. That is the only thing I would like to emphasize here. And if you are working in a government hospital and you are using the data, no problem, because government has been exempted by this legislation to some extent. But if you are a private, you have to have the proper mechanism in place. What is the obligation of the data fiduciary? What is the obligation of all of us? That is you, me, the hospitals basically are data fiduciary. You take the data. This is what it says. Follow the law. Whatever the law is there, don't break the law. That is basically it says. And you take consent. Like suppose POXO Act is there. I want to show child's photograph and the family has given consent. That is not allowed. That means it's a violation of the law. So again, and suppose if you are processing the data by giving it to somebody else. Example I will give you. Suppose you have given, like if you have brought a ECG machine and the data is going to somewhere else for the analysis. Okay? And it goes to a server, maybe in Hyderabad. Something may go wrong in between. Who will be held responsible? For that you need to have a valid contract with whoever is analyzing the data there. That means the ECG machine. And if you are storing there, you need to have a valid contract. What does it mean? If you know HIPAA compliance, you will be able to appreciate. Nowadays, if you are going to buy any device or any services which is related to data, you need to ask them, do you comply with this DPDP Act? Show me the certificate. That valid contract should be there, because nothing may happen in your hospital premises. It may happen somewhere in the Hyderabad or somebody else, the device, or maybe the server is hacked. You will be called in because you are the data fiduciary. You have taken the data. So that's what the whole thing crux remains. So you need to ask for the compliance of this legislation, whatever you buy for the hospital. Moving to okay, suppose if there is a hacking or the data goes missing or it gets corrupted. immediately you have to inform the board and to all the patients. Please remember, I'm again repeating this. If you don't do this, only 150 crore rupees fine. 150 crore rupees is the fine. So you need to inform the data protection board and also to the patients whose data has been missing or it goes somewhere else. Coming to you need to appoint a data protection officer in your hospital because he is going to maintain the data, and if there is any grievances there, he is going to address those, and also he has to be involved in data auditing. Who is going to access the patient's data, who will not have access, anybody can access or not, all those things will be taken care by them. And as far as understanding, all the hospitals are considered as a significant data fiduciary because we will be having a sensitive data. That means you need to be extra cautious. That's what the law says. What are the rights of the patients here? Rights of the patient is basically, this is what, in the hospital, it is the rights of the patient because the data belongs to him. At the same time, you are a data principal wherever you are using your apps. It may be Uber app, wherever. There, right to summary of the personal data. What does it mean? The patient can ask, give me the personal data, what are those? You have to give him. If you say, wherever you have sent my data, wherever you are stored, with whom you have agreement or contract, please provide that. You have to give that information. You can't say I have kept it somewhere. You have to give all that information. If he says erase, you have to quote certain law and say I can't erase this by this virtue of law. Otherwise, somewhere else, everybody has a right to erase their data. That's what the rights of the data principle, and you can nominate somebody as the owner of the data. For example, I will give you, Dr. Suresh Vashisht may have a YouTube channel which is running smoothly. He have around 10 million subscribers. Tomorrow something happens to him. He can give this to his children and he can nominate his son to run the YouTube channel, or he can close it. Nominating, even social with this, whatever your data is there can be given to somebody else. That's what the right has been given. So duties of the data principle, that means here the patient, he cannot give you false information. If he gives false information, false ID, somebody else's name is giving, the punishment is 10,000 rupees for the patient. So need not worry about that. So coming to final part, the data protection board is there. That will be already been, I think in the rules they will be notifying who will be there, how many are there. Moving to the penalty, this is the worst part. This is how much it says. It may extend to 250 crore rupees if there is a breach. Okay? And breach in observing the obligation to give the board affected data principle, we have to notify them. If you don't do that, it is 200 crore. Breach observation and obligations you are not fulfilled, 2 crore again. So you will be paying compensation in huge amount, and if you are using your own whatever computers or the data you are storing, you have to be very careful. That's what it is said. Coming to the final part of my presentation, basically it is, I have around 2 minutes. So let me be very clear, this law appears to be very good, but if you are going to have your own data, running your own show, you have to be very careful. And you need to do data auditing. As the data becomes big, you will become a significant data fiduciary. You have to make sure that it does not get breached, and you have to have at least valid contract with all the people whom you are going to share the data of your patient. It doesn't mean that only EHR. Without your knowledge, a lot of data are going to be synchronized, either it may be in the cloud or somewhere else. So you need to know how it evolves. But anyhow, this is how the impact on health industry, legitimate use of data, which I have told you. Okay, this is the one important thing what you have to do in the if this law is completely implemented in your hospital, you have to follow this. I'll be sharing this PPT to you so that it is small, I will not be able to tell. So with this, I'm going to stop so that you can ask questions. Any questions, please?
With permission of chair, may I ask?
Yes, sir, please.
2 questions. One, there is Health Breaks. I don't want to name, but Health Breaks is a company which gives you for a prescription, and the total data, what you feed there, is saved by them, and it is not saved in your computer. So here, the total liability will be of the physician who is feeding on it. Is it correct?
Yes, sir, because you have to have a valid contract, and there the contract you have to write. If anything goes wrong on their end, they will be held responsible. You will be zero liability. That DPDP Act compliance, you need to have a valid contract.
Okay. Second, so many times the government officer, maybe a CMHO or a deputy collector, he wants to have your documents. Now, ideally, only the court can order, or if some sub judice thing is there that they
By the
can
virtue
ask
of
for data.
legislation also they can ask.
No, this legislation gives the power up to which officer that they can ask for these data.
So there they will not ask data if there is this. Basically, this legislation does not repeal anything. It is an additional legislation. Additional legislation means you have to follow IT Act, TOA Act, MTP Act, whatever all the laws are there, you will follow that. One more additional law is there. We had, I think, approximately 54 laws as a healthcare professional. This is the 55th law we have to follow.
Exactly. Now, if this law violates one of the previous laws, which will prevail?
This will prevail. Good question, sir.
Thank you.
If there is a fight between if both the laws are supplementary, it will go. If there is any fight, this law prevails over that.
Basically, this law, a part of that, goes against the PCPNDT Act.
This will prevail.
Right? And MTP Act.
Yes, this will prevail.
In MTP, you have to have a separate register which should remain with superintendent. Right? And this information should not go to anybody else.
Yes.
But
No,
here,
it doesn't say. That's a good question,
MTP
sir.
Act. I am saying about MTP Act.
MTP Act, this law is very clear. It doesn't say don't give it to anybody. You have to follow the law. There is a MTP Act law is there. You have to share the data you are sharing. It says, see, you will follow the law. That law also you have to follow. You can't say that this law will prevail over that. No. It says it is IT Act is there. You have to follow IT Act also. You have to follow this also.
Thank you.
Dr. Suresh, that is my temptation. By saving the prescription, do you think it is a data preservation?
Sir?
By saving the only prescription, it means you are saving all the data of the patient?
Yes, sir. It will be, if you ask me the prescription, if it has a sensitive data and the patient thinks that his data has been breached, if he gives a complaint, you may be liable. Let me be very open to it, sir. It's just a prescription. If the patient doesn't feel anything, no problem. But if they take it very seriously, it will be an issue.
How many of you save the data? You yourself, or you have kept the person? Myself. Very few persons are. Secondly, in India, the technical issues are there. Nobody is trained in our doctor, especially in doctors. Doctors are not expert to save the data. It is a big problem. And virus आ गया है. 5 दिन आपके पास कंप्यूटर ठीक करने वाली नहीं. How can you save the data? 5 दिन आप क्या करोगे? Okay. It is a big problem. So very difficult.
Yeah, sir, that is the reason you need to be very careful. This is a big industry if you ask me. Now, if you are going to have a data saving on your computer, or you are going to third party, or you are hiring a software industry, you need to ask them to have DPDP Act compliance certificate, and also you should tell them if something goes wrong in your side, you will be responsible, and something goes on my side, I will be responsible. Full stop.
IT people are so smart, they can take the data immediately. आपके हाथ से 1 मिनट चुरा के ले जाएंगे.
Yes, sir.
Sir, we are saving the data in EHR, not on cloud or anything else. And if the computer goes off and data is lost, patient comes, erase my data.
So it is already erased, no, sir?
No, but he said, prove me in front of me that we are erasing or we have erased.
Sir, if that is called as a data breach. If it is get erased, it is a breach. You have to notify the board. You have to notify the patient, telling that your data has been breached. Now the board will decide whether you have taken a reasonable degree of care or not. It is, again, this law doesn't say 100% compliance. It says reasonable degree of care. What does it mean 100% compliance? Sir, because of electrical fluctuation it has happened, no problem. Sir, I have done, my data protection officer is there, I have done audit, I have a reasonable degree of security measures like firewall, all those things. It is the data erased.
No, because computer crashed.
Yeah, fine. Then they will say, okay, there will be no punishment.
No, but right now I don't have any record to whom to inform.
No, that the data protection officer board and also all the patients' email address, phone number you should have. As soon as it happens, you have to inform them.
No, but where to store them? The computer got cached.
You need to have a backup, sir.
So
that's what. See, this is a big industry. It is going to grow, and
training is required. Training is required.
No, keeping the backup is also a risk because when you keep backup, it goes to other computer. Every computer cannot be under your control.
There is a virus. Virus will insert all the data.
I don't know. And only problem to the person who is having a problem, wrong data entry, 10,000 fine.
So it may be not only patient. I am giving certain data to Uber. If I give false information, I will be the data principal at that time. For Uber, Ola, Amazon, giving false information, they can also, you have to go to the data protection board, they will charge 10,000 rupees. And false complaints, again, is a punishable offense. Here it is again 10,000 rupees.
So what is the logic they have given to keep the crores of compensation for data breach or data loss? Any compensation reason was given of 2 crore rupees or 250 crore rupees?
Because
what is the logic?
Logic is simple, sir. Our data has been sold like everything, anywhere, anyone. You check in to the hotel here, next day onwards you'll start getting calls, sir.
Yeah.
Jaipur mein site hai chahiye. So that kind of data is selling to another people and patients' data are getting breached. So they want to see to that the data is kept safe because the Supreme Court in the important decision, that is the reason Justice
Should not we ask the government to keep the data with them and we just enter into their system?
Very good, sir. ABD is the same. Ayushman Bharat says that we need to have the data which the government is taking responsibility. Who knows, tomorrow if you are all agree to ABD, they will definitely consider. Now the rollout is occurring into the government hospitals. They are taking, and the government, if there is a data hack occurs with the government will pay fine to government. So it doesn't make any sense. They are exempted. So government doctors who are sitting here, don't worry.
Now, Suresh, you mean the digital locker for the
Sorry?
data? Locker for the saving the data by the government.
Sir? I'm sorry, sir. I don't have the answer for that.
Rupees indemnity policy insurance we can't bear.
I don't have answer for that, sir.
No,
Who
amount
knows?
of 250 crore rupees covering, the insurance will be too high.
Yeah, right, sir. Right.
And suppose we don't keep any data?
That's a, if you keep a, like physical pen and paper, this will not be applicable at that time. This law will
only
not
for
be.
digital data.
Ah, right. This is very clearly digital data.
Yeah, no, but pen and paper also have their mobile number and other things.
No, sir. Okay, but it will be individual patient here. It is the data which will be sold. That is the reason they are worried. Pen and paper. I'm not going to say that, but okay. Thank you very much, sir. Thank you.
Thank you, sir. Sir has shown the future and the dangers in the future. I would like to request chairpersons to please felicitate Dr. Suresh for this beautiful session and all the way coming from Bangalore. I would like to call Dr. Ajay Jain from Seeker, Dr. Virendra Agrawal from Kota, and Dr. S.M. Yadav from Kotputli. From Jaipur, sorry, for felicitation of the chairpersons. Dr. Ajay Jain from Seeker, Dr. Virendra Agrawal from Jaipur, and Dr. S.M. Yadav from Kotputli.
Thanks, Dr. Ajay, for wonderful moderation. And the next session is on communication, counseling, and consent. And for that, okay. So I request Dr. Raj Sekira, the boss, to provide the certificate to Dr. R.M. Sabda, sir. So a small introduction about Dr. Avnish Oja, the moderator of the session. Dr. Avnish, always charming face, always smiling, और सबका चहेता from UG time, from in the PG, he was my colleague in PG and even after PG, और सबका से मतलब आप समझ गए होंगे. अवनीश भाभी जी साथ में आइए कुछ और बोलूं. सब ठीक है. So Dr. Avnish is general physician, sonologist and endoscopist, and he is running his hospital in Nivai by the name of Oja Hospital along with his better half. And he is also considered the travel guru, market guru, investment guru of the Upchar. So overall, he is a multi-talented personality. So I request Dr. Avnish to come on the stage and start the proceedings.
Thank you, Ashok. Ashok was my PG mate in JLN Medical College, Ajmer. So we have many chit-chat memories. Hello everyone, I am Dr. Avnish Oja. Before our esteemed speaker start session, it is a great honor that I invite our distinguished chairperson to join on the stage. Please give a warm welcome to Professor Emeritus Dr. Dharmdas Jethwa sir, Dr. Durga Jethwa ma'am, and Dr. Dheeraj Verma sir. Dr. D.D. Jethwa and Dr. Durga Jethwa are esteemed Professor Emeritus at Mahatma Gandhi Medical College in Jaipur. They both completed their undergraduate and postgraduate studies in anesthesiology from prestigious SPMC Medical College, Bikaner. Since joining Mahatma Gandhi Medical College in 2001, Dr. D.D. Jethwa and Dr. Durga Jethwa ma'am have played instrumental role in shaping the medical infrastructure and services of the institution. They were pivotal in establishing the operation theatre, various ICUs and super specialty divisions, demonstrating their commitment to providing state-of-the-art healthcare facilities in the community. Their dedication and expertise was further evident in their involvement in Mahatma Gandhi Medical College first organ transplantation, a landmark achievement that underscored their pioneering spirit and commitment to advancing medical science. Dr. Dheeraj Verma sir is Principal Specialist, Additional Medical Superintendent in County Hospital, SMS Medical College, Jaipur. So today's topic for this session is communication, counseling and consent. Ladies and gentlemen, esteemed colleagues, it is my privilege to introduce our distinguished speaker for today's session at the National Medical Legal Summit 2024, Dr. Kamal K. Parwal. Dr. Parwal illustrious career span over 3 decades, during which he have made significant contribution to the field of the orthopedic surgery and healthcare management. With a master's degree in orthopedics, MBA in healthcare services, LLB and diploma in Gita, Dr. Parwal embodies a unique blend of medical expertise, managerial acumen and spiritual wisdom. Hailing from New Delhi, Dr. Parwal currently serves as a medical advisor and director at Akash Healthcare Super Specialty Hospital in Dwarka. As a practicing consultant orthopedic surgeon in Janakpuri for the past 36 years, he has garnered immense respect and admiration from peers and patients alike. Dr. Parwal's commitment to excellence extends beyond clinical practice. He has been empaneled with NBEMS as Senior Consultant Orthopedician and Accreditation Assessor and has held pivotal roles such as Chief of Medical Services Akash Healthcare, Medical Superintendent at Bhagat Hospitals. Additionally, his active role in various medical associations including Delhi Medical Association, IMA Janakpuri and DMA underscores dedication to advancing the medical profession. In addition to his professional accomplishment, Dr. Parwal is also a prolific author and a spiritual thinker. Alongside his wife, Dr. Sadhana Parwal ma'am, an ophthalmologist in New Delhi. He authored, produced, and narrated a complete Hindi poetic translation of Srimad Bhagavad Gita titled as Shri Govind Gita. His special prayer for medical fraternity is widely acclaimed and serves as a ceremonial vandana at fraternity meets. Please join me in extending a warm welcome to Dr. Kamal K. Parwal as we eagerly anticipate his enlightening session on communication, counseling, and consent. Thank you. Sir.
Thank you so much for those kind words spoken. First of all, I extend my sincere gratitudes to the organizers for calling me to my hometown, and Jaipur being my native place, Rajasthan being my native state, I am no outsider here. So I am coming to my topic, respected chairpersons and the august audience. I am very, in fact, delighted to see a large number of august audience till this fag end of this wonderful summit. And the topic given to me are in fact three: consent, counseling, and communication. So I have to mix them up and really make them precise for the given time. So just moving to the So communication, counseling, and consent are three cornerstones of all the healthcare business nowadays. Communication is, we have to, the need of communication, the importance of communication, and the skills cannot be overemphasized. We have to learn those skills in today's era. Counseling is a very specific type of communication when it is spoken in terms of, in the perspective of the healthcare. And consent is in fact the legal documentation of whatever communication we make with our patients and whatever counseling we really do for them. And why this is all necessitated? Because gone are the days when doctors were considered demigods or superhumans. Doctor-patient relationship used to be sacrosanct, based on mutual trust and faith, but now it is no more there. Gone are those days. Now is the era of mistrust, era of Consumer Protection Act, era of allegation, litigation, violence, and era of hostile authorities, regulatory bodies, judiciary, media, political priorities, and political questionings are taking over the public good. And the last line, the whole basic melody to this profession today is era of commerce and law is dominating the science and humanity, which is considered the soul of medical profession. So there is no place now for any kind of assumption, any kind of presumption, paternalism, complacence, and there is no place for not accepting the ever-changing socio-economic and educational status of the society, ignorance of ever-changing regulatory and legal provisions, as you have seen just now, DPCP with 250 crores of penalties easily, and closing our eyes on consumer expectations now, consumer activism and consumer vigilantism. So healthcare communication, importance cannot be overemphasized because poor communication is the biggest cause of dissatisfaction leading to all sorts of these maladies, and good communication is the best and the only and the most effective preventive tool for all above allegation, violence, litigation, and effective communication requires engagement between the parties involved, because if either party lacks it, the whole purpose is ruined. So communication is, we have to communicate with the patients, with the attenders, with the care providers, within our fellow fraternity in terms of, say, whenever to make some handover or referrals or transfers. The communication may be formal or informal, may be verbal as in the spoken words, and may be non-verbal in the body language. So communication have certainly three elements. There is one sender, there is one receiver, and there is a message. But the message is only communicated back if there is a good feedback, then only we know the communication is complete and correct. So the communication needs to be clear, it has to be concise, it has to be in fact correct and given to a correct person also. It has to be concrete, coherent, continuous, consequential, confidential, complete, and of course courteous, then only it is all effective. So the communication requires speaking skills. The speaking skills are speak slowly, clearly, speak appropriately, no medical jargons, speak to the understanding of the receiver. We say something to the nurse, we hardly recognize whether the nurse is the level of nursing superintendent or a nurse supervisor or just first year joinee. We just communicate to her without understanding that whom we are going to communicate, what is the understanding status of that particular person. Use appropriate terminology, avoid medical jargons, ask open-ended questions, and make sure that your non-verbal gestures, which are most important, are consistent with the words spoken. But more important than speaking skills are listening skills. Because listening also requires to maintain a very positive attitude, very good eye contact. You have to be attentive, you have to show your interest, you have to be concerned about what is being spoken, and watch the expression of the speaker, because body language tells you much more than the spoken words. Avoid interrupting, and the most important point, avoid planning the response while listening, because it will just disturb the listening process. What we do and what our patients do, whenever somebody is talking something, we keep on planning that whenever he stops, I will ask this. So the good, important time of listening is lost, because in that particular time you are planning for something different. Ask for clarification as and when they are required. Now this is particular, I just wanted to share this particular thing, that whereas the spoken words comprises just 7% of the message, and the tone of voice comprises 38%. It is the body language only which comprises the maximum part of the message you are giving. So body languages can be of many types. You can have everything speaks. Your facial expression whenever you are talking, they speak. Facial expression can be neutral, can be disgusting, can be anger, can be sad, can be fearful, can be exclamatory, can be frowning, can be just not interested. Your gestures can be, it speaks so many things. Having a good handshake or good bye-bye, or just pointing the fingers, or just I just hardly care. These kind of expressions make something, just beating the drum, biting the nail, or just pricking your nose, or just keeping your hands into the pockets, or just having the facial support like this, or something. So every situation, every particular kind of expression speaks too many things. The tone and modulation of voice speaks, as I have said, it contributes to not less than 35% of your message conveyed, and eye-to-eye contact requires it. And say the person with that hardly interested, no eye-to-eye contact, you can just imagine what kind of communication is being done. But certainly those postures are not good as far as profession is concerned, so they also communicate some different kind of message, wrong or right. So this was what about body language, I'll just go through. And then there can be good formatting of the communication. What are the formal communication required on day-to-day basis in the healthcare setup? ISBAR is a tool, we all know it, for handover whenever your resident medical officers or nursing officers hand over their duty, what should be the communication skills. It has to be formatted for proper documentation also, and to save you in the court of law if at all the case such arises. There can be good format made for the inter-specialty references, that what is the kind of reference, what for a particular referee has to come and see, is it urgent or is it not urgent, and whatsoever. And then there can be a good format for patient transfer, either within the hospital or for outside facility. This is what I was talking of, ISBAR handover. I'm not going to know the details because it's a particular thing. Those who are into quality business and those who are having their quality accreditation, they all know it. These kind of documents are most minimum required. There are certain situations when the communication skills need to be enhanced and what they are normal. And enhanced communication in healthcare is a definite reality. It arises whenever there is some kind of, you have to break the bad news, you have to share some kind of terrible diagnosis, you have to disclose the adverse event happening to you, happening to the patient, to the attenders. You have to handle the aggressive patients or aggressive attenders, or you may have to manage some kind of aggressive employee, or communication in some special situations like emergency or disaster, or managing any other argument. So these are the enhanced situations, special situations you need to have enhanced, you need to develop some kind of protocol for those kind of enhanced communication. And those communication can be, it has to be done by senior executive and senior doctors only. And primary consultant should always be involved. Because the patient is there in the hospital for the primary consultant only. Because he is the only one who is giving something to the patient. Rest all are taking something from the patient in terms of billing or money or time or whatever it is. So primary consultant is the person to whom the patient and attenders are having maximum amount of faith. So in such kind of situation or exigencies, these primary consultants should always be involved. It should be with some kind of compassion, some kind of empathy, and in a comfortable environment. The fact should be communicated clearly. Further action plan should be categorically explained. That is what is the problem. If you have to say, break the news of person's death, now you have to have the empathy and compassion and tell them what is happening now. Because once something unprecedented occurs, some stunning news goes to the patient, so they are just aghast. They just can't decide what happens. So you have to provide them all kind of logistics and guidance. Okay, we are packing the body here, we are keeping it in the mortuary, you have to take this transportation, or we will provide someone, or this or that. Those kind of guidances should be provided to calm down the atmosphere. But a special attention should always be given to the security and safety of the hospital property and the personnel. And never waste much time to call local police if any such threat is looming all around. Above, communication should be preferably video recorded, and every such situation, that is the most important, should be analyzed after the event. That whatever has happened, where was the lack of miscommunication or the reasons for it, they should be analyzed, and the results drawn, conclusions drawn should be percolated to each and every staff member, because that is the education learned. There are many communication barriers. Barriers can be physical. You are communicating to some person who is not within the reach of your voice or of your sound waves. और बीच में कमरे के पीछे से कुछ भी बोल के कहीं पे भी चले गए, शीशे का दरवाजा बंद था, आप कुछ भी बोल के चले गए. Then there can be some cultural barriers. What I am talking, the person of a different culture might just not be taking it in that sense. There can be gender barriers. A man talking to female, they have many limitations. Then there can be language barriers. We talk to our other colleagues who may not understand the language you are speaking, English or Hindi or whatever is in the language. There may be certain emotional barriers, but the most important are organizational barriers when we talk within our organization. So communication skills, styles should be very specific. There should be no social distance. Organizational structure should be like that, that the information sharing is authentic. Information overload should not be given to the employees or within ourselves. Lack of trust should be avoided. There should be clarity, consistency, and frequency of the information being shared. Then only organizational barriers will be minimized. I'm just how to cross those kind of physical or emotional or cultural barriers, because we may have to paraphrase the sentence. Whatever I am speaking to you, if it's not taken up by you because of some kind of barrier, I have to revise the sentence in a different manner. Or there can be some kind of reflecting. I can support my narrative with some kind of examples. But important is we have to keep a good working environment so that if the message is not understood by the other, he can certainly ask clear, open-minded and open-ended questions. And that only happens when the environment is good. A poor first-year student or a first-year nursing student will just be scared if the environment is not good. And whatever you have said, you think that she has understood, but she has not, but she will not ask. And you should always have some kind of standard and authenticated communication channel. In the organization, sometimes the communication is given by WhatsApp, sometimes by through email, sometimes by through Messenger. And if the communication channels are not standard in today's era of information technology, then the information's authenticity is always lost or compromised. And check any grapevine communication, whatever rumors are there, you have to check. Your all communication strategies has to be monitored, and whatever the lessons learned should be imparted upon the whole staff. So coming to the counseling, because I have to cover 3 topics, my time is running short, I'll seek another 2 minutes, more than that. Because quite often people are very anxious whenever they visit any healthcare facility because vulnerability or apprehensions. So healthcare counseling is a concept that amalgamates the principle of biology, psychology and medical sociology, aiming to infuse sense of positivity, which is certainly essential for balanced decision making and optimism of recovery in the patient. So we'll just be short with the counseling. Counseling allays the necessary apprehension. A multidisciplinary counseling session helps putting the combined perspective of the management of different specialists. When patient is confused, 4 specialty उसका इलाज करिए, patient confused रहता है. तो एक pattern हर किसी hospital में होना चाहिए. Multidisciplinary team meeting should be there. May be repeated, may be video recorded, so as to explain the patient the whole perspective of the entirety of the disease, and not the cardiologist saying something in the morning and nephrologist comes in the evening, says something, and respiratory physician says something more. So counseling should provide a special knowledge not only for the medical treatment but for the preventive, promotive and rehabilitative aspect of the medical conditions. It should respectfully use the cultural, religious and spiritual traditions of the counseling, and empathy is much more important than the sympathy. Coming to the consent, consent is the willingness of the patient to subject himself for examination, and consent is based on the moral and legal premise of the principle of autonomy of any individual, as envisaged in Nuremberg's Code, Helsinki Declaration, Indian Contract Act, CRPC, NMC regulations, but most importantly now superseded and described elaborately in some Supreme Court judgment coming in 2008 in famous Samira Kohli, Dr. Prabha Manchanda case. So consent can be implied or expressed. I am not going in detail into it. But the consent to be really valid has to be informed consent. And what is informed consent as described in Tabor's Medical Dictionary should have at least these 5 components: nature and the purpose, expected outcome, the alternatives, the likely complications, and the 5th one also included are the instructions concerning about what should be done if the procedure goes wrong. So what are the rules and norms of the consent? It has to be free, it has to be without fear, it has to be voluntary, it has to be direct to the person, and it should be informed, explained with the support of reports, it has to be unambiguous, it has to be understood, vernacular because different languages are being used in India, signature and the thumb impression of the person should be taken, and doctor and the member of the medical team must sign and must take the consent. It's not that कि nurse से जाके 4 number कमरे में sign करवा के आ जाओ. The doctor or the treating team person should be taking the consent and should be signing it. It should be fresh, preferably within 24 hours of the procedure. Quite often, an ophthalmologist friend of mine was asking the other day कि मेरा जब OPD में आया था मैंने अगले हफ्ते की डेट दी, उस टाइम consent sign करा लिया था. अगले हफ्ते आके उसका ऑपरेशन कर दिया, क्या ये वैलिड है? Yes, law तो कोई डायरेक्ट नहीं कहता, लेकिन it should be preferably within 24 hours of the proposed procedure. Consent of spouse is not necessary. There are special situations in abortion, pre-NDT invasive procedures. Guardian must consent for abortion in minors. Contraception, sterilization and ART requires consent of both the husband and wife. Separate consent for surgery, anesthesia. Audio-visual consent is legal, but it should be disclosed beforehand to the person that you are being monitored. High-risk consent or consent of death on table are also legal. Blood transfusion consent has to be separate from surgical consent. However, there can be common consent for additional procedures if they are contemplated at the start. Procedure-specific consent format should be developed, and that is the need of the hour now. And because many procedure-specific consent forms are now available online also, you can just download, just change that to your requirement and take it. Surrogate consents, now, because if the person is not able to give the consent because of, say, invalid age or maybe in good sense of neurological status, then surrogate consent or consent by somebody else can be taken, but one has to mention that why this surrogate consent is being taken, and it can be taken from the patient, from the spouse, mother, father, son, daughter, in that order, siblings, guardian, friends, but hospital staff should not be made the witness. Consent is invalid if it is the person is ineligible, consent is not informed one, insane, intoxicated person unable to understand the consequences. Yeah, I'm just aware, just take 2 minutes. Consent obtained by fraud, coercion, impersonation is again not valid. Consent given for a criminal or a wrong act is invalid per se. There can be no contract if it is against the existing law. Eligible age, we all know it, I am not going into details. Informed the refusal, because to refuse is a fundamental right, but you have to record the refusal also. Get it written and signed. If the person is not signing it, get it signed by the relatives. If they are not signing it, get it signed by at least 3 doctors of the hospital. And if there is facility of audiovisual recording, it is preferable, because quite often this happens in emergency. मुझे इलाज नहीं कराना, मैं जा रहा हूँ, बाद में कुछ हो जाता है तो कहते हैं इलाज नहीं किया. However, consent is exempted in many situations in emergency, only for life-saving procedure, only in emergency. Section 92 IPC protects you. Medical examination of the victim in criminal case, no consent is required, it is forced upon him. Medicolegal autopsy, nothing is required, it is a requirement of the law. Treatment of notifiable disease or psychiatric examination or examination of the prisoner, no consent is required. There are exceptions to the informed consent. That is the therapeutic privilege, therapeutic waiver. These situations are not very common in India, but yes, in Western countries they are there. A person can select, okay, I don't need this information to be given to me. He can waive the information receiving from the doctor because it may be harmful to him for psychological reasons. Likewise, a doctor can have the therapeutic privilege not to inform the same, everything to the patient. However, do not lie, but may not tell the whole truth. You can inform it to the attenders, not to the patient at times if such situations are like that. There are statutory authorization, as I have told you about the medicolegal postmortems or organ removal or vaccination. You don't require any extra. Now this is particular case, just 3 slides for this, because this particular case today governs the whole ecosystem of consent taking, and it has changed the whole perspective of it. Coming from Supreme Court in famous Samira Kohli versus Dr. Prabha Manchanda case, and it was delivered in January 2008, and accordingly, the para 32, the Honorable Justice says that we may summarize the principles. So all the guidelines have been laid according to this, and this is existing law as on the day, because common law, any decision given by the Honorable Court, it becomes a law. Doctor has to seek and secure the consent of the patient before commencing the treatment. That is there. Consent should be obtained, should be real and valid, with the capacity and competence of the person giving it, and it should be voluntary after adequate informations receiving. Then only it becomes informed consent. The consent given only for diagnostic purpose cannot be considered consent for therapeutic treatment, mind it. Consent given for a specific treatment procedure will not be valid for conducting some other treatment procedure. Because this is what happened. For the benefit of audience, I'll just take 15 seconds to explain. A person was taken for some kind of endometrial curettage because of endometriosis. That surgeon considered, because the hysterectomy will be the better option when the patient was under anesthesia. The resident was sent outside to get the consent taken from the mother of the patient. Patient was unmarried, somewhere around 40 or 45 years of age. So the mother consented for hysterectomy was conducted. Later on, when coming to the recovery, the person certainly because of some kind of billing dispute or something which triggered, and then there was a case against Dr. Prabha Manchanda. The whole case led to these particular things. The fact that unauthorized additional surgery after curettage converting to the hysterectomy, unauthorized additional surgery is beneficial to the patient. That was the plea taken by the defense. That would save the considerable time, and repeated surgery and repeated anesthesia is not ground of defense. That is what the clear words coming from Honorable Supreme Court in this case. What are the additional procedure? Only exception to the rule is additional procedure through unauthorized is necessary to save the life. OT के अंदर ही bleeding हो रहा है कि यहीं पे मर जाएगा, तब वो आपको एक exemption इस चीज का मिला हुआ है कि you can really do. However, there can be common consent. पहले ही आप दोनों consent ले लीजिए कि curettage or hysterectomy or both, then it is considered valid. The adequate information should be given to the person. Adequate information of just last 2 slides, because this is the most contemplated question. Many questions must be arising in your mind, that what should be told to the patient and what should not be told to the patient when the question is of informed consent. कितने कॉम्प्लिकेशन हो सकते हैं वो उसको बताया जाए, कितने नहीं बताए जाएंगे, ज़्यादा बताएंगे तो ज़्यादा डर हो जाएगा. उसमें सुप्रीम कोर्ट की गाइडलाइंस बहुत क्लियर है. द एडिक्वेट इन्फॉर्मेशन का मतलब है कि द इन्फॉर्मेशन should be disclosed by the doctors with all these things, alternatives, adverse consequences. But what should be the extent of information? That is what I'm doing. The extent of information need not be stringent and the highest degree mentioned in one school of thought, Canterbury, developing in USA, but should be of the extent which is accepted as normal and proper. So again, the Bolam principle is used here. What is a normal and proper, which is being done by the considerable number of people commonly, is the Bolam test, Bolam standard. But in America, Canterbury standards are being developed, where the onus of informing everything has come shifted to the doctor, which is called as real consent. So that should be there. However, the court has especially said there is no need to explain remote or theoretical risk involved, which may frighten or confuse a patient, leading to refusal of consent for the necessary treatment. Very specific words. Similarly, there is no need to explain the remote or theoretical risk of refusal to take treatment. Quite often we do it, just to persuade the patient to go for treatment. कि भैया इलाज करा ले नहीं तो मर जाएगा, 3 दिन में तेरे को ये हो जाएगा. तो इतना भी कहने की जरूरत नहीं है, because that is again showing your. So court is very clear, balance should be achieved between the need of disclosing necessary adequate information and at the same time avoid the possibility of the patient being deterred from agreeing to the necessary treatment or offering to undergo an unnecessary treatment. So because this has been given verbatim, whatever court has said, you can always say it. What is real versus informed consent? The real consent concept developed in UK based on Bolam's principle, that जितना ज़रूरत हो, जितना आमतौर पे बताया जाता है, उतना बताया जाए. But in American courts, the real informed consent has this particular emphasis, because in the last line, shift the emphasis to the doctor's duty to disclose. And that's that last two. But the last slide, the court has said, we, however, consciously prefer the real consent concept evolved in Bolam and Sidway, in preference to the reasonably prudent patient test in Canterbury. However, just last paragraph, and then I'll say goodbye for the time. If the medical practitioner and private hospital becomes more and more commercialized, then if there is a corresponding increase in the awareness of patients' right among the public, inevitably a day will come when we may have to move towards the Canterbury standards, which is there in Canada, America, and Australia right now, but not for the present, because the court has realized the Indian realities and therefore given us some kind of leeway for the present. But if the things deteriorate further, then they have no choice. Thank you for your kind patience. Thank you so much.
Thank you, Dr. Kamal K. Parwal, sir, for delivering a captivating session on communication, counseling, and consent. Your expertise and passion illuminated important aspects of these topics, leaving us with valuable insights and tools to navigate these areas effectively. On behalf of everyone here, I extend our sincerest gratitude for sharing your knowledge and expertise with us today. Your contributions undoubtedly enriched our understanding and with positively impact our practices moving forward. Now, I invite Dr. Santosh Dhaka ma'am, Senior Gynecologist Junjunu, and she is also a General Secretary of Upchar Maitri, to please come over the dais and facilitate our guest. Dr. Owen Meena, who is a Senior Physician in Government Hospital Nivai, to come over the stage. Dr. Avdesh Jain, who is a Senior Pediatrician, Honor of Namokar Hospital at Nivai and Upchar member, and Dr. Lakshya Mittal, he is a National President of United Doctor Federation. And now I ask our chairpersons to please facilitate our speaker. May I ask Dr. Kantesh Khetani to please hand over the certificate to Dr. Laksh Mittal. Please, Dr. Laksh Mittal. And may I ask Dr. Shivani Purohit to please come over the dais and take your certificate.
Greetings, ladies and gentlemen. I have been asked to moderate this next session. I am Dr. Kantesh Khetani from Upchar. First of all, I would congratulate the audience present here. In the month of April, we are seeing an August audience. The patience, the focus, the substance of the audience is remarkable, and it is really motivating. For the next session, since we are running out of time, I would like to wrap up the session quickly. So not wasting much of your time, I would invite the chairpersons first. First of all, I would like to invite Dr. Anup Hajela ji. Dr. Anup Hajela ji, he is the president of Madhya Pradesh chapter of AHPI. And he's the owner of Hajela Hospital in Bhopal. Then I would like to invite Dr. Rahul Khare ji. Dr. Rahul Khare ji is the secretary AHPI of Bhopal. He is the owner of Manisha Hospital. And both of them are very active in the state of Madhya Pradesh as far as the welfare of doctors and hospitals is concerned. As a third chairperson, I would like to invite Dr. Anwar Ali Sahab. Dr. Anwar Ali ji is the General Secretary of Kerala Private Hospitals Association. He is also the Secretary of FANA. FANA is the acronym for Federation of Private Hospitals and Nursing Home Association of India. The topic of this session is, what is the role of federations in uniting the state level associations? As we all know that at the local level we have multiple associations catering to the welfare needs of different categories of doctors and of course hospitals. But usually these local associations are active only at the local level, at the most at the state level. What if their voice is to be reached to the national level? For that very purpose, the concept of federation, whether it is really useful or what are its pros and cons, to share the experience on this very topic, I would like to invite the President of FANA India, Federation of Private Hospitals and Nursing Homes Association of India, the President of FANA India, Dr. H.M. Prasanna sir. He is an orthopedic surgeon running Pristine Hospital at Bangalore. And he is also the executive member of Indian Association of Orthopedics. And FANA is actually such an initiative which aims in uniting all the local state level hospitals and private doctors association into a single national level federation. So I would invite Dr. Prasanna Sahab to please take his place on the podium. Dr. Prasanna sir.
Good evening, Jaipur and Rajasthan, and greetings from the Federation of Private Hospitals and Nursing Homes Association. And I thank Dr. Khetani, Dr. Rahul, and all the members of Upchar for providing a podium for me to talk on the Federation. I'll be brief, I'll not bore you. because we just want to ensure that you all know what is the main purpose of making this federation. Because already we have FICCI, we have Nat Health, we have AHPI, and IMA Hospital Board also is there. In spite of this, what we have seen, like FANA Karnataka is about 20 years old, and FANA Andhra Pradesh is almost 32 years old. So all these organizations have been there because we need somebody to take care of the needs and to listen to the hospital owners and the hospital entrepreneurs who are running the nursing homes. It can be a single specialty, multi-specialty, or it can be a corporate hospital also. What happened, we were members of FICCI and Nat Health for a long time. But FICCI is a very vast body which has a lot of commercial entities in that, and they were unable to focus on the particular needs of the hospital owners and the hospital enterprises. So we thought, why don't we start a South Zone chapter? In the initial, the concept was to have a South Zone chapter of 5 states. But then we realized, why not make it an all India body so that all of us can join together. Nowadays, we are seeing that there are a lot of issues which concerns at the national level, where we need a representative body of hospital owners at the New Delhi level to fight for, like, it can be GST issues, it can be income tax issues, it can be now, all of you are aware, now we have filed an interim petition as one of the parties in the ongoing like the trial which is going on in the Supreme Court, where there is a PIL on fixing of tariffs for private hospitals. So this has been taken up under the Central Clinical Establishment Act. So somebody had to fight for our rights. We have to take care of ourselves, because IMA has been busy protecting the rights of the individual doctor. They have been doing a phenomenal jobs, even pre-independence time to now. But as a hospital body, it is strong in few states, but in few states we don't have any representation properly. So all of us have joined hands, and last March was the time we launched this federation in Bangalore, and we had nearly about 12 state associations which joined that day. And many more are in the pipeline, because most of the states didn't have a proper hospital body. Like for example, in Punjab and Haryana, we didn't have a FANA of Punjab and FANA of Haryana. So those state bodies also have been formed, and they have joined the federation. And in Himachal Pradesh, Uttarakhand and Chhattisgarh, even Bihar doesn't have a proper hospital body. So all this was necessitated, and we are working with those state bodies, because as you know, the requirements for a hospital is totally different than from an individual doctor. So there are various aspects, like in some states you have nearly about 45 regulations affecting and your licensing. So somebody has to represent, including Pollution Control Board. Recently we represented to the government of Karnataka, because the Pollution Control Board charges were hiked by almost 400%. There, FANA Karnataka, I was the president, we took up with the state government, the Environment Ministry, and we could get a rebate of nearly about more than 75%. The same thing, when we work as a federation at the national level, definitely we will be heard. As a first sign of victory, recently when there was a meeting about Ayushman Bharat rates, even the federation was one of the invitees there. We went in, represented, gave our suggestions how Ayushman can penetrate all the private hospitals, provided they do a scientific costing. The same thing now regarding this CGHS rate, which is looming over our head. Dr. Arora is sitting here. We took his help in drafting our petition, and I hope he has approved it and it has come out well, and we are going to file a intervention petition and hope it will be taken up and we become an impleading party. So a lot of good things we are doing, so that this creates a good ecosystem for our private hospitals to work up with. See, you can't be working like this on a ad hoc system forever. The second thing which we are working as a federation is working with the General Insurance Council. We had a meeting few months back in Mumbai, where we represented all the private hospital bodies, and our suggestions have been taken up, and still that fight is going on to set up a scientific committee to do a costing for those 140 packages which the General Insurance Council has taken it under the GIPSA. So as a united body, definitely we can achieve a lot of good things in the future, because I foresee if we don't unite and fight this, it's bleak for the private healthcare sector. You can't work with CGHS tariffs for all private patients and the whole private healthcare industry will crumble. What will happen to the FDI coming into the country? What will happen to the investors who have invested billions of dollars into the medical industry? So we are answerable to our own self as professionals who are putting in our manpower. So many times, most of us work without realizing what is the cost we are incurring per procedure or per day in our hospitals. It was an eye-opener. We did a good costing study in Karnataka. The package rates for those 140 procedures, how we have arrived at, how scientific calculation has been done, that we have shared with all the state associations now. I would love that Upchar and other organizations of all the states will take up this methodology and do their own costing, because we have given a criteria to everything, to the place where it is, whether it is rented or it is owned. Even if it is owned, we have taken the costing as a rented premises. So that, see, we are giving our own premises and not thinking out of a rent, earning out of it. And you are putting in as a owner 14 hours, 16 hours per day, but how much you are getting back? You are happy as long as you get your revenue to match your expenditure. That's what most of us have been doing all these years. But where is the returns for your investment? And your manpower hours, what you are spending? You are not earning even peanuts for that. So this costing study was a good eye-opener. We had a good interaction even with IMA Hospital Board. They had done their own costing study, but it was grossly incorrect. So we have pointed out to the IMA also, adopt a scientific way of costing. Please do it so that multiple organizations, we do a similar costing study and present it to the Government of India and to the General Insurance Council. Then nobody can neglect us. They can't just show us away, no, this is incorrect. So that's what a lot of good work we are trying to do. I have just made a beginning. It's not that federation belongs to any one individual or any one state. It belongs to the whole country. Somebody has to take the flag and keep it going, do better things in the future, and our aim is to create a good ecosystem for the private healthcare sector. That's what we are doing. These are the three things. And the fourth important aspect, as I told you, we are also working on the NOCs for the fire norms. See, because each state has a different type of fire norms. The national building law tells something, the state building law tells something. So we need to create a uniform guidelines for this, because as we see, there are fire accidents in the hospital, there is a knee-jerk reaction from the judiciary, it passes some law in a state. And it is quite harsh sometimes. So we are also working with the Environment Ministry to create a national guidelines for exempting the smaller hospitals and clinics from this NOC, fire NOC criteria, so that any building which is more than at least 21 meters and above should need a fire NOC. So below those buildings which are below 21 meters should be exempted from the fire NOC system. And that already the government of Karnataka has passed that law. And same thing we can replicate in other states. In Tamil Nadu, they have much more worse building bylaws. So if we have a national guideline properly done, it really helps each one of us. And as a country, when we are united, the guidelines also should be similar to all the states. Indifferent attitude by different state governments has put a spoke in that. But it's a fight which we are taking it up. And then was the biomedical waste management system. Again, it was very indifferent and totally arbitrary level of charging in various states. So we are fighting irrespective of the category of the hospital or the bed strength. We are telling you charge per kilogram of the biomedical waste which is generated per day. You charge little more. Sometimes what happens, all the hospitals will not be full. Even you have a 100-bed hospital, you may have just 40-bed occupancy. But some states, they are forced to pay even for those unoccupied beds for the biomedical waste management. So these few 4 or 5 things, we have taken it up on priority, and I have Dr. Anup, who is also part of the Federation, Dr. Anwar Ali is a General Secretary who is very dynamic, and to tell you, Kerala has done a phenomenal work in the judicial work. They have also won lots of cases in the High Court of Karnataka and Kerala, and in the Supreme Court also. So they have a vast knowledge which they bring to the Federation. So each one of us can utilize our knowledge together and make this Federation more vibrant and more cohesive, so that we help one another and make a stronger union, so that we want to be a collaborative, constructive body to work with the government system. We don't want to work with a leftist attitude, always agitating or confronting the government agencies. We need to engage them and get the works done in the right way by putting up the right kind of notes to them and making them understand the requirement of the private healthcare sector. That's this one which is required for the day. That's where I stop, and I'd like our senior members to add up if I have left something. This is where we stand, and I would request all the states to join the Federation who have not joined and make this a stronger body so that our voice will be heard, just like Picky and Nat Health. And we work with the IMA. We are also not confronting with the IMA. Always IMA is like a mother body for all of us because it's been there for a long time, more than 70, 80 years. But our requirements are specific, and we would like to stick to that requirements and work to fulfill those achievements. Thank you for a patient hearing.
Thank you, Dr. Prasanna. We are very fortunate that you have come here. And I am Dr. Anup Hajela. Firstly, I am director of a private hospital, myself owned entrepreneur. And I am the president of AHPI MP branch. I am also the Center Council member of the Federation of the Private Hospitals and Nursing Home Association. And I am also the president of one unique organization which exists in Bhopal, is the United Doctors Federation. This federation has all the other associations, including private nursing home associations, the IMA, the AIMS Association, the Medical College, Medical Teachers Association. So under this United Doctors Federation, it's under a big umbrella, all the doctors are there. So whenever there is a common problem or a problem that comes, all the doctors of Bhopal gets united, and we fight against that right of that doctor or that association or that particular hospital, may it be a government medical college or an institute or a private medical college. And we have won many battles and reverted many absurd orders of the government, like suspension or So the association, because in MP was the first state in India, in 1973 we have the MP Nursing Home Act, and it was implemented in 1998. So in 1998, it was the problem of the MP Nursing Home Association that joined all the hospitals. Usually associations, they start from a problem. Like Upchar also, they have shown the way in the whole country that unitedly you can do anything or we can do anything. You have turned down the Right to Health Act. That was a big achievement, and the show of my lot of congratulations to you, Upchar. And I need and we need such type of associations in the country, because like see, in the latest BNS Act, all the drivers went on strike for one day, and that part of the act is now under review. So doctors can do anything. If all the doctors stop work for one day, it can bring down any government. So if we are united, we can do anything. We got the Doctors Protection Act in MP. We got a stay on the Nursing Home Act and got all the rules changed, and the act changed in 10 years, then it got implemented. There was moves, there are central acts for which we have central bodies and all the federations. Then we have many state acts because in the state acts. But I think the most important thing, the state acts or the central acts, the implementation of the various acts. The implementation of these acts are different in different parts of the state. So we need to share what is going on in your state, what is going in our state. So whatever is beneficial, we should adopt that thing and go to the proper authorities and get that thing implemented in the interest of all our doctors' fraternity. So this is my humble request. We should keep on sharing the problems and give them inputs also if there is a problem in one state and it has been solved in the other state. And I think now the federations have started, the Upchar has started. Our federation was there in 1998. The time has come when we should all be united, and because of the WhatsApp and all those things, it is very easy to get united and to share the information and get benefit out of what is going on in the other state, what problems, how it can be solved. And through the AHP I am getting information. We have your Rajasthan last, this year only we had a conference of the AHP National Conference in Jaipur itself, last year. It was a big conference. All the doctors of various states had come. Okay, Dr. Prasanna has a flight, so I request Dr. Anwar or Dr. Khari if they want to add something.
Yes, one thing, that Federation of the Private Hospital Association is a unique association in the way that it comprises of hospitals from all over the country, where most of us are hospital owners, and we know where the shoe really hurts. There are other organizations like Nat Health, HPI are there, but most of them are comprised of CEOs of various hospitals, and that is the problem. They don't understand the problem of small hospitals. Hence, this organization was very much required, where our day-to-day problems can be addressed, and we can represent them in an united manner. Thank you. Thanks a lot.
Dr. Prasanna has a flight to catch at 7. So I'll just say one word, Saath raho, kuch bhi namkin nahi hai. And that has been proved by Upchar.
Thank you, sir. Thank you.
All the best. Thank you.
Now I would request the chairpersons to please felicitate our speaker. And I would request our Upchar members, Dr. Arun Sura, Dr. S.L. Soni Saab, and Dr. Ajay Mishra ji, to please felicitate the chairpersons. Dr. Arun Sura, Dr. Ajay Mishra, and Dr. S.L. Soni Saab. डॉक्टर एस.एल. सोनी साहब, डॉक्टर अजय मिश्रा जी, हमारे वरिष्ठ चिकित्सक साथी हैं एस.एल. सोनी साहब, और अजय मिश्रा जी सीकर से उपचार के कोषाध्यक्ष हैं। थैंक यू डॉक्टर अनूप हजेला जी, डॉक्टर राहुल खरे साहब, डॉक्टर अनवर अली साहब, thank you. And now for the next session, as a moderator, I would like to invite a member of Upchar SAC, Dr. Rajpal, to please take over.
Good evening, everyone. This is the last session of today's event, and the topic of today's last session is sudden OT death. And for this topic, I would like to invite our chairpersons. First, I would like to invite Dr. Deepak Shah sir to please come and chair the session. Dr. Deepak Shah. Dr. Deepak Shah sir is orthopedic surgeon at Bhopal, and he is a qualified lawyer, LLB also. He is past chairman of Legal Cell of Indian Orthopedic Association and at present advisor to MP Nursing Home and Hospital Association, of which he was president and secretary in the past. I would like to invite Dr. Ala Prasanthi ma'am to chair the session. Dr. Ala Prasanthi ma'am is MBBS, DA and LLB. She is medical director, Tulsi Multi-Speciality Hospital, Guntur, and she was president in Indian Society of Anesthesiologists, AP State, 2022 and 23. Ma'am is also secretary, Andhra Pradesh Private Nursing Home Association, Guntur. I would like to invite Dr. Leena Jem ma'am to chair the session. Dr. Leena Jem ma'am is MBBS and sonologist and presently working as a sonologist at Sai Spurs Hospital and Arihant Ultrasound Central, Loharu, Haryana. For this session, I would like to invite our speaker, Dr. Ashok Sharma sir. Dr. Ashok Sharma sir is a consultant urologist at his own clinic in Maitri Hospital, Kota. Sir was first, established first urology clinic in Kota division, and sir was also very much in academic activities and invited faculty in many national conferences and workshops. So it's over to you, sir.
Thank you, Dr. Raman. Thank you, chairpersons. With your permission, I am starting. See, I am the last man batting. और बाकी लोग तो सब कानून के ज्ञाता थे, कम्युनिकेशन स्किल्स के भी ज्ञाता थे. My talk doesn't represent any law or communication skill and not written anywhere. What I have compiled is the experience I have generated in last, say, about 30 years of practice. मृत्यु शाश्वत सत्य है, उस पर शोक करने की कोई आवश्यकता नहीं है. ये केवल गीता में ही लिखा है, पर जिसके घर में हो जाती है उससे पूछो और जिसकी टेबल पे हो जाती है उससे पूछो, दोनों के क्या हाल होते हैं. तो इसलिए गीता की तरह लेना चाहिए, बट व्हेन इट कम्स टू रियलिटी, life is very difficult. Hospitals have 3 types of deaths: natural expected deaths, unnatural expected deaths, and unnatural unexpected deaths. And management of all 3 types of deaths are different. In the expected deaths, natural expected deaths occur in terminally ill patients, old age patients, and when we expect that patient is going to die, just try resuscitation. If not successful, declare death, complete the formalities, and shift the patient to the home. That is the easiest way, and most of us are doing it. The other type of death is unnatural expected death. The causes of unnatural expected death are accidents, polytrauma. The suicide attempts, poisoning, snake bites, and other unexpected life-threatening emergencies. And all of us in our hospitals get these patients. So what should be our action? Because the one way we think we are gods, we have to treat patient, but there are risks too. And of course, every patient comes to our hospitals, it gives money too. So we are always at other side of the story ki kuch to aayega. But that is not the ball game. Ball game is you have to admit these patients only if you have the optimum facilities and specialists available. And once patient is admitted, this patient should be admitted to ICU, all the concerned specialists to be called, proper recording of the vital signs and all actions to be taken. And immediately police have to be informed for this happening, that there is a suicide death or poisoning or polytrauma. And if the patient dies, then getting the autopsy done is mandatory in all the unnatural expected deaths. But if the facility is not available, as per the Supreme Court guidelines, we are duty bound to provide first aid. At the same time, we have to inform the patient, police, and we have to shift the patient to the center where the facilities are available. And mind that Supreme Court has made mandatory, obligatory on us to send one qualified, experienced escort with that serious patient up to the other facility. We should not delay our patients on account of non-availability of money or the ambulance. So always try to provide first aid, convince the relative that we do not have the facilities, shift the patient with the trained medical escort. But the problem occurs when it is unexpected and unnatural. When I was a student, my professor was to go to Jodhpur, and nursing superintendent's son had appendicitis. शाम को ट्रेन थी तो 1 बजे बोला सर आप ही कर जाओ कि नहीं, मेरे रीडर कर देंगे कि नहीं सर आप ही कर जाओ. अच्छा चलो मैं कर देता हूँ. तो उनको शिफ्ट कराया. Since the son was of nursing superintendent, so anesthetist was the chief of anesthesia, surgeon was the professor of surgery, and assistant was the leader of the unit. Appendix was out, peritoneum was closed. तो वो उसी के पिताजी बोले सर आप चले जाओ, मेवाड़ा जी बंद कर देंगे. The reader will close. The moment he went down the stairs, the patient arrested. Those were the days things were taken because everybody was in confidence. Had it been today's scenario, things would have been very different. So in these cases, it is very difficult to manage. And nowadays, in the delivery cases, cesarean cases, PPH cases, patient admitted for small ureteroscopy and patient dies in the OT. How to explain and how to manage? This is the issue. And most of the complications are known to us. But there are times when these incidences come from heaven. अब तो ये हो गया, अब क्या करना है? And we cannot guarantee that even a simplest operated patient will come out safely out of the theatre and alive. If somebody says कि मेरी life में कोई complication नहीं हुए, that means that surgeon either is lying or has not operated. So what is DOT? DOT is death of the patient during the surgical procedure or immediately after the successful surgery. And this death is something like death in police custody, where in police custody only police knows what had happened, and in theatre death we only know what has gone wrong. Despite of the fact that you follow the WHO guidelines or take any sort of consent, these incidences can occur. By following WHO guidelines, by examining the patient, what we may get prepared for the eventualities, but we cannot stop the eventuality to occur. And many times our patients ask, what is the standard risk? साहब कितनी रिस्क है ऑपरेशन में? तो मेरा तो एक बड़ा सिमिली है कि आपकी कार बिल्कुल ठीक है, ब्रेक भी ठीक है, गियर भी ठीक है, टायर में हवा भी है, फिर भी एक्सीडेंट हो सकता है. That is the standard risk. But if your car is malfunctioning and still you are driving and you meet with an accident, that is the high risk. That means patient with comorbidities always is a high risk patient. And in lifetime of a surgeon, these accidents might occur once in their life. No surgeon wants to perform CPR of his patient in operation theatre and shift the patient from operation theatre to mortuary. No surgeon would love this scene. But it happens. And when it happens, first victim is the patient's family, the healthcare provider, and the subsequent patients. What happens to the healthcare provider? ये क्या हो गया? He is always in a shock. Immediately start thinking, blaming self, blaming the system, and ultimately goes into depression. मैं हॉस्पिटल का ये सीन होता है. We always see often in newspapers, hospitals vandalized and doctors beaten. So how to manage these situations? So before declaring the death, we must go all out to try to save the patient. Whatever specialists, government, private, anyway, we should invite all the specialists, try to save the life of the patient. And at the same time, we must make the chronological noting of all the help or all the services or all the treatment we are providing to patient to complete the document. Because the patient's relatives might ask the documents immediately. And all the notes should tally among the consultants. There should not be any contradictions. And mind, most of the times the allegations are बेहोशी की इंजेक्शन ज़्यादा लगा दिया, खून ज़्यादा निकल गया. ये दो एलिगेशन थिएटर में बड़े कॉमन होते हैं. So, after such incidents, you should not disturb the theater environment at all. सफाई नहीं होनी चाहिए theater में. Surgeon, what's the surgeon's worry? When to shift the patient? How to declare? Relatives को क्या कहूँगा मैं? पुलिस से क्या होगा? मीडिया, मेडिको-लीगल, compensation, damage to reputation, और आगे सर्जरी करूँ या नहीं करूँ? These are all the stresses which come to patient. Very difficult. Dr. Kamal Parwal has just told. Very difficult to communicate the unexpected death. So how to communicate such incidences to relatives? News should be the news should be communicated to the nearest relative, and it should be communicated jointly by the team. Team means the operating surgeon, the anesthetist, and the members of the help team, whosoever are there. So that the message goes that they have tried their level best to save the patient, but somehow they could not. During the communication, most of things should be told, but good communication does not mean that we should tell everything whatever had happened in the OT. So team communication effort should be there. The relative should be called in the office, informed to the, and this is what I learned during one of the deaths in our unit when I was a postgraduate student. And after such happening, always ask for the postmortem. Most of the time, relatives will say, we don't want postmortem. So neither we are in the position of refusing it, nor the relatives. Our duty is to inform the police in writing that such and such incidents has happened in our hospital, and we want postmortem. And postmortem has to be done under the supervision of police. So our duty is over once we inform the police. Another issue is billing or cost. In one of the speaker in the morning session said, what about the money? Money nahi lenge tum. So always make a bill. Hand over the bill. But don't force the patient to ask for the bill. Because once we waive off the bill, the sense goes that we are guilty. So make a bill, hand over the bill with the discharge death summary. Don't force him to pay the bill. Keep it in your records. And who will issue the death certificate? Doctor can issue the death certificate only if doctor knows the cause of death. In such situations, we do not know the cause of death. The cause of death will only be known by the postmortem. So, but if we don't issue the death certificate, the problem is, relatives say, एक तो पेशेंट मार दिया, ऊपर से परेशान कर रहे हैं. But if you issue, law says you want to put the whole incidents under the carpet. So we are at the balancing way. So what is the best balancing way is, when relatives ask for the death certificate, just write a death summary. That patient was admitted with this complaint, was being operated, and patient passed away, and the cause of death will be known after the postmortem, and give them. That is the best way to inform the relatives and give a certificate about the death. Media reaches to such places even before we ask for this help. So managing police, media, advocates, courts is another difficult task. We should always inform all unnatural, unexpected deaths on table, even the death due to accident and violence. In Western world, it is sad that within 24 hours of the surgery, if any death occurs, it has to be informed to the police. All abortion-related deaths or all medical procedure-related deaths have to be informed to the police. And the information should be in a very simple way. Mr. X was admitted with disease, this procedure was being done, and during this procedure, patient died. This is for your information and necessary action. Now the onus lies on the police and the administration how to proceed. And this will save you, I'll come further, from your own safety also. Sorry. Yeah. So one of the major concerns in DOT is being accused of malpractice. This is obvious presumption. So in such cases, since patients do not have access to OT, onus lies to the doctor to prove that we did as per the standard procedures and patient died because of the accident. So that is why the entire theatre setup has to be preserved to be handed over to the police. Police has to be informed in writing. If on phone, the belt number has to be noted, and we should always ask the entry number in the रोजनामचा. जब हम पुलिस को फोन करते हैं तो पुलिस आपकी फोन को एक रोजनामचे में एंटर करती है. तो पुलिस को कहिए कि वो रोजनामचे का नंबर बताइए आप. जैसे आप नंबर पूछेंगे, अगर कोई समझदार होगा तो कहेगा साहब आप नंबर का क्या करोगे, कि साहब हमें चाहिए हमारी टिकट पे एंटर करने के लिए. So that number is very important, because by that it becomes evident that we have informed to the police. And then police comes and prepares a panchanama. The original case papers have to be handed over only to the investigating officer. Any Tom, Dick, Harry, you should not hand over the original case paper. There will be a request from the investigating officer in writing that we want a case paper, and then that case all the documents should be numbered 1, 2, 3, 4, 5, and the receipt, and before handing them over, take the photostat copy, at least 3-4 photostat copies of the case paper, because the case will run for 4 to 6 years or 10 years in court, and you will forget everything. For your ready reference, you should have the case paper with you. And while handing over the case paper, you should take the receipt in the way that Mr. X case paper comprising of 40 pages have been handed over to Mr. So-and-so. The number of pages is very important, because at the end of the day, if something goes wrong or paper nikal liya or paper koi le gaya, so this is not your responsibility. What is panchanama? वैसे तो पुलिस में पंचनामा होता है जहाँ क्राइम सीन होता है. हम लोग क्रिमिनल नहीं है, लेकिन पंचनामा मीन्स let the police examine your theatre, collect the syringes, ampules. Even many times the police collects the suction material. जो suction में आपका material आया है वो भी collect करती है, mobs collect करती है. So let the police collect all the evidences from your theatre. This collection of evidences will always save you in the court of law, because the allegations are extra injection लगा दिया, ज़्यादा bleeding हो गई, and these evidences will save you in court of law. Media trial. Media reaches to hospital before your friend will reach to help you out. And media management becomes one of the very difficult tasks, especially in the single man or a couple setups. Because जिनके यहाँ हो गया वो तो already stress में है, अब क्या होगा? In such cases, the role of उपचार, IMA, FANA comes into play. Your spokesman should be one of your friends from your organization, and he should be made responsible for all communications to administration and to media. We should never be frightened about loss of reputation. You know, memory is very short. लोग नोटबंदी भूल गए, लोग अकाल को भूल जाते हैं, भुज को भूल जाते हैं. So your pupil's memory is very short. Don't get frightened because you have done 1,000 good cases in your community. Single case will never harm your reputation. This is a question of only, help yourself not being beaten up, inform to police and your superintendent. There is a experiment in Allahabad, QRT, Allahabad Private Nursing Home Association has hired a group of bouncers. Those bouncers take round of hospital daily like doctors, and in case of emergency, all the bouncers reach to the hospital. Do a sincere introspection, what had gone wrong, no blame game, so that we can improve our system. Inform to the insurance company even before the notice comes, so that if possible, if insurance company can get out of court settlement, it's his job. And the avenues for the patient's relatives are many: NMC, civil courts, consumer courts, criminal courts. The whole day we were discussing about what avenues they have and how can we protect ourselves. Good records. And the take-home message is strictly follow the WHO guidelines. We should do all-out efforts to save our patients, inform police and cooperate with the investigation. Media management should be done by your friend or by your organization. Take safeguard against violence. Always you should have a exit gate, escape gate in your hospital. Optimum indemnity cover, no blame game, and honest review of system. अलाहाबाद में एक हॉस्पिटल वाले ने अपने सामने कांच लगा रखे थे पूरे. मैंने पूछा भाई कांच क्यों लगा रखे हैं? कि जब पत्थर फेंकते हैं तब कांच ही टूटते हैं तो बदल जाते हैं, और कुछ होगी तो बाकी चीजें टूटे, और उनका गुस्सा सारा कांच में निकल जाता है. Thank you very much. So this is basically we have to learn by experience.
Thank you, Dr. Sharma, for a very
Sir,
good.
there is one question.
Yeah, please.
You have given one scenario. I am giving you another scenario.
Yeah.
If patient's relative wants to take silently the body to the village and cremate it, they are not complaining. Still, we have to inform the police.
Yes, sir. Because tomorrow another member of the family can come and say the doctor has joined the other persons and murdered the family, the member. It is our legal duty to inform such incidences to police and get the postmortem done. Let the police allow them to take the body. You should never allow them to take body home.
The relatives are reluctant for the postmortem.
No, sir. This is nothing to do with us. We have to just inform to the police, let the police take its own course. We have informed to the police, let the police decide. We are nobody to decide whether postmortem should be done or not.
Even the patient's relatives
Yes,
are
sir.
not filing any FIR.
Yes,
nothing.
sir. Yes, sir. Sir, please.
So I'm Dr. Gaurav. I am a forensic medicine specialist. So the law here says this is an MLC case.
Yes.
In an MLC case, you have to inform the police. इसमें relatives की नहीं चलेगी. Even if the 50 of them give in writing that we don't want a postmortem, the law demands a postmortem. So इसमें ना डॉक्टर की चलती है, ना पेशेंट्स की रिलेटिव्स की चलती है. The law says this is a MLC. MLC has to be registered,
Yes.
and a postmortem examination has to be conducted by the police. And it is always better that you inform the police and get the postmortem be conducted, because in almost, I would say confidently, 99% situations, you will be exonerated after the result of the postmortem examination is determined in the form of cause of death. The doctor is always at his advantage when he moves first and calls the police than otherwise.
Yes. Thank you, sir.
Dr. Sharma, thanks for giving such information. There is a small comment which is addition. After a OT death, the first and the foremost, you should not rush to declare the death of the patient.
Pardon?
You should not rush
You
to
should
the
not rush.
attendants.
Yeah.
First complete your notes with help of
That's why I told
anesthetist.
it.
Yeah.
That while preparing everything, you have to complete your notes in chronological order, no contradictions, because immediately your notes may be asked.
Secondly, have a meeting of your staff, particularly class 3 and class 4, because the attendants have a tendency to bribe them and to ask what exactly has happened.
That is why in our industry, you should always have your 3rd and 4th class employees in good order. Pay them good, help them in the need of hour, behave like they are our family members. Then only your employee will be at your side. If a erroneous or a जो खराब एम्प्लॉई है वो आपके लिए आपका दुश्मन है, उसको तुरंत पॉलिटिकली हॉस्पिटल से ईज आउट कर दो.
And lastly, invariably we only see the ampules which are used, but police may seize other ampules also which
So what
were
you
not
see-
used. Just a minute, small, let me complete. So many times it happens, those ampules which we are not using are expired. So there is a small suggestion that you should have your drug audit in the theater, which is very important. Because even if you are not used, and if they seize that particular injection which is expired, it becomes difficult in the court of law.
Sir, in NABH, when you go for even preemptive NABH accreditation, you have to make a SOP of discarding all the expired injections. So we should all make the practice of discarding the expired, and that can only be done by making SOP, emergency medicines, expiry date, and one person has to be in charge of that. And all ampules should be discarded even a week before the expiry, so that these incidences do not occur.
Congratulations, sir, for doing
if allowed.
nice presentation.
I'm sorry, if allowed.
Yes, sir.
How many times, Dr. Ashok, or may I know it from Dr. Kaurav, you have seen OT death declared the way you are suggesting, asking police to get into the OT and examine the buckets and also don't clean it. How many times? Okay, it is written that death in OT is a medico-legal case and it has all the medico-legal norms to be followed. How many times it is practically possible and practically useful, feasible and practically correct? आप अपना crime scene बता रहे हो उसको?
Sir, no, sir. Our duty is to inform to the police and yes, please.
So let me answer. It is rare. Okay, that is one. Secondly, it is not that I am inviting the police into my house, my operation theatre to get it checked and verified and seized. It is their obligation by law. We cannot stop it. If they don't want to visit the OT and seize equipment, it is up to them. If they want, I can't stop it. My duty is in OT death case to inform the police.
Yes.
Now the ball is in police's court. They will seize the body and they will get a panchnama and order for a postmortem examination. We are not requesting. They are ordering for a postmortem examination. And if they want to come to the scene of crime, so-called operation theatre, it is their obligation by law. We are helpless bystanders.
Yes. So we don't invite them. We just inform the such and such incidents has happened. Now it's up to you to whatever you want to do.
One point I would have, sometimes the situation is like that. We have taken a DOT consent and the patient is critical. Either he will die otherwise, and the patient attendants are saying you go ahead, even if there are 1% chance. if he dies, we are ready to it, ready for accepting it, and we have a devotee. Now the patient says, if we say that we want a post-mortem, then sometimes there are more problems.
Yes.
So why media is that in an affidavit, we ask them to give an affidavit that we were explained about all these things, patient had a devotee and we don't want to do a post-mortem. Then can this is allowed?
No.
Otherwise,
No, sir. No, sir. No.
Otherwise, just please listen to me complete. Otherwise, there are situations that arises, the patient's attendants who are cool at that point of time, ready to take the body, they start vandalizing the hospital.
No, sir. See, sir, number one.
I
Your
will
sir,
answer
first
this.
question is.
Ashok, let me answer this because let me answer this. And he's right. This problem happens. That you ask
Sir,
him to
sir, what law says? If I hand over a gun to you and write on affidavit, you shoot me. Will you shoot me?
Just listen to me and then jump the gun. You see, he's right. You know, this is practical difficulty. The patient party turns hostile. If you ask them to sign a paper that I refuse the postmortem, they say, we will not sign. Already you have washed up the surgery. Now let us peacefully take away the body. That's what we want. We don't want to have any fight with you. We want to go. And they want to leave immediately. Now what you are saying is correct, that it is our duty to inform the police. So legally it is very, very correct. And there is no objection with it that you tell them, okay, you take away the body, but inform the police. When the police comes, give them address. They have taken the body. We asked them to get the post-mortem examination done, but they didn't agree and they took away the body. They have the first right on the body.
No, sir, no,
No, sir, no, sir.
Once we have informed the police, they don't have a right on the body.
Yes.
We don't have a right on the body.
No.
It is up to the police.
Police.
Now the matter is
Please
out of
listen.
my hands.
Please listen. No, it is not the case. Your duty is to inform the police.
Yes.
For the post-mortem.
Yes.
Requisition of post-mortem, you have to communicate that and you have to inform about the incidents that has happened in your hospital. But you cannot restrain them from taking away the body, remember it.
So if they are distracting,
You cannot
case
restrain them.
yes.
You cannot use any coercive method. That
No.
would be illegal. What is the problem? They are breaking the law.
Yeah, if they are breaking the law, then the
What is
police
breaking
will
the law?
take action against them for destructing evidence, case property, dead body.
You could not help it. They want to take away
Fair
the
enough,
body.
fair
You are
enough.
not expected to, man fight with
Hey,
them.
sir.
That is not expected of you.
Sir,
Affidavit is illegal. Affidavit is illegal in such a
Sir,
situation. It has no value.
if they take away the body, case is against them, not
Yes.
against us.
Yes,
Exactly.
yes.
Case
that
is against them.
Against them.
Number
You are
one.
right.
Number
Take
two,
against them. This is
number
what
two,
you should do.
our duty finishes once we inform to the police
Exactly,
and
yes.
note down the batch number. That's
Absolutely,
all.
absolutely.
Now I have seen police going to the funeral ground and taking up the body for postmortem.
So the point is that if you expect that violence can start, then it would be better if they take away and you keep on.
You inform the police
and
again
on the
that
right
they
side
have
of
taken
the
the
law.
dead body.
Yes.
Ah.
You have to
If
inform
it is
the
Now
better,
a
take
new
away.
duty arises
Yes.
that they have taken the dead body, that
Yes.
is, they are going to destroy case property.
Yes, they
Yes.
are on the
So
wrong
you
side of
inform
the law.
again.
Yes.
That is your
So
new
let it
duty that
happen.
is arisen.
Sir, mind it if the patient take away the death body in a medico-legal or potential medico-legal case, not only in death in OT but any time in your emergency. You have to ensure that you made reasonable efforts to protect this from happening.
Sir, listen,
मेरे
sir.
साथ एक केस हुआ था कि आपने गेट बंद किया क्या?
नहीं
वो
सर,
गाड़ी लेके कहाँ भागे?
हमें पुलिस को इन्फॉर्म करना है कि ये मेडिकल लीगल केस है और ये भाग सकता है. नाउ इट इज अप टू द पुलिस टू कम एंड डू द नीडफुल. हम कोई थानेदार नहीं है, हम कोई बाउंसर नहीं है, हम कुछ भी नहीं कर सकते. हमें हमारी ड्यूटी केवल पुलिस को इन्फॉर्म करने की है और उनकी आइडेंटिटी को उसके केस पेपर पे लिखने की है, बस. इसके बाद पुलिस को काम करना है सारा.
सर ऐसे एक केस हमारे यहाँ हुआ था. डेथ पेशेंट सीकर में ऑपरेट हुआ था, जयपुर आके कॉम्प्लिकेशन मैनेज नहीं हुआ, एक्सपायर हुआ, फाइनली डेड बॉडी ले जाके हॉस्पिटल में रख दी. तो अब उस टाइम मैं तो शायद मैं क्लिनिकल प्रैक्टिस में आया था, तो वो न तो डेड बॉडी उठाने दे रहे थे, न पुलिस वाले उठा रहे थे, और हमें ऐसे लग रहा था कि वायलेंस हो
नहीं वो दिस इज नॉट आवर बिजनेस. वो जो पेशेंट जो
सर, लेकिन डेड बॉडी तो हॉस्पिटल के पोर्ट्स में पड़ी थी ना,
तो पुलिस करेगा वो. तो
पुलिस भी उसको उठा नहीं रही, घर वाले भी उठा नहीं ले रहे, और हम
नहीं,
50-60 डॉक्टर्स इकट्ठे हुए तो शायद इसीलिए वो न्यूसेंस नहीं हुआ जो भी होना था.
Actually, in
ऐसी
this,
स्टेट में क्या करना है आपको?
in this situation, you have to inform to higher authorities. थाने के आगे चले जाओ कि साहब ऐसा हो रहा है. और अब तो शायद उपचार ने करवा दिया कि इस तरह का सीन नहीं होगा. Now उपचार has worked very hard for getting this thing done. कि police will make sure that bodies are removed from hospital in a peaceful manner. Thank you उपचार for that. Sir. Pardon, sir? Yes. Sir, Mike.
You see, otherwise, according to law, you can file a counter FIR against those who are doing a Matana kind of
Yes.
affair. So, for extortion, blackmail, and intimidation, you can file an FIR for that, and that is what you should be doing. If the other party is, attempting all this, that keeping the dead body there for demonstration purpose in front of your hospital, this is what you should do, according to law.
Sir, usually if you go with the writing of letter that accept this letter that something has happened in hospital,
Yeah.
police usually will not accept it.
Police will have to accept it. Make 2 copies given and get it signed.
So
Police will have to accept it.
Sir, usually they refuse. So is
They
there
can't
any other
refuse,
way
sir.
also?
They can't refuse, sir.
Is there any other way also that by
Inform them on WhatsApp. They have all nowadays all police stations have WhatsApp numbers. You can even email. You can inform on email.
Yeah, I was going to
Yes.
say, you just
You-
answered my question. We have used this in Delhi very effectively in many cases as
Yes.
part of our legal team. We inform the police commissioner. The police commissioner email is there on the
Yes.
website. Action happens
Yes.
within
No time.
hours,
Yes.
not days, within hours.
Yes.
We've used it very effectively in many cases.
Yes, sir. And for your information, for उपचार members, वो राजस्थान मेडिकल पर्सनल प्रोटेक्शन एक्ट जो है 2008, we were the first person in Rajasthan to file a case against a errant relative, and we contested that case for 12 years, and now we got the money of our damages, and that person was put behind the bars for 6 months before he got the bail. Thank you very much.
Thank you.
Thank you, sir.
Thank you, Ashok Sharma sir, for enlightening us with your knowledge and experience. Now I request all the chairpersons to please come and felicitate Ashok Sharma sir. Now I request Dr. Keval Krishna Bose and Dr. Sandeep Bakar Bose to please come and felicitate our chairpersons. I request Dr. Hemlata Patidar ma'am and Priya Goyal ma'am to please come and felicitate our chairperson.
And now I request Dr. Ramdev Chaudhary to say a few words and give vote of thanks. ये पहले फिनिश कर दो, फिर फोटोग्राफी करनी है रामदेव चौधरी।
गुड इवनिंग। कौन कहता है आसमां में छेद नहीं हो सकता, एक पत्थर तो तबीयत से उछालो यारो। ये करके दिखाया हमारी 4 साल की उपचार ने, जो काम बड़ी बड़ी संस्थाएं नहीं कर पाती हैं राजस्थान में, और ये प्रयास ये सब हुआ है। मैं उन सभी को आज शाम को अपने दिल की गहराइयों से धन्यवाद देना चाहता हूं। सबसे पहले बहुत बहुत सारा दिल से धन्यवाद उन फैकल्टीज को जो केरला से लेके पंजाब तक, कर्नाटका, गुजरात, एमपी, महाराष्ट्र, दिल्ली, सभी जगह से पधारे, उनका बहुत बहुत धन्यवाद। उनके साथ साथ डेलीगेट्स जो आए, उनका बहुत धन्यवाद। स्पॉन्सर्स जिन्होंने इस सारे प्रोग्राम को हमें अच्छी तरह से करने में हमारी हेल्प करी है, उन सब का बहुत बहुत धन्यवाद। स्पेशली डॉक्टर नवनीत जी का, जो आज शाम का खाना उनकी पूरी टीम ने इस इवेंट को मैनेज किया है, उनका बहुत बहुत धन्यवाद। साथ ही साथ लक्ष्मीकांत जी जिन्होंने प्रिंटिंग का काम किया है, उनका बहुत बहुत धन्यवाद। ये पूरा इवेंट MLAG की सहभागिता के बिना नहीं हो सकता था, तो उनका बहुत सारा धन्यवाद। और ये एक ऐसा एक्सपीरियंस था जो हम चाहते हैं बार बार मिले हमें, और इसी तरह से हमारी ये जो माला है, जो धागे के रूप में डॉक्टर राजशेखर जी ने सभी मोतियों को मिला के बनाई है, मैं उस ऑर्गेनाइजिंग कमेटी के लिए आप सबसे चाहता हूं कि बहुत सारी तालियां बजाएं। मैं एक एक का नाम लूंगा जो पिछले 15 दिनों से बिना थके, बिना हारे, बिना सोए जिन्होंने काम किया है, उनके लिए हम सबकी तरफ से बहुत
स्टैंडिंग ओवेशन फॉर ऑल।
बिल्कुल स्टैंडिंग ओवेशन बनता है उस ऑर्गेनाइजिंग कमेटी के लिए। आप सबसे थैंक यू सो मच। थैंक यू, थैंक यू। अभी गाला डिनर है, प्लीज सब डिनर करके जाएंगे, कोई जल्दी नहीं। हम सब ने सुन लिया कितने कॉम्प्लिकेशंस होते हैं, उन कॉम्प्लिकेशंस को यहीं छोड़ के मस्ती के साथ सब मिलें, डिनर करके फिर जाएं। थैंक यू सो मच। एक मेरी रिक्वेस्ट है, ऑर्गेनाइजिंग कमेटी के सारे सदस्य एक बार स्टेज पे आ जाएं प्लीज, ताकि एक फोटो हो जाए। ऑर्गेनाइजिंग कमेटी के सारे मेंबर्स एक बार स्टेज पे पधारें। आ जाइए प्लीज, आ जाइए।